Modi, Dr. Kaushal Gandhi chair this session. It is about number 17. And moderator will be Dr. Vishal Mehta, Dr. Vinay Bhumia, and Dr. Poonam Brahmbhatt. I think all of them are there. I would like to request Dr. Asha Shah to kindly introduce our two speakers, Dr. Shweta Nagar and Dr. Shwilpi Mohan. Over to Dr. Asha Ben. Dr. Asha Ben. And moderator will be Dr. Vishal Mehta, Dr. Vinay Bhumia, and Dr. Poonam Brahmbhatt. I think all of them are there. I would like to request Dr. Asha Shah to kindly introduce our two speakers, Dr. Shweta Nagar and Dr. Shwilpi Mohan.
Thank you very much.
Over to Dr. Asha Ben.
Thank you very much, Dr. Jayesh Bhai, and thank you, Dr. Sharma and Cadicon team for inviting me here.
Dr. Asha Ben.
I am busy. I am audible.
मैडम आपने दो डिवाइस से लॉगिन किया है, दूसरा आपका डेलीगेट वाला है, वहां से लीव कर दो.
I would like to request Dr.
Oh my God, I don't know.
Dr. Shweta Nagar and Dr. Shwilpi Mohan.
Thank you very much.
Over to Dr. Asha.
Thank you very much, Dr. Jayesh Bhai, and thank you, Dr. Sharma and Cadicon team for.
Please go ahead, Dr. Asha Ben. So I would like to request Dr. Vishal to kindly introduce Dr. Shweta Nagar, please.
Shall I? Dr. Dhaval, go ahead, introduce our second speaker.
Dr. Kaushal Gandhi.
Kushal,
Yeah,
Dhaval,
very good morning.
Second speaker next time.
Very good morning. So, myself, Dr. Kaushal Gandhi, and good evening for the talk number 41 and 42. So, here, Dr. Shweta Nagar is the founder of Vitazia Wellness, the diet clinic, and she is MSc in Foods and Nutrition with more than 12 years of experience. And her expertise in counseling the clients and motivating them to achieve their health goals. She awarded with the Best Dietitian to treat the PCOD in Ahmedabad 2019 and for another award till 2016. And her seminars are very interesting. Right. So I am inviting her for the talk, which was on the case was the 39 years old male who is presented with the inferior wall MI, and for he underwent the primary PCI to RCA, which was successful, and his lipids was triglyceride were 242, right? HDL was 33 and LDL was 111, and he was on rosuvastatin 20 milligram. So talk number 41 with her, Dr. Shweta Nagar, and it was, for example, the Indian dietary modification is the most important preposition, yes or no, right? So I would like to invite her, Dr. Shweta Nagar.
Thank you, Dr. Kaushal, for your kind introduction. Good morning, doctors. So today I'm here. So do I need to share my screen?
No, you have to, Dr. Kaushal, you have to again introduce Dr. Shilpi also, and then they will start their lectures.
Yes, sir. So, and the debate part 2 is talk number 42, yellow, which was yoga, and yoga and meditation are the best suited modalities for the cardiac rehabilitation. So for that, another speaker is Dr. Shilpi Mohan, who is MD Medicine and followed by DNB Cardiology. She is consultant cardiologist at Apollo Clinics, Secunderabad, and awarded by the Time Research Media, which is most prestigious, most prominent cardiologist of the 2019 in Secunderabad. She is consultant cardiologist in Orchid Hospital, Ranchi, consultant cardiologist Columbia Asia Hospital, Gurgaon, and Artemis in Gurgaon. Then alumni of Army Hospital, RNR, which is well-known, respected hospital in New Delhi. And her area of interest are preventive cardiology and holistic healing. and she was the guest columnist in leading English Daily of Central India in Hitawada, and certified yoga trainer in Patanjali Yogpit Haridwar. So second speaker is Dr. Shilpi Mohan. Okay. So okay. So her areas of interest of yoga versus these debate on diet and yoga. So what is the best option?
So shall I start the presentation?
Yes, please.
Yes, ma'am.
Go
Yes,
ahead.
go ahead.
Okay. So let me share my screen first.
Hello, Shweta, can you start?
Hello,
Yes, please start.
Shweta. Not audible, ma'am.
We are not able to hear.
Hello, Shweta, ma'am. Hello.
So when we do yoga, we shift our focus from illness to wellness, and there is a body, mind, spirit integration, balance of body, mind, and spirit. By doing integration of breathing and coordinating it with the movement, what happens is, and when there is a focus in the present moment, the body becomes still, mind becomes calm, the emotion is becoming stable, and then there is a holistic healing which takes place in the patient. The basic mechanism of yoga and meditation is it works on the vagal system and slows down the sympathetic system. So by better stimulation of vagal system, there is a better heart rate control, increase in insulin sensitivity, increase in glucose tolerance, reduction of HPA axis stimulation, which leads to a reduction in atherosclerosis and CVD. And by doing mindful exercise, as the stress is controlled, there is a reduced intake of drug usage, which is a very important factor in this patient, where he has to continue the treatment lifelong. Stress and obesity are correlated because stress leads to activation of HPA axis, increase in secretion of cortisol, comfort food and binge eating, and increase intake of alcohol or alcohol addiction. And all these three factors lead to obesity. Whereas when yoga and meditation is done, it stimulates vagus and reduces emotion and external eating and leads to abstinence of alcohol, which leads to better control of obesity. So if we look into all the core components of cardiac rehabilitation, be it weight management, blood pressure, lipid control, diabetes control, yoga and meditation has a role to play in all these factors. So if we differentiate between routine cardiac rehabilitation and yoga, what we are doing just a slight shift. Where stress management is done by medication, here we are doing the breath control and meditation. Physical exercise, which is a competitive exercise, here we are doing the smooth muscle movement along with conscious breathing. Lifestyle modification, we are doing counseling and changing the diet and all those things here. Because the patient becomes calm, there is self-restraint and utilization of better healthy diet in his life. So whatever I'm talking, do we have any scientific evidence to support what I'm saying? Yes, this is the first scientific review which has been published in International Journal of Cardiopulmonary Rehabilitation. It has shown that yoga has a multi-organ role to play, be it autonomic nervous system, metabolic, anti-inflammatory role, immune system activation, as well as neuroendocrine system. This was an article which was published in International Journal of Yoga by Dr. Indranil Basure, and he highlighted that yoga has been categorically found to inhibit baneful effect of stress. As we know that stress is related to broken heart syndrome or stress-related cardiomyopathy, and it has been shown that yoga and exercise are some of the methods which can be implemented to control the stress, which has been brought out by Dr. Erin Mikos. This was another study which was a systematic review and meta-analysis which was published, which showed that it is a promising alternative for patients of CHD and it improves the quality of life. This was a landmark trial which was published by Dr. Durairaj Prabhakaran, which is a yoga care trial, and he highlighted that yoga care improved self-rated health and returned to pre-infarct activities earlier than the conventional cardiac rehabilitation. This was the editorial journal. This was the editorial which was published in JACC, which showed that exercise in the form of yoga and mental exercise, such as meditation and mindfulness, have benefits in primary and secondary prevention of cardiovascular health. This was another article which was published in Circulation, which showed that yoga boosts quality of life and emerges as an rehabilitation alternative. And it was mentioned that if we give more choices to the patient, especially traditional choices to the patient, it is more likely he will sustain and do it in the longer run. Because over a time, boredom sets in and the patient leaves it. That is the main problem during cardiac rehabilitation. So if we give them conventional and traditional choices, it is more likely that he will be able to sustain it. This was again a state-of-art review article which showed that yoga reduces stress, anxiety, and improves autonomic function. This abstract I have taken from Indian Heart Journal, where it has been shown that addition of yoga-based relaxation therapy to conventional treatment helps in better management of risk factors. Again, this article has shown that addition of yoga to rehabilitation improve subjective findings of cardiac health and quality of life. So we have n number of publications in last 1 decade which have highlighted the importance of yoga and meditation as cardiac rehabilitation alternative. This was a study which was done in India which showed that it reduces blood pressure, cholesterol, and anginal episodes. Dr. S.C. Manchanda is a pioneer in this field, and this was an editorial published in Indian Heart Journal where he showed that it is a significant tool for cardiac rehabilitation and leads to improved fitness, stress reduction, and patient well-being. This was again published by Dr. Harinder K. Bali, where he mentioned that yoga is an inexpensive method of addressing the core issue of epidemic of cardiovascular disease. This was a publication in European Cardiology Journal of Preventive Cardiology, where it has been shown that yoga can improve quality of life. So if you look at different articles of different part of the world, yoga has shown significant benefit in most of the patients of cardiac rehabilitation. This was a scientific statement which was given by AHA, and it has shown that studies of meditation suggest a possible benefit on cardiovascular risk management, and more studies are required in the similar direction. So in the end, if we do a SWOT analysis of yoga and meditation in cardiovascular rehabilitation, the strengths are, it is an indigenous method. It is a way of life. We Indians are born with it, and we have utilized it in some or the other way in our life. It has got a multidimensional benefit, be it body, mind, and spirit balance. We get a holistic improvement by doing yoga. It is cost effective. We don't need any devices or any equipment for that. There is no age bar. Even old patients can do pranayam and do some exercises which they can perform without doing those jerky movements and strenuous physical activity. The weakness is, as I mentioned, it is difficult to sustain interest in the long run, and it may not give immediate results, which may make the patient less likely to continue in the long run. And wrong postures, wrong methodology, wrong timing may cause some harm. And scientific evidence are upcoming, and we are very hopeful about more studies in future. The opportunities include, it is gaining popularity world over. Now 21st June is celebrated as International Day of Yoga. There are more ongoing researches, results are long lasting, and awareness can be spread to even small places and villages where gym facilities are not available. And it is revival of our own ancient knowledge, which brings a sense of pride to all Indians. It is one knowledge which has shifted from east to west. Most of the knowledge we are taking from west to east. So we should be proudful of it. And the threats include our unwillingness and inability to motivate people. There are certain religious dogmas associated with it, which we have to remove. And still we are laying more stress and investing more on treatment rather than prevention of the disease. So my talk is the first talk of the day by design or default, and yoga comes first, then comes all the things. Thanks for your patient listening.
Thank you very much, Dr. Shilpi.
Pleasure.
And do we, Dr. Sharma, do we encourage the question and answer now or after the bouts are over?
Ma'am, we will discuss after the bouts are over.
Oh, okay. So I would invite the next speaker if she's ready.
Dr. Shweta must be ready now by this time.
Yes, yes. There was some audio issue. I'll try and share my screen now.
Yes, please.
Unmute yourself.
Hello, am I audible?
Yes,
Yes.
go ahead.
The moment I share the slide, my audio goes. I don't know what's the issue.
We are
You can
audible
try,
now.
Shweta, not making full screen and just display it and then also speak. That time we were able to hear you. When you made full screen, it disappeared.
Okay. So No, so now I don't see my presentation only. Just a second.
Another option is keep the video off.
Okay.
Morning, Dr. Kamal. Dr. Ajay here.
Neelam, if you can help her, Sweta.
Yes.
Yeah, unmute and speak, Shweta, if we can hear you. Let's see. No, we can't. So I think you stop sharing and then speak off without slides. That's fine. You can scroll the slides for yourself and at least we can hear you.
Okay, fine. Just a second.
Yeah, we can hear you. Go ahead, please, Shweta.
Okay, fine. So basically, sorry for the inconvenience, but then yes, today I'm going to talk about Indian dietary modification, which is an important preposition for an acute coronary syndrome. I agree with Dr. Mohan that she said that implementing meditation as the key, I mean, could be a little troublesome. The reason being that the people might not be consistent following that, and that's the reason why I feel that dietary modification can play a very important role when we talk about first a step to do when we have to improve this thing. But yes, with the dietary modification, what I feel is we should not ignore the other coronary protective factors like she already mentioned moderate physical activity, lifestyle modification, meditation and yoga, moderate alcohol consumption, and lean body weight, obviously if the person is overweight, and no tobacco is also one of the coronary protective factors that we should be considered. So I'm sorry, I'm not able to show the slide right now, but then I would have loved to show the result of one of my client who is a male 35-year-old. His BMI was absolutely normal. The only problem with him is like it was a stress induced dyslipidemia, I feel, because he was an overthinker and so much in stress that he was on antidepressant at times. So because of his, and on top of that, the erratic schedule, his lifestyle was also the problem, which was dominating and creating the dyslipidemia. So when he came to me, his cholesterol levels were about 200 and his triglycerides were about 275. And then when we talked about how to start the progress, we discussed about all the CPFs that are important. So while discussing, the first thing that came up was it's the dietary modification that he can actually start with his busy lifestyle. He could not include exercise or yoga or meditation at the very first place. And that was the reason I put him on a dietary modification, which includes a low saturated diet, high fiber with mono and polyunsaturated fatty acids, with absolutely a phytosterols also in the plan. And he could adhere, because of his busy lifestyle, he could just adhere to 50% of what I suggested. And just with 50%, yes, there was a nominal difference in the total cholesterol, but his triglyceride levels drastically dipped. So with this, I could always, convince myself that yes, diet can be the first step to implement when it's difficult for our people around us who have a busy lifestyle, when they cannot exercise or when they cannot have time for meditation. So, but yes, another thing that the cholesterol levels total cholesterol level did not improve much, also proves that exercise is also very much important. Now, talking about few research papers, I had come across one research article that was published in the Journal of Cardiology and Therapy. They tried to analyze the association of CPF with the patient following ACS. So they also said that in this research paper that the research papers and the team scientists analyzed, and they said that adherence to healthy diet and moderate physical activity were highly significant CPF and ACS of ACS. And I also have a chart. Unfortunately, I cannot show you that chart, which has an analytical data for men and women, where actually physical activity, moderate physical activity takes the lead. And the second leading one in the list was the dietary modification. Yoga and meditation also has a basic, small association. So the graph basically says that the moderate physical activity was in lead, and the lean body weight, meditation and yoga were also significantly less CPF but had a weak association. Never tobacco and moderate alcohol intake were also significant CPF, but with only weak association among females and females with ACS. Moderate alcohol intake was not protective factor, although, but then yes, it does have among the females, but it does has an impact in the male. So this research definitely shows that dietary modification is first. Why? Because the lifestyle change, the exercising in this busy lifestyle becomes little difficult for people to adopt and to take the first step as. And that's why dietary modification is important. There is a very fine saying, I even have mentioned it on my clinic, that every time you eat or drink, either you're feeding the disease or you're fighting it. So there are n number of researches that have proved that introducing some functional food into the diet can itself improve their dyslipidemia. So to have some, researches with us, one more research that proves, it was published in the WebMed journal, and that was about, it said that the dietary modification of the functional food and implementation of dietary supplements for dyslipidemia management. Many were tested, like many food products were tested, but the functional food which were actually holding a positive impact was soya protein, plant sterols, probiotic yogurt, and marine derived omega-3 fatty acids. So talking about soya and the derivatives, the isoflavone content in the soya actually reduced the cholesterol level by 3.1% of consumption in just 1 month of time, and the significant effect was like little less on the LDL and HDL, but yes, it did improve the total cholesterol levels. And the other one, what I was talking was plant sterols and stenols, that exerts basically their hypocholesteremic effect, possibly by interfering with the uptake of both dietary and biliary cholesterols. So from the intestinal tract. So there is one more research I would have loved to show that. That's again in the PubMed journal that has been published. And the present evidence is accumulating to promote their use for lowering LDL cholesterols as a first line of treatment. Now, talking about the other functional food, that is probiotic yogurt, which showed an improved dyslipidemia in terms of the patient who are dealing with type 2 diabetes along with dyslipidemia. And talking about omega-3 fatty acids, even a mild consumption of 25 to 50 grams in a week had improved the cholesterol levels in the patient with high cholesterol and LDL triglyceride levels. So last but not the least, there was one more research which I had again found, and it was published in the cardiology journal, that dietary modification is the first step for implementing. I mean, this study concludes that specific dietary strategy are the mainstay of dyslipidemia management. The exact approach differs according to the type of dyslipidemia. So basically, after so many years of experience, I have a set kind of a combination that I work for with my patients. So the approach changes based on the kind of dyslipidemia we see in the reports. So if the patients have high levels of triglycerides and low HDL level, the reduction in high glycemic index food and substituting it MUFA and PUFA is the strategy. And the patients who have high cholesterol levels and LDL levels, reduction in the saturated and trans fatty acids with the substitution of functional food like phytosterols have more efficacy. Definitely, weight management is going to impact, like it have an overall effect on the improvement in the dyslipidemia, and it also has an impact in improving the HDL levels and high triglyceride levels. So exercise is also must. That is what the research again says. And potential benefit may derive also from single dietary management of the diet, such as legumes. You add more of legumes, fruits, vegetables, nuts, and omega-3 fatty acids, as I'm repeatedly saying on it. So with the backing of all these reports and researches and all that, what I feel is the takeaway from my talk could be, yes, exercise is very much important, but because in this lifestyle, in the kind of busy schedule we are into, exercise, getting into that exercise regime, and as Dr. Mohan said, being consistently exercising or meditating and yoga is little difficult. At least implementing the right food and eating right in a right manner also is a key for the success. So with balanced diet and exercise, I also preach my client about the circadian rhythm and the cognitive behavior therapy. I also focus on more of cognitive behavioral changes. Like I try to preach them about what is the positivity of this program and all that. We all know that lipid pathway are under circadian control in all the major metabolic tissues, and loss of that clock, like most of the time people sleep late at night, get up late in the morning, or even if they get up, they are in rush, they are not in the calm. As Dr. Mohan said, that breathing in and breathing out right way definitely plays a very important role. So if your clock are not at place, the results, this can result to an abnormal fat storage and lipid transport. So that's the reason, along with diet and exercise, biological clock and CBT. CBT can help our patients reduce their systolic and diastolic blood pressure. It also helps them manage their stress. It also helps them take care of their depression. And yes, when the dyslipidemia is due to stress, like my patient who was on a normal BMI, but more stressed. His lipid profile was more stress induced and not obesity induced. So in that case, I personally also recommend more of stress management through yoga and meditation. But the strategy changes based on the patient. There is no one set strategy for all. That is what I
last
see.
30 seconds, please.
Yeah, so I'm done with it. So that was my last slide anyways. So again, to sum up with, all the CPFs has to be considered while we treat the patient.
So the house is open for discussion if there are any questions.
Asha ma'am, we have fantastic faculty for this session. Thank you both of the speakers. Asha ma'am, Dr. Dhaval Doshi practices a lot of what we actually are discussing here. Dr. Dhaval Doshi.
Yes, sir.
Also is Dr. Kushal Gandhi, who's been student and prodigy of Dr. S.C. Manchanda, one of the father figures of yoga and cardiology. Dr. Vishal Mehta, Dr. Bhaumia, and Dr. Poonam Brahmbhatt, please, your comments, please.
Yeah, I
Chairperson.
would like to go first, Dr. Sharma. I mean, both of the speakers have done justice to that topic, and it's not contradictory. I think it is all complementary to each other. So that is a great point. And we all also agree to whatever they said. Both of the methods work for the patients who are already on medications and also other lifestyle modification. Oh yeah, so basically it is all very clear, and I don't think there is any confusion in this. And I congratulate both of the speaker and Dr. Sharma. Thank you very much for the opportunity to be here. And I do say that there are some technical hitches which did happen, but that's okay. So yeah, my comment is that. And Dr. Dhaval, you are there. You are the best person also to talk about this, because you are practicing many of the things that both the ladies said.
Yes, yes. Thank you, ma'am. Yes, yeah, I also agree that lifestyle modification is responsible for decrease 50% mortality of the cardiac patients. So lifestyle modification, including both yoga, meditation, exercise, and diet. So it is a balanced, comprised diet and exercise, yoga, meditations. When we all include together, then and then this coronary artery disease prevent can be done very easily. And the burden of the disease also decreased by lifestyle modifications. So I've also recommended that we should follow baseline evidence-based medical treatment, then also this yoga, meditation, exercise, and balanced diet.
So, can I ask something? No.
You are muted, Dr. Trivedi. Unmute yourself.
Can I ask one question?
Yes, please.
What is your prescription for lifestyle modification like yoga, exercise, and meditation? What is your prescription like? How much time they should do it for each?
Yeah, as far as yoga meditation is concerned, the prescription includes that we should at least start doing it. That's the number one point. Even if we do for 5 to 10 minutes, but at least we should start doing it. Because sooner we start doing it, the timing is going to increase in future, because the patient will become more confident of the results he's achieving. That's number one. And as it holds good for physical activity, same holds good for yoga and meditation. Minimum of 30 minutes to 45 minutes is something which is good enough if done in a day.
Completely agree with Dr. Mohan. It's like, something is better than nothing.
And which time is better, night time or morning time?
Morning time. Morning time is the best. Early morning, empty stomach, because there are many yogasanas which, if done with a full stomach, then it may lead to reflux, because there are many bending poses and all those things. And even Kapalbhati, if you're doing, then you cannot do it with full stomach. So the best is when you get up in the morning, free of all your basic schedules, and after that you do first yoga and pranayam, and then continue with what Dr. Shweta has said with the diet and other changes in the day-to-day life.
But meditation can be done anytime.
Meditation can be done anytime, even at night, because throughout the day you are stressed out. So if we do meditation at night and clear, it is like a recycle bin. So whatever junk is accumulated, if you clear before you sleep, then you wake up fresh and then you are ready for the next day. So yes, you're right, meditation at any point of the time, but yoga preferably in the morning time, preferably.
Thank you.
But can you do like alternate day or something, because both the things are doing daily, maybe time consuming. So is it possible to do that?
Yes, definitely. As I said, you have to set patient on the right track, that these are the changes which are going to do good in the long run. It is like depositing money in the bank. So if you do today, 2 days you don't do, but you do again, but at least you are doing, rather than just wasting your money over buying things. So it is the same way. You have to start doing it. Suppose today you're doing yoga, preferably followed by meditation, because it is a sequence that your body is prepared and then you're calm down and then you're doing meditation. But there are days when you're busy and you're not able to do it. You can plan your regime that you're doing asanas today, tomorrow some short asanas followed by meditation, where you are focusing more on meditation, less on asanas. Yes, definitely it can be done as an alternate day or as a periodic schedule which you can plan. No issues with that.
I think Rahul and Rohit, the way in which they are complementing each other. Similarly, Shweta and Shilpi has done wonderfully well. And if there are no further questions, we'll go for the second bout.
Ma'am, one question regarding the refined oils regarding Dr. Shweta Nagar.
Basically, we can always, so as in the last CardioCon, if you remember, we talked about the role of olive oil and cardio health, right? So yes, olive oil is good, but talking about the Indian cooking methods, the best healthy hard practice, if I would say, the oil that has good smoking points are all vegetable oil, like soya bean oil and corn kernel, rice bran and all that. But you should always practice shuffling the oils, because each oil lacks in a certain in one essential fatty acid which is not present in the other. So if you're looking for a heart healthy practice, it is always good to shuffle the oils. All we avoided are majorly palm oil that I would not refer to any.
Ma'am, I'm the student of Dr. S.C. Manchanda sir, and he used to tell that whichever the oils available in the market, all are refined oils. So soybean, which are the oil are available are refined oils. Don't use any refined thing, right? Just use filter or double filter oil.
So filtered and double alternatives also are matlab, better than the refined one, but
Right.
yes, using the refined one is not.
And he used to say that anything in ghee is good because the ghee is normal at higher temperature also. It's not
Yeah, so you're
regenerating.
it's
Right.
not about, see, there is no food called bad or good food.
Right.
So it's more about having it in limitation. So अगर आप घी ले रहे हैं, if you're having ghee, make sure that total carbohydrate intake जो आपका है वो 30% of the calorie should come from good fat, right? So good fat includes ghee, good kind of an oil. It has to exclude saturated fats. So it's absolutely
He
okay.
used to say that वघार करવો હોય तो ઘીમાં વઘાર કરવો જોઈએ refined oil કરતા.
Yes, that's better.
I think we have crossed the time, please. Now
Yes.
go for further questions and we'll go to the second bout, please. Otherwise, we'll be late all throughout the day.
Yeah, second talk. Okay.
Thank you so much. Thank you, Dr.
Thank you
Kamal.
so much.
Thank you all
Thank
the
you all.
moderators and the
Thank you.
speaker as well. Thank you.
Now for the second bout, bout number 18, I would like to invite Dr. G.R. Badlani, Dr. Manish Agrawal, Dr. Devendra Singh Jhala, Dr. Dharmesh Solanki, Dr. Pawan Roy, and Dr. Nilesh Purushottam. The topic is diabetes and heart failure, SGLT2 inhibitors. I would like to request Dr. Badlani to kindly introduce our speaker. Dr. G.R. Badlani, please.
Good morning, everyone. At the outset, I want to thank Dr. Kambar Sharma and the whole Cardiocon team for giving me this opportunity to moderate the session. And as we all know, this is bout number 18, and the topic is diabetes and heart failure. Yesterday, we discussed the heart failure, and today is diabetes with heart failure with particular emphasis on SGLT2 inhibitors. For that, we have 3 speakers. And the first speaker is Dr. Soumitra Ray. He's the Director of Invasive Cardiology, AMRA Hospital, Calcutta. He's an ex-professor, Vivekananda Institute of Medical Sciences. He's an ex-vice president of CSI. He stood first in order of merit in higher secondary, MBBS and MD, all the exams. And he later on pursued MRCP in UK after MD from Calcutta Medical College. He's trained in interventional cardiology at Royal London Hospital, London. And he has published many papers, reviewed many articles, and written many chapters in cardiology books in India and abroad. And he is in the editorial board of Indian Heart Journal and Journal of Diabetic Dyslipidemia. And he represented CSI in interventional conferences. And he's the founder president of Calcutta Cardiology Association. Welcome, Dr. Soumitra Ray. Then we have another speaker. He is a well-known figure in Ahmedabad, Dr. Sanjeev Phatak. He's a renowned cardiologist and physician in Ahmedabad. He's at Vijay Ratna Diabetic Diagnostic and Treatment Center. He's a principal investigator in more than 30 global clinical trials. And he's a recipient of Sanofi Lectureship Award at Epicon in 2016. He was invited as guest faculty at various national as well as international conferences. He has many publications.
Keep the introduction part, Dr. Badlan.
Okay. So he's the first diabetes. Okay, sorry. Then we have third speaker, Dr. Uddha Jadhav from Mumbai. He's a consultant in cardiology as MGM New Bombay Hospital, and he's a professor and faculty, Maharashtra University of Health Services. He's actually involved in research, and he was awarded many. He was given many awards and award sessions at American College of Chest Physicians, International Critical Care Congress, CSI, API, Hypertension Society of India, and Indian College of Cardiology in last 5 years. So this is the introduction for all the 3 speakers. And now I invite the first speaker, Dr. Soumitra Ray, to speak on dapagliflozin in the patients of heart failure. Dr.
Thank you, the whole team, Cardiocon, the respected chairpersons, Dr. Sharma. Would you allow me to share my screen, please? Please allow me to share my screen.
Yes, you can share your screen.
Just give me a minute to share my screen. I think you can't see the full picture now. Are you seeing the full screen? Not yet. Just give me one more bow. No, are you seeing the full screen?
No.
No. Okay, just a minute. Can you see the full screen now?
No, you put it on
Not yet.
slide show,
Not
sir.
yet. Okay, just a sec. Now you will see. Now you can see the full screen, now. Just tell me whether you see the full screen.
Okay, done. Yeah.
Yeah, done. Yeah. Okay. Thank you, Dr. Sharma, for starting the day with the lovely doctors talking about yoga and diet. I was almost going to decide to start yoga and dieting from tomorrow, but I resisted at the last minute. So today's talk is that dapagliflozin is the preferred choice of SGLT2 in this person. Look at this person. A 95 kg Indian male on optimal cardiac medicine, has diabetes with A1C 8.2, BMI 34.5. Remember, ejection fraction 40%. Remember, history of CABG 2 years back. Please remember. Now, dapagliflozin is the preferred SGLT2. And why not? The choice is actually clear if you do not want to break the law. And Dr. Sharma is a very law-abiding person. He already put empagliflozin in the red corner. He put remogliflozin in the yellow corner and gave me with dapagliflozin to go ahead with the green-blue corner. So the choice was made not by me, but by Dr. Sharma. Thank you, Dr. Sharma. So there is a myth that in presence of ASCVD, empagliflozin gives a MACE benefit, which does not give what the dapagliflozin in DECLARE does not give. But you see, EMPA-REG had all 100% ASCVD patient, and DECLARE TIMI had only 40% ASCVD patient. And if you see dapagliflozin, as far as the ASCVD group of those 40% is concerned, you have got a clear benefit in cardiovascular death and heart failure hospitalization with 17%, and the confidence interval does not exceed 1. So if it is ASCVD, dapagliflozin as good as empagliflozin. And that is shown by here also. If there is MI within 2 years, beyond 2 years, you get even MACE benefit, not only the death benefit and hospitalization for heart failure benefit. And if you see the meta-analysis of EMPA, CANA, and DAPA, you will see that ASCVD, everybody is a meta-analysis showing good result. But for multiple risk factor, it is not showing good result. Meta-analysis is important because my subsequent speakers will show meta-analysis. If you believe their meta-analysis, you have to believe my meta-analysis as well. So all three SGLT2 have shown benefit that are limited to ASCVD patient. MACE benefit, remember. So there is a myth that presence of ASCVD, EMPA gives MACE benefit. It is not. It depends on the molecule. It does not depend on the molecule. It depends on the patient profile. If it is ASCVD, everybody gets benefit. If it is any patient, you will get heart failure benefit. But heart failure cannot be judged from those two trials because only 10 to 15% of those patients were heart failure. So we have to fall back on DAPA heart failure and Emperor reduced trial for our patient. And DAPA heart failure showed clearly an astronomical p-value for benefit for dapagliflozin for the cumulative benefit of heart failure and cardiovascular death. And the individual component, if you see, they have got ischemic cardiomyopathy more than 50%, even with DAPA. So DAPA is not an ischemic, that is a totally wrong idea. Even in DAPA heart failure, more than 50% people had ischemic cardiomyopathy. And what did DAPA show? There's a significant benefit in heart failure hospitalization, and there is a significant benefit in cardiovascular death. But the EMPA showed there's a significant benefit in heart failure hospitalization, but no benefit in cardiovascular death in Emperor reduced. So EMPA couldn't reduce risk of cardiovascular death. And all-cause mortality is also very important, isn't it? And DAPA showed a 17% reduction of all-cause mortality. P-value is 0.02, which is significant. And Emperor showed only 8% benefit of all-cause mortality, which is not at all any different from the placebo. And DAPA also showed the composite ventricular arrhythmia and sudden cardiac death reduction by a p-value of 0.03, which is again significant. Does EMPA has any data on reduction of composite ventricular arrhythmia, resuscitated cardiac arrest, or sudden death? Not yet published. If it is not yet published, I can't talk about it. So, DAPA and EMPA in these two trials, cardiovascular death, only DAPA. All-cause death, only DAPA. And even onset of new diabetes in pre-diabetic people, only DAPA. EMPA fails miserably in preventing diabetes as well. Now, I talk to my patient over here. Now, you see, Dapagliflozin shows the benefit from BMI 15 to BMI 50. There is uniform benefit. But you see here, very interesting. EMPA has got no benefit when your BMI is more than 30. Emperor reduced, go back and see the trial. If the BMI is more than 30, Emperor has got no benefit this patient. And what is the BMI of my patient? 34.5. So Emperor has got nothing to do in this patient. Now, ejection fraction from 10 to 40%, Dapagliflozin shows benefit in death, in all-cause death, in heart failure hospitalization, uniform benefit. Here you see the Emperor reduced. If ejection is above 30%, absolutely no difference with placebo. It's on the neutral line. And what is the ejection of my patient? 40%. So no question of giving empagliflozin in a fat person of ejection fraction 40%. What is the positioning of DAPA in recent guidelines? In 2020, only 2 years ago, Heart Failure Association of ESC said by naming it that dapagliflozin should be given in HFrEF. What is the Canadian said? That recommended SGLT2 inhibitor such as dapagliflozin, which is a representative molecule with and without concomitant diabetes. But also Dr. Sharma kept remogliflozin. Why? No reason, except personal obligation. To write for me, if the company people say, sir, please write 1 or 2 prescription, I might oblige them. I should not. But no presentable data whatsoever. Of course, price matters. Of course, price matters. I know that. Empagliflozin made in Germany, 15,000 per year. Remogliflozin made in India, 8,000 rupees per year. Dapagliflozin, if it is made in Sweden or UK, 16,000. If you search in certain apps, you will get it an 8,000 home delivery. But dapagliflozin in India, 5,000. Remogliflozin in India, 8,000. Dapagliflozin made in India, 5,000. Of course, I'm concerned about price. That's what I'll give dapagliflozin. So if my patient is rich, I'll give Forxiga over Jardiance. If my patient is poor, I'll give a DAPA India rather than a Remo India. So for this patient, DAPA scores over other SGLT2 because it is the only molecule which causes reduction of cardiovascular death and all-cause mortality. It is the only molecule which is applicable for BMI above 30. It is the only molecule which is applicable above ejection fraction 30. It is the only molecule which prevents ventricular arrhythmia and sudden cardiac death. And it is the only molecule which is best affordable of all the SGLT2 available wherever it is made in the world in India. So for this case, Dr. Kamal Sharma told that for empagliflozin, do not proceed, a red light. For remogliflozin, you think twice. And for dapagliflozin, just go ahead. Just write the prescription. Thank you, Dr. Sharma, for this favor toward me and all other here for being law-abiding citizens. I stop over here. Thank you.
Thank you, Dr. Soumitra Rai. Now we will go to Dr. Sanjeev Padak.
Yes, good morning, and thank you, Dr. Kamal Sharma, Dr. Jayesh Trivedi, Dr. Badlani. May I be visible?
Yes,
yes, sir. Is it in the full screen mode now?
Yeah, continue.
Okay. So thank you very much, all the delegates and all the faculty members who have joined. And thank you, Dr. Soumitra Ray. I know you are a very learned cardiologist, but the patient who has come to you, he has not just come to you for heart failure management. He has come to you for overall management. And that is why the patient, after going to Dr. Soumitra Ray, has now come to me because he received dapagliflozin and could not get the control. Why so? I'll explain you in next few slides. First, let me clarify that this is not about the red signal or green signal. This is about the boxing bouts where red is put in the favorite position, whereas blue and green probably are the fighters, but most probably the favorite is red. So here, the favorite one is empagliflozin. And obviously, I'll vote for empagliflozin, not in this particular case, but for any diabetic patient who is having history of cardiovascular disease. No need to remember that with heart failure, give dapagliflozin, without heart failure, this, kidney failure, this. You just need to remember one gliflozin, that is empagliflozin. Why so? I'll explain in next 8 to 10 minutes. Well, our patient, 34.5 BMI, A1C is 8.1 controlled, CABG before 2 years, LV ejection fraction 40, which may be 45 with the other cardiologists. Dr. Soumitra Ray knows this very well. Presently is on the guideline-directed medical therapy, which obviously includes metformin, and he now needs, according to any guidelines, an SGLT2 inhibitor. Which SGLT2? It has to be empagliflozin. What are the aims of management for our patient? First and foremost is the glycemic control, not just heart failure. You need to prevent the microvascular, macrovascular, all the complications. Second is weight loss, prevent the cardiovascular event, prevent heart failure hospitalization, and obviously reduce mortality. Let us look at the glycemic control. And then there are meta-analyses which have been published even in 2019, has shown that compared to dapagliflozin, which is in the dotted graph, EMPA gives better HbA1c reduction, better fasting control, better weight reduction, and better systolic blood pressure reduction. And this is meta-analysis of 7 studies from Asia. Regarding the cardiovascular events, we very well know the EMPA-REG outcome, that a robust 32% reduction in the all-cause death with empagliflozin when used in type 2 diabetic patients with cardiovascular disease. And this patient, the patient which Dr. Kamal has referred us, is having cardiovascular disease. He has already undergone a bypass surgery. So you can expect 32% cardiovascular as well as the all-cause death reduction. And this reduction is across the categories of the CV death, whether the patient had fatal MI, fatal stroke, heart failure related death, sudden death, whatever it is. And this is again, regardless of the various types of CAD. In this particular patient, we have 2 things. One is patient is prior CABG, significant reduction. Patient also has heart failure, again, very significant reduction. Again, this is regardless of the CVD manifestation, whether the patient is having PAD, stroke, prior heart failure, prior atrial fibrillation, whatever it is, patient will benefit. You need not remember whether the patient is having ejection fraction 40 or 42, whether the patient is having bypass surgery or not. You give empagliflozin and it is one-time solution for everything. Look at the cardiovascular outcomes. Everything is in green. This green signal is important, not that one. EMPA-REG, 3-point MACE, CV death, heart failure, everything is significantly reduced. Unfortunately, Declare-TB showed only heart failure reduction. So it is a heart failure drug, not a diabetes drug for that matter, I can say. Asian patients, our patient is Asian, and obviously you can see significant benefit in Asian patients in the empagliflozin, whether it is 10 milligram or 25 milligram. And based upon this, we know that empagliflozin became first and the only OAD approved for reduction of cardiovascular death in patients with type 2 diabetes with established cardiovascular disease. This is what our patient is having. And this is not just based on one study, that is EMPA-REG. Apart from EMPA-REG, the meta-analysis of 7 phase 3 studies, not including EMPA-REG, has also shown significant benefits in 4-point MACE, 3-point MACE, cardiovascular death, and heart failure hospitalization. Let us look into heart failure now. EMPEROR reduced 25% relative risk reduction, 30% in the dapagliflozin. In one of the studies, Dr. Soumitra mentioned that DAPA had 17% reduction, where EMPA had 38% cardiovascular death reduction in type 2 diabetic patients. Here, the difference is only 5%. But if you look at the absolute risk, there is not much of a difference. Again, the adjudicated total hospitalization for heart failure, first and recurrent, 30% risk reduction with empagliflozin. Both the populations were different. Ideally, we should not compare these two trials, but for the sake of comparison, the overall baseline risk was much higher in the Emperor reduced compared to the Dapagliflozin. Moreover, in the Emperor reduced, the patients were either on ICDUs or CRTUs or ARNI. That means they were receiving the guideline-based therapy, and on top of that, empagliflozin could achieve an additional benefit, which was not the case in the DAPT trial. So regardless of heart failure is there or not, diabetes is there or not, empagliflozin in diabetic patients has definitely given much better results compared to dapagliflozin. And that is true not only with reduced ejection fraction, but also with preserved ejection fraction, more than 40. This patient is having ejection fraction of 40. With some other investigator or cardiologist, it's maybe 45 also. We know it is a subjective thing. Across the category, empagliflozin has shown benefit. We very well know, I'm not going to details of that, whether it is CV death, hospitalization, whether LV ejection fraction is 41 to 49, whether it is 50 or more, or whether it is less than 40, EMPA will give you benefit. And this study again, this meta-analysis again shows, even if it is below 25 or 25 to 35, or even more than 65, EMPA is going to give you cardiovascular benefit, not just the heart failure benefit. Moreover, patients who had higher background risk and those who were treated with the ARNI-like therapy or CRT or the devices, still empagliflozin could give benefit. The meta-analysis published in the Lancet 2020 also mentioned that both the trials show significant benefits, and these benefits are almost similar. There's hardly anything compared between these two. If you look at the kidney composite outcome, both Emperor reduced and Emperor preserved showed better kidney composite outcomes compared to the DAPA-HF or declared meaning thereby that not only heart failure, but also in the kidney-related endpoints, empagliflozin scores over dapagliflozin. So it confers significant and meaningful CV benefits in patients across the CV risk continuum. If you look at the patients with low risk, medium CVD risk, phase 3 meta-analysis, significant benefits with EMPA. EMPA-REG outcome in diabetic with established cardiovascular disease, benefit. Again, patients with prior CBABG, benefit, which is the case in this patient. With preserved ejection fraction, benefit as per the Emperor preserved. With reduced ejection fraction, benefit as per the Emperor reduced. What are the other benefits that are unique to empagliflozin? Maybe there with other gliflozin, but not well documented. One is the blood pressure reduction, whether it is nighttime BP, daytime BP, 24-hour BP. The SACRA study showed that empagliflozin reduced the systolic blood pressure by 6 to 10 millimeter of mercury. How about obstructive sleep apnea, which this patient is very likely to have? Very, very significant reduction by empagliflozin in the risk of OSA, 52%. And we know very recently one of our famous Bollywood personality died due to obstructive sleep apnea. Hepatic fat content, both Indian studies as well as the Western studies have shown that empagliflozin reduces the liver steatosis and fibrosis. Well, this may be there with Remo and DAPA, but not so well documented as compared to empagliflozin. So let us compare finally with DAPA and Remo. I could not find any comparative study. So the 3-point MACE, CV death, all-cause death, everything very, very favorably affected by empagliflozin. With dapagliflozin, none of these factors have been affected in diabetic population. And that is why it is the only SGLT2 inhibitor officially recommended to reduce the risk of death in diabetic people. I'm not talking about heart failure also, I'm talking about diabetic as a whole. So I have 3 medicines, all 3 drugs will reduce your blood sugar. But let me ask my patient, one drug will save your life, and that is empagliflozin. Whether you are having heart failure or not, whether you are having heart failure with mildly reduced, or preserved ejection fraction, this drug is likely to save your life. Well, talking about the cost, we Indians are always innovative. We doctors are no exception. We can cut down the cost by making the empagliflozin half. So by spending 10 rupees extra, if you are going to save the life, I think that's worth doing it. And we have data with both 10 and 25 milligram of empagliflozin that they are equally effective, not only in reducing the HbA1c, but also in the cardiovascular outcome, whether it is EMPA-REG, EMPRISE, or Emperor Preserved trials. Finally, glycemic control, you can say EMPA is slightly better. REMO, we do not have any comparative data. Whatever data is there with Dapagliflozin is comparative. Weight loss, almost equal. CV events, overall, empagliflozin has more benefits compared to DAPA. REMO, people will ask, what's that? What is CV events? Reducing mortality, REMO, there is no data. Empagliflozin, there is stronger data. Heart failure, slightly better data with dapagliflozin, but EMPA has data even in the preserved ejection fraction. Sleep apnea, much better data with empagliflozin, no data with the other drugs. Liver fat, better data with empagliflozin. Half dose of EMPA is effective. SGLT2 receptor affinity, much more, and that is probably the reason why empagliflozin scores over the other drugs. Kidney injury, risk is minimal. Bladder cancer, no debate, no risk. DAPA was initially not approved for this reason. Amputation, probably we have no data with CANA, rather. There is a typo error here. It should be not CANA, remogliflozin in the last box. So EMPA is a clear winner, not only for heart failure, but for cardiovascular events, for the renal events, for weight reduction, for sleep apnea, for liver fat, everything. So I would rest my case here with empagliflozin being the best drug amongst the SGLT2 inhibitors. Thank you very much. Thank you for your very kind.
Superb, Panik.
Now, Dr. Uday Jadhav.
Thank you very much for allowing me this opportunity, respected chairpersons, Dr. Kamal Sharma, and the entire team from CardioCon. So let me share the slides and make it quick. I promise you I'll save your time. So first thing first, am I well heard before I go ahead? And is the screen visible?
Yeah, yes, you are audible.
Very nice. So the last slide that Dr. Sanjeev Phatak showed, you saw remogliflozin in that marathon trying to climb up to the other molecules. And therefore, I rightly put this, that this is an uphill climb. So I was surprised that I was given this heading that it is the most studied molecule in the heart failure. It cannot be anywhere near the real truth. It is the least studied molecule in heart failure. I go by the science. I do not try and protect what I want to say always, but still I'll put in few very important thoughts. So let's talk of remogliflozin. And so what is the premise on which I would base this 7-8 minutes presentation? One is that it is a class effect of SGLT2 inhibitors. It is just that in the hierarchy and the historical trials as they come through, each molecule proves its worth. So if EMPA worked in...
sorry to interrupt you, sir. Can you put it in slide mode?
It is not in the slide mode?
Yes, sir. It is not in slide mode.
Is it still, or I'll stop sharing and do it again?
No, sir. It is the slides are in C, but just put it on slideshow mode, full screen mode. Now you are stop setting.
Is it now on a bigger mode?
Yeah, it is fine.
All right, so very quickly. So one is that it is a class effect and it's just the hierarchy or the historical evolution of molecules in SGLT2 inhibitors that decides how things work, but they all work. It's a class effect. I think this debate is reasonably useless for EMPA and DAPA. Both work very well. And for that matter, all SGLT2 inhibitors are going to work very well. The question is, REMO being the least studied, does it stand the merit of evidence as on today's date? Look at an analogy of calcium channel blockers, right? Amongst the CCBs, it's only amlodipine, which is the gold standard and has been thoroughly studied. Not a single one of the others, Silni, Azalni, Benodipine, not a single one of them has a CV outcome study or even a reasonably good outcome study. And yet, both medical professional doctors and their families have been on CCBs. And that's on for the last 10 years. What makes that happen? Because there will not be a clinical trial that will evolve with any other CCBs. And therefore, it will be impossible to tell you whether cilnidipine will change the CV outcomes. But don't you prescribe it to the patients? Don't you take it yourself or in the family, right? The same would work with most of the SGLT2 inhibitors. So that's my first pretext. Second, and I'll show you why SGLT1 inhibition is an important concept. And third, whatever evolutionary data has come up over the last 2-3 months. So here is a comparison between REMO and dapagliflozin. That was the initial launch study of 10 milligrams of dapagliflozin. And what did it tell us? Very quickly, it showed us that at 6 months, the HbA1c lowering, the fasting lowering, and the postprandial lowering was non-inferior. You may call it little superior if you want, but certainly non-inferior, even if the p-values are taken in consideration. So the clinical development, which started in 2019 and 20 by Glenmark, who brought it in India, continued. And the real-world assessment came from 4 clinical studies. They involved more than 11,000 patients. That was the INSPIRE data. The INSPIRE, after the head-to-head study between DAPA, was a real-world experience, trying to show what happens in real-world in 11,000 patients. And the HbA1c reduction was lesser, 0.95, as compared to the baseline. Fasting sugar went down by 42, and the postprandial sugar also went down significantly. Body weight down by 2.6 kgs, BMI by 1 kg per square. It's absolutely comparable. All these 5 parameters are absolutely comparable with EMPA, DAPA, any of the SGLT2 inhibitors. The systolic and diastolic blood pressure of 3.3 and 2.3. Very comparative. It's very interesting to see that even in the real world data exceeding 10,000 patients, there wasn't really any difference. GU infections were 12.5, and I, for one, am a proponent saying that let's not rub that under the blanket. The clinical trials, even with EMPA, DAPA, tell you it's 0.3 to 3. Well, that's not true. Believe me, in clinical practice, you will see 10 to 12%. It cannot be lesser. Whatever be the severity. Lab parameters, the uric acid and the USCR, 2 things that influence cardiovascular effects, morbidity, mortality, and heart failure got improved. So here is the comparative data from INSPIRE, and it tells you it's absolutely similar. Whenever you compare EMPA, DAPA, CANA, it's absolutely similar. And my second pretext. This is a SGLT1 inhibitor. Mind you, the SGLT2 inhibition with EMPA is way high, right? If I correctly remember, the T2, T1 affinity for the receptor and the inhibition is 3,500-fold and is the gold standard. With our remogliflozin, it's 365 T2 to T1 inhibition, so more T1 inhibition. I'll show you the data with SGLT1 inhibition, primarily with sotagliflozin, which has a 20-fold affinity. So very strong inhibition of SGLT1 inhibitor, right? Is this important? Of course. Unlike SGLT2, SGLT1 has an expression in the cardiomyocyte sarcolemma and the capillaries. This has been proved in human autopsy darts, in murine animal models, and this entire expression on the cardiomyocytes is glucose metabolism dependent in the heart with SGLT1. In end stage of cardiomyopathy in type 2 diabetes, SGLT1 expression is the most comparative to SGLT2 expression. So what am I saying? SGLT1 expression and its inhibition certainly, potentially, theoretically has to make a difference to the human heart. But is that only theory? No. Look at the Soloist WHF data. Primarily, strongly SGLT1 inhibitor, Deepak Bhatt's presentation, where he tried to look at all stages, preclinical, clinical, and the detectable cardiac involvement. That's where you can place Remo exactly like SOTA. It's used for WHF, for hospital discharge, and after 3 days, right? Look at the difference it has made. The difference is so huge at 28 days. The hospitalizations at 28 days and was significant at 0.035 since randomization. These are the events of urgent HF visit. Here is the data. Let me tell you one very important thing. Now we are talking about EMPA in HFpEF as a prospective trial, but it was not EMPA. The whole story started with LVF less than 50 and more than 50. Look at the effect of SOTA, a SGLT1 inhibition in SOSAD HFpEF. It's even more robust than HFrEF. Unlike all the other molecules, mind you, even with EMPA data, the lower the EF, the better you get for heart failure. Here is a molecule where even when the EF is not as low, more than 50, EMPA at 55, 60 is just about neutral. At more than 50, SGLT1 inhibitor is very, very strong. So I think that's important. Makes a difference in all parameters before and after. That's the LVF data. Keep that in mind with SGLT2 inhibition. Here is the pool data of 11,000 patients. Deaths, heart failure hospital, urgent HF, CV deaths, everything gets better. Everything gets better. And this is my last slide, but a very important slide. This slide must be preserved because it's DAPA, Emperor, and SGLT1 and 2 inhibition by Soloist WHF. Look at the third one, that small little dot. It scores better than everything, the one above. Even if you don't want to separate the wheat from the chaff, still it tells you SGLT2 inhibition and SGLT1 inhibition on top of that will make a difference. So Remo is not the most studied, ladies and gentlemen. It has a potential. If you study it, it will be like any other CCB in the SGLT2 class. It will prove its worth. The molecule has a place, sure and certain. Now, whether prospective trials are going to come off, I do not believe. There is the Revolution studies that are coming up with the originators in India, and there are a few others in heart failure segments, in diabetic segments, in NASH. But leave that aside. If you are waiting for an international study to come through, no, it's a Japanese molecule. It won't come. Will it come with sotagliflozin? You bet. It's already proved its worth beyond everything else. Thank you very much for the patient hearing. And I may have to move on to another meeting for ICCON, so please spare me in case I have to go in between. Thank you very much.
Kamal, unmute. Kamal, unmute.
So I think one thing which comes clearly from the discussion. I am audible?
Yes, continue, Dhiren.
Yeah. So mortality benefit versus morbidity benefit with SGLT2 inhibitors. So suppose we are keeping mortality benefit only in our mind, then of course, as per the all presentation of the science, I think EMPA will come first, then DAPA, and with REMO, there are no other data available to show the mortality benefits.
But morbidity benefits, I think all the three have are doing equal good. What is your comment, dear speakers and the other panelists also?
May I have a quick say? I'm Dr. Shomitra.
Yeah.
As it is said very nicely by Dr. Phatak and Dr. Jadhav as well, I see more patients of heart failure every day, proved heart failure. And I see ischemic cardiomyopathy and non-ischemic cardiomyopathy, both, you see. So if you see, the case was not very completely shown. We need to know the bypass occurred more than 2 years ago. How is the patient from ischemic standpoint? If he's taking, say, sublingual nitrate every day, if he's having a dynamic ECG changes, if he's getting admitted for ischemia and getting treated, then of course ASCVD is the primary disease here, and perhaps by evidence, empagliflozin is the first choice. But if the heart failure predominates and it's a burnt out ASCVD, then if they coexist, heart failure determines the future, not the ASCVD. The patient dies of heart failure and consequences, not a failure of graft. 2 years graft, in a good surgeon, this graft will last for 20 years without any problem. But heart failure, we need medical management. And for HFrEF, the dapagliflozin has got, if you see these two last, not EMPA-REG or not declared TIMI, those are not heart failure trials at all. Only 10% heart failure patient. Whereas in these heart failure trials, 50% had ischemic cardiomyopathy. So they are more representative of my patient. And here dapagliflozin has got a very clear age. But having said so, 40% ejection does not mean anything. We do not know whether the patient is symptomatic or not. And it is not a diagnosis of HFrEF. HFrEF diagnosis means symptom plus minus sign plus an ejection fraction below 40%. So just an ejection 40%, I cannot say even this patient has got heart failure. But if it is a patient is in heart failure, DAPA, if he has got ongoing ischemia, EMPA, if it is an ischemic cardiomyopathy, maybe either, but DAPA, remogliflozin is definitely has got future. Only thing is that it is twice daily dosing. And that sharply reduces compliance. That sharply reduces compliance for any medicine. That's my take.
One thing.
Hello.
So that is why if you give empagliflozin, you are never going to be wrong. Dr. Kamal intentionally did not give the full information. I think so. Regardless
yes,
of
the incomplete information is always to trigger a
BMI.
debate. You're right. So
Yes.
I kept.
So regardless
I
of that, if you give empagliflozin, you will never be wrong. 2%, 5% here or there. You
then
will
we'll
never
not
be
have
wrong.
debate, Sanjeev bhai. Then only you will be speaking. No. I was to mention. So I think the whole idea was to promote SGLT2 in heart failure. We need to have, irrespective of ischemic, non-ischemic, diastolic, systolic, SGLT2 inhibitor has to be there. I think evidences are emerging, as Dr. Uday Jadhav mentioned, for remogliflozin in Revolution study. I think that would be the largest SGLT2 data from India when it gets through. The class effect is for heart failure is very well known. We have studied that in even the ertugliflozin, which had similar trial design like EMPA, but failed in the trial. But still, heart failure was reduced. It did not reduce the MACE rate, mortality rates, but it did reduce heart failure rates. So heart failure hospitalization is a class effect. Mortality may not be, depending on how sick patients, what is the inclusion, what is the exclusion criteria that we get. So I think everybody should get SGLT2. I don't think there is any doubt about it. What to choose again?
On top of the MRA beta blocker.
Absolutely, absolutely, absolutely. So chairpersons, if you can, chairpersons, if you can have, we can have your viewpoints on this, and then we can conclude the session.
Kamal, we have to clear the confusion among the physicians.
Absolutely. So chairperson,
Now the first is suppose
Ramesh
patient.
Solanki, Pavan Roy, or Dr. Nilesh Purushottam.
Yeah.
Your comments?
Yeah, I'm very happy to hear. Thank you, Dr. Kamal sir. I think everything is well discussed, and point is, as you said, heart failure in heart failure management, and in secondary prevention of atherosclerosis, ASCVD, this molecule should be there in the prescription in all patients with and without diabetes, especially in heart failure without diabetes, and if patient has a diabetes with atherosclerosis. Among the choices, that positive points and negative points of all molecules that we have already discussed, and it is almost similar like what statin we have to use, either atorvastatin or rosuvastatin, something like that. So according to me, it is a class effect, and Remo is an Indian brand, but that evidences are emerging. So till the evidence, we can use any of that, either DAPA or EMPA, as we discussed. Thank you very much.
Hi, good afternoon, sir. I am Dr. Pawan Roy. Thank you, Kamal sir, for inviting me for this conference. Actually, any patient who admitted this heart failure, starting the SGLT2 inhibitors from the first day, I've seen some patients going into lactic acidosis or inherent UTI, which may not be detected if we don't do urine RM. So in such patients, there may be worsening of UTI or even dehydration if the patient has already been going on Lasix or direct infusion. So I have a doubt that whether we should start SGLT2 inhibitors a few days after the acute LVF episode recovers, or we can start on admission only.
So most of the times, I think we end up doing this is that we make the dose of diuretics half when we add an SGLT2 in such scenario where the patient is already stable on it.
Exactly.
And I think the whole idea what Dr. Dhiren Bhai was asking was that heart failure means an SGLT2, of course. You have very strong evidences for established ASCVD because of the trial design rather than the effect per se. But then I strongly still believe that the SGLT2 upon SGLT1 ratio is also an important determinant how significantly a molecule may or may not have impact on CV outcomes. But again, it's a subject of speculation rather than evidences. We believe because it works more so for EMPA in the EMPA-REG outcome rather than DAPA-HF, which trial design was different. But I think DAPA people learned it by default in the trial design, and that's how in EMPEROR preserved, you could not achieve mortality reduction, but you could do that in DAPA-HF. Which they learned from the failure that they had in mortality. Declared to me they could not achieve a mortality difference. So when you choose patient subgroups which are sicker, you probably end up finding more evidence-based reductions. And that's why it's more important that when we interpret a trial, we also look at their inclusion-exclusion criteria rather just interpret their results per se. So I think in patients with established ASCVD, as of now, with sick LV, with IHD, EMPA probably has an edge. DAPA also has evidence for it. Non-ischemic, as Dr. Soumitra Ray mentioned, denying these patients gliflozin, either of the two, you still have evidence for if you're believing in class for remogliflozin. That's my take. Open to any of the speakers or chairpersons to have any additional comments on that, and then we can end the session.
Can I make a comment? Here?
Sure.
Actually, he was telling about UTI. See, it has been seen that UTI is not a big problem with SGLT2 inhibitors. It's only genital mycotic infections which can happen rather than UTI or even pyelonephritis or cystitis. So it's not UTI. It's only genital mycotic infections which can have problems rather than. That's what is my comment. That's all.
Yes, fully agree with you, Dr. Raghu.
Absolutely. I think, may I make that comment? That just to be sure, we talk about mycotic infections. The very little, let's not call them even UTI, but in certain circumstances, let's say catheterized patients, for those who are undergoing urological surgery, one of the experiences, they do get symptoms of urethritis. So I would be probably a little careful in the uro setting of starting a SGLT2 inhibitor immediately. I would let this procedure settle down. Cystoscopies, digestantings, patients who have hospital-acquired UTIs, nothing to do with SGLT2 inhibitors. These are the patients where you don't want a little more trouble. So they do create a little urethritis. But besides that, you're absolutely right. It's not UTI. we don't use the term. It's simply mycotic. Well corrected. Yes, it's all mycotic.
So I think we have made it. It's a long time.
Just one
I think,
question.
yeah,
May I have one
everything
question?
is clear now. Yeah.
I have one question, please.
Yes, sir.
This is going to be the last question, please.
Okay, yeah. Can we start SGLT2 inhibitor in patient with asymptomatic bacteriuria detected first time and patient with heart failure?
Yeah.
Asymptomatic bacteriuria, when you get
Yeah. You
cell
can.
50 to 60% in
You can start. If the patient doesn't have any fever, I think you can definitely start. Yeah.
I think we have discussed this in one of the forums where Dr. Sanjeev Phatak was also there. A good strategy in such cases is if the more amount sugar is thrown when your glucose is more uncontrolled. Once you attain good glycemic control and add an SGLT2, the amount of glycosuria may be lesser and hence likelihood of UTI would be lesser, whatever is infection you're saying. So if a patient's sugar is 400 and you're giving an SGLT2, you're likely to have more glycosuria because the renal thresholds are at 70. And hence these are more glycosuric and hence probably more UTI. So if you're controlling diabetes well with your diabetologist and adding an SGLT2, then the glucosuria is lesser, but the heart failure benefits still exist, as we know from DAPT, where even in non-diabetics it works. So if you're so much worried, ask your diabetologist to, add an insulin, think of SU, whatever other things that you can do and are safer in heart failure. And on top of that, then you come in maybe in a day or two with an SGLT2, probably you will not end up. But again, this is anecdotal thing and just a physiological extension or argument, otherwise not paper and data. But of course, if the incidence of UTIs in DAPA-HF was 2%, much lesser as compared to the other trials. That is because if you're non-diabetic, you don't get UTI. That's the evidence for it.
Thank you. Thank you, sir.
Thank you, everyone.
Now we'll go ahead with another bout number 19. Thank you so much, all speakers and chairpersons and co-chairpersons. For bout number 19, I would like to invite Dr. Shashi Mundra, Dr. Raghu, Dr. D.B. Solanki, Dr. Nikhil Jadhav, Dr. Saurin Shah, and Dr. Sanjeev. I would like to request Dr. Bhagirath to kindly introduce speaker.
Doctor, our first bout 19. Good morning and thank you, Dr. Kamal Sharma, for providing me an opportunity to be here in this conference, CardioCon. For this bout, the speaker is Dr. P.K. Hazra, who is DM and DNP cardiology. He is associated with the Medical Super Speciality Hospital and Ruby Hall General Hospital, Kolkata. He specializes in interventional cardiology and cardiovascular surgery. His medical interests are angioplasty, angiography, atherectomy, stents, and peripheral angioplasty. So he is a truly interventional cardiologist, and he is going to talk on a very peculiar subject, that patient which has been given here is a 60-year male who is diabetic, hypertensive, strong family history, has a CV stroke 4 years back, completely recovered, and now 1 year before has infeasible MI and had put 3 stents. He is coming for follow-up. Apart from his medical optimization of therapy and lifestyle, what can be added over and above the aspirin, whether rivaroxaban or ticagrelor? And for that matter, Dr. Hazra is going to speak for 10 minutes about the addition of rivaroxaban 2.5 milligram BID over and above the aspirin and other medical optimization therapy for the patient. Thank you very much. Over to you, sir.
Kindly introduce Dr. Hemang Bakshi also.
Sir, yeah. For the next, this blue corner is our famous Dr. Hemang Bakshi. He is a very eminent cardiologist from the city of Ahmedabad, interventional cardiologist and director of SIMS Hospital, postgraduate in medicine from the my own BJ Medical College from where I belong, and gold medal in the DM cardiology. He is authored many research papers and had extensive experience in the field of clinical and interventional cardiology. He performed more than 5,000 PTCAs and is one of the pioneer in the primary angioplasty in Gujarat. He received the prestigious fellowship of American College of Cardiology and fellowship of European Society of Cardiology. So truly a very experienced person. And after the Dr. Hazra, Dr. Bakshi is going to talk for ticagrelor over and above the aspirin plus medical optimization therapy for the same patient, which we have already talked. Thank you very much. Over to Dr. Hazra, sir.
Thank you. Please allow me to share my screen. Please allow me to share my screen.
Yes, sir. Please, sir.
Yes, sir. Your screen is already there.
Okay. So thank you, Dr. Sharma, for inviting me. And case is already been shown there. Now, you know, this CAD is just like having a pimple on this beautiful face.
So your screen is not visible. It is a whiteboard. Please open your presentation first and then share the screen.
Now, can you see?
Yes, yes.
Yeah. Now it is visible.
Okay. So thank you, Dr. Sharma. CAD and many other cerebrovascular disease or peripheral vascular disease, I'll come back to CAD. This is just like a pimple on your face, and it can be treated, untreated. There's necrotic rupture, stress, food. Many things are important. So lifestyle is very, very important to keep your simple pimple not disgracing your face. So you have a stent and you just cover one pimple. If you have two stents, you cover two pimples. And if you have three stents, you cover three pimples. And these pimples are basic informations for our case to understand what I'm going to say. If you take this case, 60 years, there are some trials which fits into it. The red color tells you that it doesn't fit into that trial. They take more than 65 years. In Compass, they take enrichment criteria if somebody is less than 65 years. Diabetic, inferior MI, hypertension is not there in Compass trial. Stroke is not there in Pegasus. If somebody has a stroke, so this patient does not fit into Pegasus trial. Pegasus talks about multivascularity, Compass talks about polyvascularity. The strong families is not there in both the trials. Dyslipidemia not there. CKD is missing, which is a very important component of Compass trial. With this, may I propose a score for this patient for my convenience, like a CHADVAS score. CCA is more than 65 in non-Asian and more than 55 in Asian. So he gets 1 point diabetes. And if he has got stroke and multivascular coronary artery disease, he gets 4 points. And if he has got 4 points, it's a solid case for DPI, not DAPT or SAPT. Now, I have very, very low threshold to prescribe DPI in these patients. Very rarely, patient will escape my prescription of DPIs, typically this patient. Now, if you talk about A, B, C, D, E, F, G, H, I, J, or polypharmacy or monotherapy, you have many drugs which can brings your death down 9%, 2%. An outlier is here that it reduces death and stroke by 42%. And close by, another molecule we just finished talking about, 32% plus increasing stroke with empagliflozin 18%. So what are these molecules? These are basically DPI, empagliflozins out here. Now, this is basically evidence-based, whether lipid lowering, whether blood pressure lowering, everything is important. But what is more important, to choose the right drug for the right patient in right time for the right period of time. And if you continue to choose the best drug like DPI way, rivaroxaban 2.5 milligram plus small dose of aspirin, perhaps on the top of your lifestyle modification, you can make it better. You can make it 82% relative risk reduction. That is amazing. Unfortunately, we do not have any marker for these rivaroxaban plus aspirin combinations like LDL. So this biomarker or the biotargets are absent. That is the only drawback. But you have the same drawbacks for your DAPT or SAPT regime. So both are at same level of lack of evidence. And this data came from her, not from randomized clinical trial. It came from a registry, the DAPT. And this DPI is very important. Initially, we thought that DAPT is more important. Now we think that DPI or thrombin is the most powerful platelet agonist. It's very important after a few days of angioplasty, 12 months of acute coronary syndrome. When you treat a patient, we do not treat only the the molecule or the cellular level, you also treat the society as large. So in the society, if you give this molecule, you will prevent many debilitating stroke, amputation, so on and so forth. And this is the history, and the history is very beautiful on DAPT, but the history just began with the trial which has been stopped prematurely. You cannot name any DAPT trial, SAPT trial, any combination of antiplatelet trial because of its overwhelming benefit, like Jupiter, Sprint, Paradigm, Credence, Femian, DAPA, CKD, SCORE trial. You have only one trial on this antiplatelet, antithrombotic, that is COMPASS trial. And the DAPT duration, again, topsy-turvy course. So there is a confusion, but now we are moving towards shorter DAPT. Initially, we had clinical inertia. We had some kind of myths, some kind of stigma, because we have done some historical mistakes, like having BMS, having Cypher-like stent, having Texas-like stent. And when we used to put this stent, we used to prolong DAPT because of incomplete job, a wrong judgment. Now it has been much more prudent to do complex PCI with imaging. So it is just like I could not fix the brake, therefore I made the horn louder. So this horn louder means longer DAPT. Definitely this imaging helps, you see better. Now many people still live in medical tribalism. That means they still believe nothing can replace DAPT. We are a special group, needs preservations. We are indispensable. We are the gospel truth. DAPT is the only truth. That is not true anymore because you have evidence from COMPASS trial that it reduces CV mortality, all-cause mortality. So that is beyond any doubt. Whatever may be the number is excellent and beautiful. You have only one molecule in 2022 which has shown its beauty, whether it's vein, or there's artery, or there's pulmonary artery, or there is brain, or the atrial fibrillations. So it's a beautiful molecule. So now you have a freedom of choice to choose between 2 DAPT or 2 antiplatelet, aspirin plus ticagrelor. In this case, you have aspirin. Now, the other one is also another antiplatelet, that is clopidogrel, prasugrel. But you should go for the best, that is Pepsi or the rivaroxaban. If you have more risk factor, you gain more. And this benefit is usually disappears, ticagrelor versus placebo from trimestral at 6.5 years. So beyond this period, what takes the upper hand is the DPI. And we bleed more, and we bleed more on DAPT. So East bleeds more than West on DAPT than DPI at the cost of ischemic risk, but the ischemic risk is very small. So I would prescribe DAPT. Many patients face this kind of rapid CV, sometimes like appendicitis, fracture. This emergency situation is much easier to handle than DAPT. Now, this is a trial which is controversial. If you bring down your LDL, which we very often do, bring it down to 40 or 50, 55. If you bring it down with ticagrelor, you bleed more. If you bring it down to 54, perhaps that is the threshold. So you bleed more on ticagrelor with lipid lowering. Again, this is new information. So Japan, they do not use ticagrelor at all. They believe clopidogrel. So after the master DAPT, we are moving toward SAPT single-handedly. But if you move, if you really want to go fast, go alone. If you want to go further, go together with a little boy, a little elephant, that is rivaroxaban 2.5 milligram. These benefits accumulate over time. So you go longer with this molecule. So if I want to finish here, for those who believe no explanation is necessary, for those who do not know explanation is possible. I'll finish with a short story that world champion relay race final. The US 4 girls were favorite, and they were one person who won 100-meter sprint, another one 200-meter sprint. So the odd was in favor of US, 43.59 and 44. But at the end, if you see that the blue represents French moving with the baton, ultimately the French team wins this relay race. But how they won? Look at her legs is as good as US, but look at the change or handover of baton and the strong command. So handover was excellent and beautiful. You can argue with the future, But for me,
Just 1 minute.
then you perhaps going for path of immortality. So DPI is the only way to go. Thank you for your kind attention.
Thank you, sir.
Now, Dr. Hemang Bakshi.
Okay.
Dr. Hemang Bakshi.
Yes. Good morning, everybody. Am I audible?
Yes, but screen.
Yeah.
Your slides. Dr. Hemang, your slides are not visible.
Yeah.
Now, yes.
But you are not seeing, Hemang.
Yeah. All right. We'll start the video. So, thank you, organizers, CardioCon, Dr. Kamal Sharma, for inviting me for this nice debate, and thanks, Dr. Hazra, for attractive talk. Now, I will discuss my viewpoint on ticagrelor 60 milligram BD with aspirin in this patient. Just a minute. So we know the patients, right? He is having multiple risk factors, has got stroke 4 years back, and has got multivessel PCI, and has got inferior MI before 1 year. I would have loved to have some further details like EGFR of these patients, what are the ongoing medications, does patients have PAD, and what was the type of the stroke the patient suffered from. But anyhow, let us discuss the science. I don't have those beautiful pictures, but I will stick on to the science. Whether there is a need for long-term ischemic protection post-MI, and how does the long-term ischemic risk rise? And if you look at the various data, the REACH registry shows that there is in patients with in the patients with ischemic events, there is quite high long-term risk of ischemic events, further ischemic events over 48 months. And this is the Apollo registry, which showed that approximately 20% of the patients had the risk of subsequent MI following 1 year of myocardial infarctions over next 3 years. And this is the placebo arm of the Pegasus trial, where it was observed that the MACE incidence was 15% up to 72 months after myocardial infarctions. And this risk lasts and continues up to 7 years in this IMPROVE-IT trial. What about the patients with complex PCI patients? We know that patients who had undergone complex PCI, they have got significant high rates of MACE, MI, and stent thrombosis over a period of time. So these are the patients which have got a significant residual risk, and we need to do something. And we have this DAPT study which showed that the reduction in the ischemic events was significant when this clopidogrel was given for long term up to 36 months in these patients. And this is the results of the, this is the Pegasus TIMI study, which studied patients more than 50 years with history of spontaneous MI 1 to 3 years prior to enrollment, and at least one additional risk factors, that is age more than 65, diabetes, second prior MI, multivessel CAD, and chronic end-stage renal disease. They were included, and they were given long-term ticagrelor. And the study, we already know the results that the long-term 60 milligram ticagrelor has got significant benefit over aspirin alone when it is given beyond 12 months. And this reduction in MACE is complemented by individual endpoint reductions, that is CV death, MI, and stroke significantly, as you can see over here. Major bleeding was expectedly high in ticagrelor 60 milligram arm, but the fatal bleed or ICH were similar between these two arms. And most important thing to remember is that the greatest benefit of this ticagrelor is when it is initiated within 2 years of prior MI. So earlier initiation of ticagrelor gets benefit. As you can see, the Pegasus TIMI 54 analysis, you can see that irreversible harm, that is CV death, MI, stroke, ICH, and fatal bleeding was significant. 14% reversal is there. And that is why the guidelines have accommodated this recommendation. And you can see that ACC, AHA, as well as ESC has given class 2B indications in patients who are medically managed and not having high bleeding risk for giving ticagrelor or antiplatelet, second antiplatelet agents more than 12 months up to 36 months after MI. As you can see in ESC guidelines, ticagrelor is the clearly preferred over clopidogrel, not in the ACC AHA guideline, while in patients who has undergone PCI and they are not having high bleeding risk, again, it is a class 2B indications that this ticagrelor should be given beyond 12 months in these patients. Now, we have to identify the high risk patients who can benefit the most with this long-term dual antiplatelet agents. And these are the patients who are having more than 2 risk factors and they benefit the most. And our patient has more than 2 risk factors. He is diabetic and he is having multivessel disease. So he is definitely going to benefit more when this ticagrelor long-term is given. And as you can see, these are the risk factors. Patients which are having this, they get the greatest benefit. And if you have more than 1-2 risk factors, then the benefit is definitely going to be high. But at the same time, you have to exclude the patients who has got high bleeding risk. So this is a very good algorithm. So step 1 is you assess the bleeding risk. The patients who has got prior hospitalization for bleeding or patient who has got low baseline hemoglobin, they should be excluded. Then you find out the risk factors. If the patient has got more than 2 risk factors, then they are going to benefit the most as far as the, you can see the MACE is maximum benefit in patients who has got multiple risk factors. CV death, all-cause death, again, best in patients who has got multiple risk factors. And our patient, it fits in this criteria because you can see this, that patient has got multivessel disease. He has got diabetes. We don't know about the renal impairment. Patient is definitely not having, multiple prior MI, but with these 2 risk factors, history of MI before 1 month, ticagrelor 60 milligram BID, 3 years post, up to 3 years leads to significant 34% risk reduction in CV mortality and 21% risk reduction in CV death, MI or stroke. Now, coming to the other molecule that Dr. Hazra discussed, rivaroxaban, you can see the comparison of the trial that 100% of the patients with Pegasus TB 54 had prior MI and median of 1.7 years since their qualifying MI, while Compass trial had 62% patients with prior MI and mean of 7.1 years from their index events. Though our patients resembles more with this Pegasus TB 54 trial patients. At the same time, the MACE was definitely reduced with rivaroxaban in Compass trial, but you can see MI was slightly high, although not statistically significant, but stroke was significantly increased in these patients. And our patient also had a stroke, so we should be careful while giving this rivaroxaban in this patient. And this is the slide showing efficacy versus major bleeding with the rivaroxaban. Bleeding is definitely high, but more worrisome is that in this study, it was shown that bleeding was associated with increased risk of cancer. We don't know, it may not be causative. It may be just a coincidence, but you can see that number of cancers, new cancers, a proportion diagnosed after bleeding was much higher, whether it is GI cancer or genitourinary cancer. And the cancer was diagnosed early, that is within 6 months after the bleeding, as you can see from this slide. And the author's conclusion was that among Compass patients with vascular disease on long-term antithrombotic therapy, more than 1 in 5 new diagnoses of cancers are preceded by bleeding, and GI bleeding and GU bleeding are powerful predictors of new GI and GU cancer diagnosis respectively. More than 75% of these cancers are diagnosed within 6 months of the bleeding event, and this should be kept in mind, and you should be careful for that. So in summary, epidemiological studies confirm that our patients with prior MI remain at high risk of major adverse events up to 5 years after the event. DAPT with ticagrelor 60 mg per ASA reduces this risk, but at the expense of increased major but not fatal or intracranial bleeding. and a simple patient selection algorithm in which patients' predictors of high bleeding risk, that is anemia or prior history of major bleeding, are first excluded, and then the remaining patients are stratified according to the number of ischemic risk factors, may be useful to identify patients more likely to derive greater benefit from treatment with ticagrelor 60 mg per aspirin extended beyond 12 months. Thank you very much.
Thank you, Dr. Hema.
Now the house is open for discussion. If there are any questions from anyone.
I think I would not a question, but just making the thing more simpler, that platelet is the cornerstone of the treatment, means antiplatelet agents. Now adding the something which is going to affect the coagulation cascade, that is a rivaroxaban, whether it is going to benefit, it is a very attractive hypothesis. But as Dr. Hemang Bakshi already in his lecture said, that there is increased bleeding risk naturally because you are going to block the platelet and coagulation cascade both. And every bleeding risk is within few months is going to be diagnosed as the malignancy. So that is, I think, is again a matter of concern, but I think there are more light should be thrown on this aspect if anyone else can do that.
Yeah, I think the bleeding, he has rightly mentioned, that goes in favor of DPI regime rather than going in favor of DAPT is sometimes a blessing in disguise. If somebody is on DPI, as he has rightly mentioned, you pick up more GI cancer or your urological cancer, bladder cancer earlier, because you will be putting them on cystoscopy, upper GI endoscopy. So if you pick them up early, so it's a kind of blessing in disguise. And second, somebody who is living in a rural area, and he has a hematuria, and on the telephone, if you ask you, doc, I'm having hematuria bleeding, I'm on DPI, one patient, another patient is DAPT. If you ask them to stop DPI because of short-acting rivaroxaban, he is actually protected from the very next day. But on the other hand, which is ticagrelor regime, that he is not protected for 5 to 6, 7 days, as I have mentioned. During emergency surgery, somebody who is on DPI is much simpler to handle than the DAPT, CABG, or appendix, or a ruptured gallbladder. So these people are much more safe to deal with surgical emergency. So definitely I'll go for DPI.
But sir,
basically, if you talk about this particular patient has got multivessel stenting, patient has suffered inferior wall MI before 1 year, patient is having multiple risk factors. So in this particular patient, Dr. Hazra is right that rivaroxaban is a good molecule, but I would, I would be hesitant in giving these patients who has got multiple stents to give. I would prefer to give antiplatelets rather than anticoagulants over a longer period of time. And rivaroxaban, I would say that it's a good molecule, but in patients with chronic coronary syndrome, or patients who are low risk for post PCI, in those patients, it's a good option. But in this particular patient, we should be giving ticagrelor.
I think fantastic talks, both of you. The point was to drive that the Pegasus data is driven primarily by patients who have had MI, which this case has. Stroke is something which is significantly reduced by rivaroxaban, not so much by ticagrelor. That was the other tilting point for the rivaroxaban, and MI was the tilting point for ticagrelor. That's why the whole debate. And we do get scenarios like this, but now we have evidences emerging even for acute stroke for ticagrelor. But remember, there the dosaging is 90, not 60. So that was the another highlight to bring out. I think both of the speakers did fantastic deliberation on this. But I would just ask both of you, if this patient had, suppose, another episode of TIA, what would be your next strategy? If he had a TIA, what would happen to the two therapies that you're giving? First, Dr. Hazra, and then Dr. Bakshi.
I think you have nicely mentioned the stroke is the outlier. Pegasus did not have any stroke patient, so he doesn't fit into Pegasus-like patient. If I want to choose my death, I'll never choose stroke. I never choose dialysis. I'll never choose cancer. Rather, I want to die from acute myocardial infarction, which is painless death. So stroke is devastating not only for yourself, for the whole society and the family sometimes. So stroke is important. If you have a stroke, you have 80% reduction in the another stroke. So if somebody was on DPI, I wish he is taking the medicine, the chance of getting another TIA is very low. If he gets a TIA, you have to investigate again the carotid and the other sources of embolism. And you can go for ticagrelor for the brief period. And later on, when the things are getting nicer, you can go back to DPI. Thank you.
I think Dr. Rajiv Agarwal wanted to make a comment. I think.
Yes, I'm sorry. Thank you. I'll say two simple things in just less than a minute. Once the atherosclerosis moves out of the heart, you tilt towards DPI. If it is confined to heart, it is simple DAPT. But if you look at the COMPASS intervention data, about 1,000 patients, that also favors in PCI, multivessel disease confined to heart, a DPI. That is another subgroup analysis. Of course, it is not a double-blind, placebo-controlled trial. So I'll say I'll go more for DPI than DAPT. There is no mortality reduction with DAPT. That is one thing which attracts me.
Right. So it's like a pimple. You get pimple on your face, pimple on your back, pimple on your neck. So it's not restricted to always on the heart. Thank you, sir.
So thank you. Brilliantly said. And your talk was brilliant and with lots of good examples, brilliantly presented. Very nice talk. Thank you.
Thank you, sir.
Thank you.
So I think we'll go for the subsequent session. This is bout number 20. Next session is bout number 20. This is the last session before lunch. This is on lipidology. And I would like to invite Dr. Kamlesh Upadhyay, Dr. Dhiren Joshi, Dr. Vijay as chairperson, and co-chairpersons are Pankaj Talokar, Kinjal Bhatt, and Dr. Atul Parikh. I would like to request Dr. Dhiren Bhai to kindly introduce speakers.
At the outset, I congratulate and thank Dr. Kamal for giving me the opportunity and organizing such a fantastic conference in which every clinical situation is put in a question and multiple options, and then coming to a conclusion in a physician's perspective. This is really a good design of this trial, and really I congratulate Kamal for that. Now coming to the bout number 20 regarding the diabetic dyslipidemia. I invite the first speaker, Dr. Praveen Chandra from Delhi. He is MBBS, MD and DM cardiology. He is chairman of interventional cardiology at Medanta Medicity, Gurgaon. He has been awarded for success and achievement in the field of medicine with Padma Shri by the President of India. Also served as a director of cardiac cath lab and acute MI service at Max Hospital. He is a consultant cardiologist at Heart Institute. He is a fellow of Endovascular and Interventional Society of India.
Thank you.
He is distinguished faculty member in various international meetings. He is the organizer and director of AMI course held in New Delhi from the year 2006. He has published ample of articles, reviews, and abstracts in various prestigious national as well as international journals. So, Dr. Praveen Chandra. Second speaker.
Dr. Atul Bhai, you can introduce another two speakers, Dr. Rajiv Agrawal and Dr. Ramesh Goel.
Atul Bhai.
Dhiren Bhai, you can only introduce them.
Hello. Am I audible now?
Yeah.
Yes, Atul Bhai, please go ahead.
Yeah. Please, Atul Bhai. Please go ahead.
He chairs the Department of Cardiology, I'm talking about, and he works equally in preventive and invasive cardiology. He has deep interest in the vascular biology. His department is bigger referral base in India. He was awarded Amar Ujjan National Excellence Award. He is inspiring doctor for India and health icon facility for lifestyle server by the Times of India, and he has literally excellence honor by 2018 by Bharat Nirman, a private NGO since 1980. The third speaker is, can I have the data of the third speaker, please? Our third, hello. Dr. Rajesh Goel from Apollo Ahmedabad is MD/DM Endocrinology, Senior Consultant and HOD Department of Endocrinology and Diabetes at Apollo Hospital. He is a faculty at so many places. He is a former member of the National Advisory Board of Indian Journal of Endocrinology and Metabolism. He was awarded as Best Diabetologist in 2018 and Best Endocrinologist in 2018-2019 in Ahmedabad, Gujarat by Times Health Icon, conducted by Times of India. Thank you, Jayesh bhai.
I want to share my screen if you allow.
Please share, sir.
Thank you, Dr. Kamal, especially, and all the organizer for taking me in on this very important aspect, which is very close to my heart. I think nature is kind. I superseded Praveen Chandra because anthropologically speaking, agitamide came earlier than PCSK9. So if you look at evolution, agitamide should be talked earlier than PCSK9. So I think everybody remembers the case. This is a very interesting case. This is a very interesting case. I think you have not shown the case. Can somebody put the case on the board? Because I have to build up the case.
Dr. Rajiv, I think I have the case on my slides.
Sure. So Praveen, you can come in. You can come in first. Yeah. That's
okay,
very important.
So you can unshare the screen. Unshare the screen.
I'm doing that.
Thank you.
Thank you.
Okay, so here is the case. Okay, now, okay, fine. So thank you, Dr. Rajiv, and thank you, Dr. Kamal, and all the colleagues there in Gujarat, and for this very interesting program on discussions and debates on various day-to-day issues. So here the issue which is in front of us today, that this is a patient who is 57 years of age. He is a diabetic. He has a LDL cholesterol of 112 on rosuvastatin of 40 milligrams. He had a previous PCI about 8-9 months back to RCA, and he has a strong family history of CAD. And now, after the angioplasty of RCA about 8-9 months back, he comes with a new acute coronary syndrome. And this time they find that the LAD is progressed and it is about 99%. So of course, he is going to undergo intervention, which is without any delay. But now we are going to discuss about his control of statins and protection for future events. How do we do that? Okay, so now let me take you through this case. So now I think everybody will remember this case. And the question here is, what should be the target here for the LDL cholesterol? Whether you should blow it down, how do we do it, and when do we do it? All these questions. And so in this series, what I'm going to share with you a little bit of why it is important. Because lipids are the most critical modifiable CV risk factors for acute myocardial infarction. So this we have recognized for a very long time. And here we have this data from many studies. And also LDL-C, which is the building block of atherosclerosis, has to be, so this we have to really strike at the bottom of the whole pyramid. Otherwise, we are not going to gain much benefit. So the data from the CTT meta-analysis showed that the major vascular events versus absolute LDL-C reduction, here you see that there is a constant slope which is there. And this is from the 5 trials. And this is like, very, very, I must say, pivotal to establish this concept of bringing it lower and lower. But when we did that with the, bigger, more trials, the ideal trial, the TNT, prove it, everything, and all of it showed that yes, if you give high intensity statins, it does reduce events. But what happens? What happens is that we still have some patients who will have events. So it comes from 26 to 22, from 13 to 12, from 10 to 8, but it doesn't come to 0. And what we require is that we want to bring it as low as possible. And if you look at this data, nearly 1 in 5 patients will have a recurrent CV event during the first year post-MI. So why are we delaying things? We have to do things faster. And here you look at the ischemic risk. At 30 days, it is greatest. So post-MI patient, 30 days, the risks are greatest. And within 1 year, the event rates are so high. So the question here is very, very pertinent that, of course, we have to start doing something faster, something earlier. And this is the monotonic relationship between LDL cholesterol and major outcomes. And you look at this. LDLC less than 20, 10% patients had LDLC less than 20. And it shows that there is no safety concern, even if the LDL goes below 45, 50, or comes to 20. So based on all this information, we had the new guidelines. And here we have started looking at the new things, which is the very high risk profile of this patient. So our patient, which was given to us today, falls into the very high risk category. And beyond that, there are additional risk factors in this case. And if you look at this guideline, that in this patient who is at a very high risk, a combination of PCSK9 inhibitor therapy starts coming into the picture. Why? Because he has very high risk, he has acute coronary syndromes. And if you look at this information, that this patient who was already on statins, high dose statins, was 40 milligram of rosuvastatin, or if the patient was 20 and that was the maximally tolerated dose for him, even 20 is the highest dose for him. And of course, this patient is not on ezetimibe, which will be discussed, but ezetimibe just becomes the second drug to be added in these patients. But we will discuss more that why PCSK9 also becomes a natural second drug in this particular situation. So PCSK9 has come to a very important stage where if the LDLC goals are still high despite maximum medical therapy, and if this patient has come within 1 year of the first intervention, he's receiving the second intervention, he starts coming into the picture of addition of PCSK9 therapy. Even if the ezetimibe has not been added, we can start that. And all this has to happen much faster than what we were thinking earlier. So this is our indoor patient. And if you look at the research of the last 25 years, 30 years, what we see is progressively we found that high cholesterol was bad, average is not good, lower is better, and even lower is even better, and lowest is best. So we have to bring down the cholesterol. And why we should use PCSK9? Because it reduces the cholesterol maximally. If you look at the 140 milligram of evolocumab given twice a month, it reduces cholesterol by 64%. Compared to ezetimibe alone, it just gave rise to 24% reduction. And if you combine it with statins, still it is lesser than PCSK9 combination. So that is the most potent agent. And we have to start thinking of the most potent agent in this particular very high risk situation. So PCSK9, as you all know, I won't go into this, that it just prepares the LDL receptors. It stops the interaction of PCSK9 to LDL, and the LDL particles removal, which happens through these receptors, is enhanced, and the LDL reduction starts very quickly. Within 2 to 3 doses, we get a steady state. So which means the action starts rather fast. And the dose is, as most of you know, 140 twice a day or 420 once a day. And this is the average reduction of cholesterol. When we combine high intensity statin with ezetimibe, it comes to about 6. High intensity statin, it comes to 75%. And when we combine all the three, it is 85%. So this is the particular situation where I think this patient will require all three of them. So it is not that I'm saying PCSK9 alone. Ezetimibe also should be added to this armamentarium for this patient. So the evidence started from chronic coronary syndromes from the Fourier trial, which was the most important, but that is not pertinent to us right now. The most important thing is the subset of patients from Fourier trial who were high risk and who get the maximum benefit. And these are the patients who are high risk, qualifying MI less than 2 years. So our patient is in this category of less than 2 years. You see the benefit is maximum. So we have to use this. More than 2 prior MIs. Again, this patient is the second MI, falls into this category, gets the maximum benefit. So this patient has multivessel disease, again gets the maximum benefit. Although we are deriving all this information from the Fourier trial, but we can extrapolate all this information very easily onto this patient. Then the MACE event in patients with and without PAD, of course, in PAD, if the patient also has a PAD, which we'll have to find out, then this patient will definitely get benefit from this therapy. And those patients who have previous prior PCI will again have a better outcome compared to those patients who do not give evolocumab. So you can imagine this patient is a very high risk patient, and all these patients who are previous bypass surgery, complex PCI, and complex revascularization get more benefit when PCSK9 is added to this patient, to this therapies. And of course, the safety of this therapy has been established quite well. And the safety events has been also adjudicated and found to be much safe, and there's no issues in terms of safety of adding this therapy to our patient. Then go to the acute coronary syndrome subset of patients. And if you look at the acute coronary syndrome subset of patients, the first trial which comes in the picture is EVOPAX. In this study, where these patients came with unstable angina, less than 24 hours, and here or less than 72 hours of ST elevation MI. This was patients who were given evolocumab in the hospital. And look at the change in LDL levels at 8 weeks. It was substantially different. P-value was significant, less than 0.001. And the reduction of LDL was very, very consistent. In the EVAC study, another study for acute non-ST elevation MI, given evolocumab in the first initial hospitalization, LDL reduction was quite significant and rapid. At day 1, between day 4 and 7, it was 60%, and at day 32%. So you can imagine how fast and how quick we are able to protect this patient from a second event or any other untoward incidents. So guidelines recommended LDL-C targets applicable to ACS can be achieved in most patients at hospital discharge and can be continued. And this is the level of small. If you look at the with evolocumab and without evolocumab, the difference is quite significant. LPA levels reduction is also quite significant. So basically, adding PCSK9 becomes a reasonable strategy for patients coming with multiple events like our patient, recurrent MI, recurrent interventions. All this falls into this category. Then risk for non-culprit related recurrent MI was that twice that of culprit related recurrent MI over a long period of time. And here you see that it was actually the non-culprit vessel which has come, and that is why it is important to treat these patients much more effectively. And there are many studies, intravascular ultrasound guided studies, and then of course showing that lowering LDL and plaque regression is hand in hand. So if you reduce LDL, it really makes a difference, even angiographically or intravascular ultrasound wise. This is another study showing lipid core burden index going down in quite significantly if you give PCSK9 therapy to these patients. And the OCT trial also showed that the thin cap fibrous atheroma, which is the culprit, is also treated well if you give them PCSK9, because in this study they showed that the cap becomes thicker at 12-week follow-up, which means the chance of having MI is reduced. And that is what we are interested in. And many other studies like this angiographic study also showed that the vulnerable plaques can be stabilized after ACS if they are given therapy with evolocumab over an initial period and then continue. So we can modify this residual risk by adding this therapy, and it has been shown. So the 3 concepts of lipid lowering strategies to reduce events is start early, treat much more aggressively, and use combination therapy where PCSK9 and SDMI both are to be added. definitely in this PCSK9 definitely should not be missed out. And based on the all the evidence which we have, LDL-C should be lower, the better, and it should be less than 55. And in this patient, it should be less than 40, and it should be started in the hospital. One should not wait for 4 to 6 weeks in this patient, and the effect on LDL-C should be checked at 4 to 6 and also at 4 to 6 weeks as to what is the situation. And the lipid core burden index, the fibrous cap, everything improves, and the 5-year safety data of this therapy is available. So one should not worry about giving this drug to our patients. So this is the group of patients in my practice who will be benefited in
the last 1 minute.
Giving PCSK9 disease and multiple interventions like we see in this patient. So to just summarize, PCSK inhibitors are proven and better strategy in recurrent MI, recurrent coronary interventions, and of course in patients who are having uncontrolled high cholesterol levels despite highest dose of statin therapy. Thank you very much.
Now, Dr. Rajiv Agrawal, sir.
Thank you, Dr. Praveen, for presenting such crystal clear evidence for PCSK9. I think I have to move forward in a very simple mathematical way, how I look at the case. This reminds me of a very famous quote from Alvin Roth: disease is more expensive than health. And you can imagine a patient having a repeat procedure is a bigger health burden and emotional burden. I'm very emotionally upset with the natural history of the disease in this patient on account of social reasons and account of clinicians inertia who may be an interventionist or a clinician or a clinical cardiologist. My take on this patient is there is a family history. The patient was on high intensity statin, and the consultant was not aware the difference between high intensity statin vis-a-vis high intensity lipid lowering therapy. So I call it is inertia versus ignorance. I'm not aware whether the lesion was existent in the artery before or it is a de novo LAD disease. By no stretch of imagination, a patient who is post-angioplasty should in follow-up have an LDL of 112. It is gross inertia versus ignorance. The baseline LDL 257 reminds me of reduce it, which was not practiced in this patient. There is a very famous table, if you want to go through, which is available from Dutch Lipid Clinic Network score, where you can calculate the current statin dose and a multiplication factor to decide the baseline LDL. The baseline LDL with multiplication score of 2.3 into 40 milligram of rosuvastatin calculates the LDL of 257, which is alarmingly very high. The LPA is 60 milligram, repeat procedure in less than 1 year, no mention of CRP and BMI in a patient who has recurrence of disease. HbA1c is 7.4. My patient is diabetic, and I'm not aware whether my patient is a part of polyvascular disease or a coronary artery disease. With this background, let me profile you the IMPROVE-IT trial in brief. Ezetimibe, when used with simvastatin in IMPROVE-IT, showed a mortality reduction of 5%, absolute mortality reduction of 5%. No intervention, medical or surgical, has shown absolute risk reduction of 5% in diabetics. So let me say it is a dictate that ezetimibe should be used in every diabetic patient. If You look at the polyvascular disease, which is referred by Dr. Praveen Chandra also, you find that as the LDL goes down as low as 55, first time in the history of LDL lowering, there is a continuous reduction in events and mortality. If you have polyvascular disease, you do better. The event rate is more in polyvascular disease. Not only first event, but multiple events when taken into consideration, there is progressive protection. So let us forget about the first event. There is a marked reduction in total event. Reduce it like we talk this phenomena in newer heart failure trials. As the disease burden increases within the heart from single vessel to multiple vessel or triple vessel, the outcome improves. So more the atherosclerotic burden inside the heart or outside the heart, the outcome improves. If you have a polyvascular disease with diabetes, the absolute risk reduction of 9% over a period of 7 years, giving an NT of 11. Once again, if you have patient like this, there is no intervention which gives this kind of absolute risk reduction. Another thing which was very important outcome of this trial was there was no glucogenic signal. So for the first time, we learned that non-statin drug works and they work with better safety. That means they are not glucogenic or diabetogenic. Then I must, in the same breath, continue to extend it to newer hopes. And this is a research study which shows that if you combine generic rosuvastatin and ezetimibe, unfortunately, PCSK9 is not generic. The two molecules which I am talking, they are generic, they are cost effective and improve the compliance. Then the LDL less than 70 is achieved in 80% of patients when combined with ezetimibe vis-a-vis 30%. So it almost doubles the patient population, which brings down to significant level of LDL. This is another way to look at it. When bempedoic acid is combined, again, there is 90% patient achieve less than 70%. I'm taking it PCSK9 versus oral therapy, cost versus less cost. And not only this newer drug, this bempedoic acid is not diabetogenic. So the two things which are very important with bempedoic acid and ezetimibe is they're both non-diabetogenic. They both decrease CRP on top of each other. So if the patient has got inflammation for the cause of recurrence, I think they are the very good drugs. Where to go? Like this patient has an event within 1 year, so we have to achieve 50% or less than 1 millimole as per European guidelines. This is our paper in clinical lipidology. We talked less than 30, which is a 4-year data in extreme risk group if the recurrence happens within a year. So this qualifies for extreme risk group category B. And if you look at guidelines, ezetimibe on top of statin is 2A because we have only one trial. If you combine PCSK9 with the statin, ezetimibe, this is class 1A indication. But if you combine statin or PCSK9 without having ezetimibe, the indication goes down to 2A. So I'll say it is a mandate to combine high dose statin and ezetimibe, then think of PCSK9 if you are not achieving the ideal ultra low level of LDL. This is the latest guideline which has come from Middle East, which is very, very visual and impressive to look at. As the risk category goes down, the values for LDLC, non-HDLC goes down. So another way to look at it, but it is very, very visual to understand. One thing which is very important and we should carry home, that if you reduce the LDL 50% or more, the residual risk is almost same, irrespective of the baseline LDL level. So we should know beforehand, once we are starting a lipid lowering therapy, that we have to achieve at least 50%. And if you achieve 50% LDL reduction, the residual risk is not much different in different classes. That's why I say it is a mathematical equation that how much LDL you have to receive, 50% or less than 1 millimole, whichever is lower should have been the target in this patient. And that is why I feel there is a lot of inertia and ignorance on the part of clinicians who are treating this patient. I will think in this patient because it's a very high risk, upcoming concept of zero LDL hypothesis. How do we achieve? We know diamond approach in hypertension. We know diamond approach in heart failure. We know diamond approach in chronic stable angina. I think we should start thinking on diamond approach in lipid lowering therapy. I am trying to make it simpler what Dr. Praveen showed, that high dose statin vis-a-vis with ezetimibe is always almost similar to PCSK9 alone. So if you feel that 60% reduction of LDL in your patient will amount to 50% reduction of baseline LDL, I think PCSK9 is out of picture to begin with. If you feel that will fall short of your need, then naturally PCSK9 should walk in and should walk in as early as possible. That is how I can make it as very simple. So once again, if 60% reduction in LDL is the need to achieve 50% LDL reduction, you should not think of PCSK9. If you feel you will fall short of that, then PCSK9 should walk in on board as early as possible. Another very fascinating study which has come very recently, that ultra low level of the high level of LPA, only they make a difference when you have achieved LDL less than 70. If your LDL is more than 70, the LPA does not play that much of a risk role. Because LDL is a bigger factor to challenge. If LPA is less than 70, higher LPA translate into higher events. And that is what I am trying to show, that if the LDL is achieved and your LPA is high, then these patients are better off with LPA lowering therapy. Why I am talking this will be clear to you in next slide. Let us imagine a patient who is achieved 70 milligram LDL with statin and ezetimibe, is still falling short of LDL goal. CRP is high. I'll probably choose bempedoic acid in this patient. If my patient is a statin ezetimibe is still 70 and LPA is still high, I will choose PCSK9 because both the drug on the left side, they are not LPA lowering. And fortunately, ezetimibe, bempedoic acid, and PCSK9 are not glucogenic. So they are good drugs to use in diabetic. As many of you must have seen, there is a concept of hyper and hypo responders to statin. We don't have SNPs to clearly define that, but you will know that there are many patients who with medium dosage drops down to 30. I call them hyper responders. And there are some patients who do not respond that well. So don't feel discouraged and try to see how the genetics play in these patients. And many of your patients with moderate intensity statin and ezetimibe will drop down to 70 and they are hyper responders. And I'll say it is good idea to wait for 4 to 6 weeks before starting statin PCSK9 to see whether your patient inherently is a hyper responder or not. I am a strong believer in regression of atherosclerosis, and I want to pass on this message to my colleague. Believe in this concept. It is the best medication for your atherosclerotic patient, and recurrence so early is lot of inertia. It must be embarrassment to the clinician that why my patient is coming so early in the natural history. Within a year, I did less than what I should have done. I coined a new term that we need now metabolic interventionist
who can tame lipids and diabetes with perfection, because these are the patients who are benefited most by these interventions. So I feel, let us not feel belittled that I am an interventionist, I am a mechanical cardiologist, I don't understand metabolism. I'll say, you are not an atherosclerotic expert, which you should have been. So I'm just showing you some images. This is 6 weeks of aggressive lipid lowering. IVUS images, you can see in B2 image, there is almost no lipid core. And this is 6 weeks. So believe in lipid lowering, they stabilizes, they regresses. And this is a recent hygiene study which showed that these drugs, evolocumab, PCSK9, can increase the fibrous cap thickness and make your plaque stable. Nobody dies of chronic stable angina. Everybody dies of acute coronary syndrome. So one of the aims of lipid-lowering therapy is converting ACS into CCS and ultimately eliminating. So Shakespeare wrote long back, what is in the name, that which we call a rose by any other name would smell as sweet. I'll modify his quote by saying, what is in the name? It is statin, azetamide, PCSK9, bempedoic acid, whatever it is all in the numbers and cost and compliance. So let us not make it again about as you have named it. I'll say we have to make a judicious choice of these molecules. Let us move ahead from boxing debates like we had CABG versus PTCA. Let us start combination therapy like hypertension and diabetes as early as possible in the natural history of the disease. Let us believe atherosclerosis is a metabolic disease, not a mechanical disease. And I feel we need newer generation of metabolic intervention cardiologists, and we should not believe in artery cleaners, a 1-hour job. And this is what William Osler must have said today. A good physician treats stenosis, a great physician treats the atherosclerosis. Thank you very much.
Now, Dr. Ramesh Goyal. Dr. Ramesh Goyal.
Good afternoon, friends. Both the interventional cardiologists have debated with each other, and in that process, they forgot that this is a triangular contest. And Dr. Rajiv has made my task very easy by saying that there is a need of a metabolic interventionist. And yes, metabolic interventionist is here to present his data on the diabetic dyslipidemia in a context of the patient which we are discussing. So first of all, when we talk about metabolic abnormality linking cardiovascular disease and type 2 diabetes, there is a link between insulin resistance and various metabolic conditions we should not forget. And the classic slide is the YY hypothesis. The YY hypothesis says that at a equivalent BMI, the body fat content in Asians is much higher than the body fat content in a Caucasian. So here you can see Professor Yudkin and Professor Yagnik both are having same BMI of 22.3, but look at the body fat distribution. In Caucasian, it is 9%, and it is more than double in the Indian person. We Asian Indians have low insulin sensitivity compared to Caucasians. So here on the left, you can see insulin sensitivity index, and on the y-axis, you can see the total body fat mass. So at any total body fat mass, the insulin sensitivity index for we Asian Indians is lower than the Caucasians. And similar correlation is seen between insulin sensitivity index and sum of truncal skin fold thickness. Insulin resistance is a common link for various metabolic conditions. So here you can see insulin resistance is a common pathogenetic mechanism for type 2 diabetes, and we all know prevalence of type 2 diabetes in India. We have more than 7 crore of diabetic patients in our country. We have a unique atherogenic dyslipidemia profile, and insulin resistance leads to high triglyceride, which can cause CVD. So the prevalence of hypertriglyceridemia in our cardiac patient is as high as 34.2%. And unfortunately, none of my cardiology colleagues even bothered to look at the triglyceride value of our patient, which was more than 300. And NFALD, insulin resistance leads to diabetes and is major risk factor for NFALD. So I will focus more on atherogenic diabetic dyslipidemia. So how does the atherogenic diabetic dyslipidemia influence various lipid parameters? So insulin resistance is associated with elevated triglyceride, and elevated triglyceride leads to increased free fatty acid levels in plasma, leading to hypertriglyceridemia, and ultimately it leads to low levels of HDL and high levels of small dense LDL. And this is the pattern of dyslipidemia, which is different in India compared to globally. So here you can see most common dyslipidemia pattern we see are low HDL followed by high triglyceride. Now let me talk about hypertriglyceridemia, which my cardiology colleagues they conveniently ignore. Elevated triglyceride is a major risk factor for cardiovascular disease, and residual cardiovascular disease risk remains in patients treated with statins, and triglyceride is one of the risk factors which should be kept in mind. So whether we are talking about the heart prevention study or the CAD study, you can see that despite optimal statin therapy, there was significant residual risk, and residual risk was in tune of 70 to 80%. Now I will quote this body 2D study. There is association between triglycerides and residual cardiovascular risk in patients with type 2 diabetes and established atherosclerotic cardiovascular disease. So here in this 2000 plus patients with type 2 diabetes and CAD with a mean baseline triglyceride of around 180, and the primary composite outcome was time to cardiovascular death, MI or stroke, and secondary outcome was cardiovascular death, and with mean follow-up of between 4.5 to 5.5 years. So here we can see higher triglyceride is associated with higher cardiovascular risk in diabetic patient. So on the right side, you can see every 50 mg% increase in triglyceride level was associated with a significant increase in the cardiovascular events. I will quote another study, the pre-diamet study, where remnant cholesterol and triglyceride, but not LDL cholesterol, was associated with incident cardiovascular disease. The trial population was around 7,000 high-risk patients for cardiovascular disease, like a mean age of 67 years, BMI of 30, and 50% of them with diabetes. Median follow-up was around 5 years, and total MACE incidents recorded were around 265. So these are the results, and the results shows that the remnant cholesterol, the triglycerides, and the non-HDL cholesterol contributed significantly to the cardiovascular events as compared to the LDL cholesterol levels. And here you can see, if you categorize the patient with a triglyceride of more than 150 and HDL cholesterol of less than 40 in men and less than 50 in women, then you can see the hazard ratio was 1.5 times higher for cardiovascular events. So triglyceride, non-HDL cholesterol, remnant cholesterol, and even atherogenic dyslipidemia, that is high triglyceride more than 150 and low HDL of less than 40 in men and less than 50 in women, were associated with increased major adverse cardiovascular events. But LDL cholesterol was not associated with incidence cardiovascular disease. The big study showed the 22-year mortality risk for patients with severe hypertriglyceridemia was increased by around 70% when compared with patients with low normal triglycerides. So here you can see as the level of triglycerides starts moving beyond 150, there is increased risk of the cardiovascular disease. Now, $1 million question, does reduction in triglyceride reduce the cardiovascular risk or cardiovascular mortality? So I will show some data, the cardiovascular outcome data for triglyceride lowering drugs. First was the field study, 2005. Baseline TG was 155. Fenofibrate did not significantly reduce the risk of primary outcome of coronary events. The second was Accord study, 2008. Baseline triglycerides slightly higher, 162. After a mean follow-up of around 10 years, fenofibrate did not show any cardiovascular mortality benefit versus placebo. But in subgroup analysis, fenofibrate therapy effectively reduced cardiovascular disease in participants with triglycerides of more than 204 and HDL of less than 34. And in REDUCE-IT in 2019, baseline triglyceride was still high, around 216, and after follow-up of 5 years, EPA significantly reduced cardiovascular events compared to placebo. So cardiovascular death was reduced by 20%, MI 31%, and stroke by 28%. So if initial triglyceride is high, lowering the triglyceride has shown to result in the cardiovascular mortality and morbidity benefit. So critical importance of high triglyceride reduction is endorsed by ESC 2019, and here they have quoted that in high-risk patients with triglycerides between 135 to 499, despite statin therapy, the N3 PUFAs like icosapent ethanol should be considered in combination with statin. And the American Association of Clinical Endocrinologists 2020 says that patients with triglycerides between 135 to 499 treated with maximally treated statins who have CVD or DM. So our patient has both, our this patient, plus more than 2 cardiovascular risk factors should receive IPE to prevent the atherosclerotic cardiovascular disease. So what should be the ideal approach to manage diabetic dyslipidemia? So here I am quoting the anti-diabetic medications and the medication used for treatment of dyslipidemia. Each of these drugs are acting on insulin resistance, the root cause of diabetic dyslipidemia. So the answer is only metformin and the glitazone. The second question is, which of these drugs have dual action on both insulin resistance and high triglyceride for management of diabetic dyslipidemia? And the answer is none. So I will talk about saroglitazar. Saroglitazar is a new chemical entity from India, and it is a dual PPAR gamma and PPAR alpha agonist, and more action on the PPAR alpha. So it has a primary effect on the PPAR alpha, and it improves the plasma lipid profile by this biochemical processes, and it has a secondary effect on the PPAR gamma, and by this action it has a beneficial effect in insulin resistance reduction and glycemic control benefit. So saroglitazar improves glucose metabolism and insulin sensitivity index. So here you can see it is an insulin sensitizer, and it improves the glucose metabolism. And these are the various parameters which are improved by saroglitazar. So here you can see it has a benefit on glycemic control, fasting plasma glucose improved, HbA1c improved, insulin sensitivity improved, and the indices of the beta cell function and insulin resistance as measured by HOMA are also improved. Saroglitazar effectively reduced high triglyceride and improves insulin sensitivity along with beta cell function, and by reducing the glucolipotoxicity, it has effect on the glycemic control and the lipid control. So saroglitazar reduces elevated triglyceride, HbA1c, and the raised liver enzymes in type 2 diabetic patients. And this is the integrated review analysis of 18 clinical studies on more than 5,500 patients. And saroglitazar effectively and safely reduced triglycerides by more than 50%, non-HDL cholesterol by around 20 to 35%, Small dense LDL was reduced by 20%. A1C was reduced by 0.7 to 1.6%. And there were beneficial effects on liver enzyme also. And before I conclude, I will talk about the uniqueness of India. And there is a word Gherav. That means encirclement. And this is a word which denotes a tactic used by labor activists and union leaders in India. It is similar to picketing. Usually a group of people would surround a politician or a government building until their demands are met or answers are given. And the Oxford English Dictionary could not find a English replacement name for this, and they had to incorporate the word Gherav itself in their dictionary in 2004, owing to the popularity of this word. So, similar as the case of Indian diabetic dyslipidemia, the Western guidelines, they are focused on LDL, but we should not ignore the fact that hypertriglyceridemia and low HDL are common in Indian population, which is not seen in Caucasian population. And if we are trying and if we follow the Western guidelines and keep on hammering the LDL cholesterol, ignoring the triglyceride and low HDL, then I don't think we are going to do justice to our patient to prevent recurrent cardiovascular events. So to summarize, insulin resistance is pathological hallmark for type 2 diabetes, but it is also responsible for major cardiovascular risk factors like atherogenic diabetic dyslipidemia and liver disease like NASH. High triglyceride, low HDL commonly observed in Indian patients. High triglyceride is responsible for increased risk of residual CVD. Saroglitazar is first NCE from India, which has shown promising effect on triglyceride, non-HDL and HbA1c reduction in real-world practice with least side effects. And saroglitazar is first and only drug in world which is approved by NFALD in India by DCGI. So thank you for patient listening. I'll stop sharing my screen.
The house is open for discussion.
Yeah,
we have
all
only
the
5
speakers have nicely given a justification to their respective talks. The one thing which I want clarification and more deliberation from the speaker is that one thing is very nicely depicted by Dr. Goel, that unless we reduce triglycerides to below 150 or 140, even though the LDL is at goal level, the risk because of the atherogenic LDL, means small dense LDL, is going to remain. So for that, triglyceride lowering therapy is absolutely essential, so as we can reduce the small dense lipoprotein even at the same LDL level. That is one thing. And second thing, anybody can comment about the pitavastatin, because pitavastatin is also, as Dr. Agarwal said, that it is we should also consider that de novo diabetes should not occur with the statins therapy. So pitavastatin has got some data regarding that it does not produce any diabetes and its role on this.
Yeah, Dr. Rajiv Agarwal was trying to counter that.
Yeah.
Yeah, please unmute. Please unmute. Dr. Agarwal, you're muted. Please unmute.
You are muted. Dr. Agarwal, you are muted.
I'm open now. I'll say, with all due regards for my strong comments, the common sense medicine and evidence-based medicine are the two different things. There is a big JACC review article. Anybody who wants can approach Dr. Kamal. I can send that. There are two different things. Triglyceride is atherogenic at the moment, but there is no data to suggest that it reduces morbidity and mortality. So let me make it very clear to my colleagues in endocrinology, triglyceride is a risk factor, but modification of it does not translate into any kind of gains. I call it cosmetic correction. Like saroglitazar is fine in correcting TGs, but you don't get anything in terms of CV outcomes. So let us make it very, very clear. We are waiting for prominent trial, which will be talking about PEMA fibrate this June 2022. and then we will talk whether the TG interventions play any role or not, like we have failed on HDL front. And the last point I want to make it, reduce it is not a triglyceride lowering trial. Reduce it, use triglyceride as a walk-in criteria, making it higher risk. There is no outcome data in reduce it, which is tertile related to TGs. So don't make reduce it as a TG lowering trial. So once again, just to summarize, triglyceride is atherogenic, but like HDL, TG lowering, at the moment, we don't have any evidence. So that is the problem. Thank you.
Dr. Praveen, is Dr. Praveen there? I have a question for him.
I can answer on Praveen's behalf if there
Sir,
is.
no, sir, how long do we continue giving PCSK9 and how long the benefit remains after giving that?
Atherosclerosis never sleeps. Exactly. So it is lifelong intervention. It is lifelong intervention.
A very costly affair.
That is something, a problem. And I'll tell you, inclisiran is walking into the market, and soon there will be price war between inclisiran and PCSK9, and we will be benefited.
Wow.
Inclisiran we should have in India by this year end.
Okay. Thank you, sir. Thank you.
I think what you were trying to bring out, Dr. Dhiren Bhai, was the best tolerability is, of course, for pitavastatin. But like this case where we are looking at a CV event reduction, probably these three therapies will do come into play. And yes, you are very right, as Dr. Goyal also pointed out, the residual risk that exists with TG. The TG risk is governed primarily reflective of TG by HDL being reflective of the small dense LDL. If your TG by HDL ratio is more than 3.5, what LDL you have actually reflects a smaller dense LDL, which behaves like 30 mg% higher than what actually it is. So if you have 100 of LDL, but if your TG
that is a very
it behaves like 130, it behaves like 140. So just don't be misled by the numbers of LDL alone. And because we can't do electrophoresis or photochromatography for defining small dense or large dense LDL, looking at TG is an important. And that way, I thought it was trying to pitch saroglitazar, though it does not have an evidence per se in a large clinical trial for an endpoint reduction, MACE reduction, but it does have very sound, robust evidence for reduction in the residual risk targeting therapy in terms of altering not only diabetes, but also managing TG and residual risk that may exist. So that way it's a novel therapy. That's why it was pitched in. But of course, we are not countering it as a therapy of CV reduction, but it does have a strong play when you have a dealing with a diabetic dyslipidemia. That's my comment.
But high sensitivity statin with ezetimibe, with saroglitazar will serve the purpose and it will be lesser costing than the PCSK.
Pitavastatin is a moderate intensity statin, so it has got a very little role in day-to-day management of aggressive lipid lowering. So that is the problem. But if you have intolerance, then today you can have pitavastatin because the enzyme set is different, ezetimibe, bempedoic acid, that kind of cocktail you can serve to the patient and get reasonably good LDL.
Yeah.
So thank you very much. I enjoyed being on with you all. I hope we had some insights into lipid lowering.
Yeah.
It was very nice of you.
Very, very clear guidelines and clear. Practically, I think all physicians are clear now that what is to be done in such a patients which is presented here.
Truly.
And that this type of patient we get in day in, day out in our practice.
Thank you, Dr. Dhiren Bhai, Dr. Atul Bhai, all speakers. We will go for lunch now, lunch break. And I think within 5 minutes time, we will again restart.
Is there any way the people sitting
5 minutes?
Sitting for
5 minutes for the lunch. That's
Dr.
great.
Kamal, Dr. Kamal, I want to make a request before you go. Dr. Kamal, I want to make a request. You should send us digital coupons for the lunch.
Sure, we will. We will.
Jayesh bhai,
I hope the
Jayesh bhai.
lunch is then real. It's not a digital lunch just showing the
No,
photograph.
it's a digital lunch.
Thank you very much.
But,
Thank you.
But
Jayesh
all
bhai,
of
let
you
us
are
start the
invited,
next session.
those who are at present, Dr. Atul bhai, Dr. Dhiren bhai, and Dr.
For this session, I invite Dr. Parul Bhatt, Dr. Anil Kulshresh, Dr. Nitin Parikh, Dr. Dharmin Balodia, Dr. Imanshu Meghnati, and Dr. Hussain Bhatia as respective moderators and chairperson. Respective chairpersons, do we introduce our speakers?
Dr. Anil is requested to introduce Dr. Bhupen Desai.
Very good afternoon. It's a pleasure to introduce Dr. Dhiren bhai. Dr. Bhupen Desai. He did his MBBS and diploma in cardiology. He did his MD PGI Chandigarh, DNB, DM, cardiology. He's a fellow of American College of Cardiology. He's a fellow of European Society of Cardiology. He's an ex-Wadia, Bombay and Nanavati Hospital. He's an ex-cardiologist, LNT, Bristol Mayor Squibb Hospital, ex-senior cardiologist at Quintless Research. He had more than 27 years of experience in cardiology practice. He is at Holy Family BSES, Karuna Hospital, Mumbai. Inspiring Cardiologist Award he got from Economic Times. So very decorated CV. So without much ado, I will request Dr. Bhupen Desai to start deliberation. Thank you. Should I introduce all three?
Yeah. Please introduce Dr. Rashmit also. And
Okay. So Dr. Rashmit Pandya is a senior cardiologist from our city, Ahmedabad. He is presently a senior interventional cardiologist at Apollo CVHF, Heart Institute SG Highway, and he has the rare distinction of having to carry the dual qualification of DM cardiology and DNB. He received a DM super specialty degree through Vijay Medical College. He is a research fellow in UN Mehta Institute of Cardiology. He has research papers, publications, and award and distinction. So, Dr. Rashmit Pandya is a very renowned cardiologist of city of Ahmedabad. Now to the next. It is again a pleasure to introduce Dr. Abhishek Rawal, who is from city of Rajkot. He is MD, DM Assistant Professor and Interventional Cardiologist at UN Mehta. He is specialized in cardiology, congenital heart intervention, interventional cardiology, and stress cardiology, non-invasive cardiology, and echocardiography. He has been at the faculty of the year at TCT Asia Pacific 2018, organized by Cardiovascular Research Foundation, Seoul, Korea. So, floor is open to start deliberation. So, case, should I read? The case is a 55-year-old male. His heart rate is 88 per minute. ABPM shows 152/98 millimeter of mercury. And his fundus shows hypertensive retinopathy grade 1. So I will request the speaker to start deliberation. What drug we should use? Yes, sir.
Yeah.
Yes.
Can you see my screen?
Yeah, we can see it.
My voice and my video is clear, right?
Yeah, very clear. Please go ahead.
1 second. I'll just make it in a slide. So we have a patient who is 55-year-old. His BP is 152/98. So BP is still uncontrolled. He's on at least 3 drugs. That is telmisartan, chlorthalidone, and amlodipine. And plus his heart rate is 88 beats per minute. So this is the background which we have. And how best to treat this gentleman. So what are the issues we have? We have to reduce his blood pressure. At the same time, we have to reduce his heart rate, because in 2022, heart rate of 88 is not acceptable. And I'm going to discuss about this. So what choice do I have? I can increase the dose of any one of all the 3 existing drugs. He's taking 3 drugs, but they are not at full dose. I can increase the dose of any one of the 3 drugs, or maybe I can increase the dose of all the 3 drugs. Or what can I do? I can add a new antihypertensive agent. What will I do? Because increasing the dose of one medication is better than adding a new drug. What does the data show? This is the data from more than 11,000 participants from 42 trials, and it says very clearly that extra blood pressure reduction from combining drugs from 2 different classes is approximately 5 times greater than doubling the dose of one drug. So this gentleman is on 5 milligram of amlodipine. I can make it 10 milligram, or I can add something new, but then I will get 5 times more better blood pressure reduction. So doubling the dose of an existing medicine does not help much. And this is large data from 42 trials from 11,000 patients. So what can I do? He's already on diuretics. He's already on calcium channel blockers, and he's already on ACE inhibitors. So can I give beta blocker? Can I give alpha blocker? Or can I give a newer CCB? That is the most important question. Now we have decided that we will give him a new agent, because we are expecting 5 times better reduction in blood pressure compared to doubling the dose of the existing drug. About alpha blocker, I'm not very greatly convinced, because ALHA trial had shown that it causes increased mortality. It can cause postural hypotension. Patient might fall down, and it will not reduce heart rate. Our target is also heart rate. What about newer calcium channel blockers? There are no convincing data. Amlodipine still remains the gold standard, and patient is already on amlodipine. So I would not like to disturb that also. So in my mind, I think there are 2 issues which we have to settle in this gentleman. We have to reduce his blood pressure to less than 130/80, which is the current standard of care. And we also have to reduce his heart rate. So what is the relevance of heart rate in the treatment of hypertension? As you can see this, look at this. Elevated heart rate is a predictor of cardiovascular outcomes. Resting heart rate, that is what we call it RHR. Resting heart rate is a predictor of adverse cardiovascular outcomes. As you can see from this slide, which has compared people with heart rate of more than 70 and people with a heart rate of less than 70. And head-to-head comparison has shown that fatal and non-fatal MI significantly increases. Need for coronary revascularization also increases in persons who have a heart rate of more than 70. And most important hard point is cardiovascular death also increases if your heart rate is more than 70. So we have to bring his heart rate to less than 70. So patients with a baseline heart rate of more than 70 have a significantly higher risk of full cardiovascular events. Heart rate is the key determinant of myocardial ischemia. We all know about it. The heart rate increases, ischemia risk also doubles up. And look at this data. This is the data of different heart rates and mortality rates in normotensive as well as in hypertensive. So let us discuss about this hypertensive patient. Look at this saffron bar. Hypertensive patient who has a heart rate of more than 80, he falls in this category. His heart rate was 88. His heart rate falls into the saffron bar. So increased heart rate causes more deaths per 1,000 patients. All-cause mortality is increased. Cardiovascular disease mortality increases, and coronary heart disease mortality also increases if your heart rate is more than 80, like this gentleman has it. And we all know that this is a large data from INVEST study, which analyzed 22,000 patients who had underlying cardiovascular disease. They were all hypertensive, and they were followed up for a period of 2.7 years. And as you can see, as the heart rate goes above 80, the hazard ratio starts rising. Look at this yellow line. This hazard ratio starts. Our patient falls into this category. So it's a significantly higher estimated hazard ratio for adverse outcomes, including death. We need to control not only his blood pressure, but also his heart rate. Higher baseline and follow-up resting heart rates were associated with increased adverse outcome risk. We all know about this. And this is the data from India. It's a paper published by our own Dr. Jamshed Dalal. And he says that resting heart rate is important. And this forum, that is this Dr. Jamshed Dalal's Asia Pacific Region Forum, recommends that resting heart rate should be considered as an independent risk factor for cardiovascular events and mortality. Country guidelines should be updated to include resting heart rate monitoring, and pharmacotherapy should be considered in high-risk hypertensive patients with elevated heart rate. Controlling blood pressure is only half job done. So how can we do this? How can we help this gentleman? Beta blocker is the key, in my opinion. To conclude my talk, because I've been allotted only 10 minutes, to conclude my talk, I would say that heart rate is a risk factor for cardiovascular mortality. Again, I would repeat, resting heart rate is a risk factor for cardiovascular mortality. It is independent of other major conventional risk factors like smoking, diabetes, and hyperlipidemia. Heart rate should be used to assess the overall cardiovascular risk, and it should guide us to provide a tailor-made therapy for our patient, like this gentleman who his BP was high and heart rate was 88. Beta blockers have documented efficacy in reducing heart rate, blood pressure, and also in improving the outcomes of patients with hypertension, including those at high risk of cardiovascular risk, like coronary artery disease, heart failure, and in diabetes. So controlling blood pressure without controlling heart rate is not acceptable in 2022. Thank you so much. I will rest my case here. Thank you. Dr. Anil, you are mute.
Thank you, sir, for giving a very decent presentation, excellent presentation rather, and very forceful. So yes. Beta blocker is the key. Now let us listen to the next speaker who will be talking about alpha blocker.
Okay, am I audible?
Dr. Pandya, yeah, Dr. Pandya. Please
yeah, Dr. Rashmi.
Hi, sir. How are you?
Very well.
Fine. Sir, I'll directly go to the presentation.
Yes, yes.
Rashmit, you look great.
Oh, thank you, sir. I would rather prefer doing great procedures. Is my screen?
Yeah. Yes, it is. Yeah.
Fine.
You can see it.
So, okay, I'll initially I'll clarify the case given to me. The heart rate was like mentioned 80 beats per minute. So if really this gentleman has 88 or 90 or something like that, I would certainly also think about beta blockers. But if the heart rate is say bit okay, bit 70, between 70 to 80, then I certainly would like to examine other possibilities, other kind of medicines which you can use in certain kind of patients. Now, I'm not going to details about these things. This is already an uncontrolled hypertension patient. We would rather not label him resistant right now because he's not on the optimum doses of all the medicines. But we all know that there are, as sir had already said, the heart rate is independent predictor. Much more is the level of blood pressure. Whatever level of blood pressure you have, even a 2 millimeter mercury decrease in systolic blood pressure would lead to a remarkable and drastic decrease in the heart disease mortality and also risk of strokes. So if we look at the combination therapies, as it is obvious from the guidelines in India also, we are more prone to combine the more evidence-based medicines, and it is also true. But if we see beta blockers, they are hardly recommended as first-line treatment, even second line, not even second line. Some guidelines even have pushed them down to fourth or fifth because of few important risks that we have come across in recent years. And major reasons will be two. One is the increased risk of new onset diabetes, especially when it is used in combination with a thiazide and also with an ACE inhibitor. So here the patient is already on ACE inhibitor and thiazide. And if I think of putting this patient on beta blocker, then the risk of new onset diabetes is going to be exponentially high. So that thing I must have to keep in mind and keep the patient in constant follow-up. That again is a major problem with our patients who just forget to come to follow-up and they turn up after 3 or 4 or 5 years, and you may not be able to check his or her blood pressure and even the sugars regularly. The second reason is compared with other agent, beta blockers generally are less effective in reducing cardiovascular events, especially stroke. In few studies, even stroke rate was noted to be higher in those patients treated with beta blocker, particularly because they increase the central aortic blood pressure, and which translates into increased amount of stroke. If we see the various trials, beta blockers, diuretics, when combined, they definitely lead to much more increase in diabetes. I am not going to too much of detail. These are all available, but it is a known fact. And combined with ACE inhibitor and diuretic, they are going to be a disaster. Now, if we look at the ALLHAT trial, Sir had already mentioned, this was the chief trial which resulted in setback for alpha blockers in hypertension patients, because in ALLHAT trial, we registered a remarkable increase in heart failure. It was not particularly mortality, but it was the heart failure rate which increased almost double to that of the other agents. Now, if this, because of this, this arm of the trial was stopped prematurely. Then there were many meta-analysis and scrutiny why this happened, because doxazocin is known to reduce hypertension to a very remarkable level. So then after many researches, we have come to know that it was probably because of counteraction by the body, which increases the body fluid. So fluid retention in the doxazocin arm, that was probably one of the chief reason why these happened. So whenever we want to use alpha blocker, then you may need to increase the diuretic dose or keep a tab on patient's weight regularly. That is what we have concluded. But as a third line therapy in a very major trial, ESCOT BPLA, this was again powered on, this was specifically to examine whether the heart failure increase is real or not. And here we found out that the blood pressure lowering by the alpha blocker was to the tune of almost 12 millimeter mercury in systolic and 7 in diastolic. And we are all aware, most of the major drugs, they produce a very modest decrease in the blood pressure to the tune of maybe 5 or 7 millimeter mercury. So they are very impressive agents, pushed back because of 1 or 2 negative trials, but there are many important follow-up trials which we many times forget to take a note of. So if we see the ESCOT BPLA, the heart failure rate incidence, if you see, it is almost similar to that of placebo. So alpha blocker, this was again a very major and large trial, and this was actually specifically designed to see. So we have to understand. So if we, I'm not going through this slide, there are many guidelines which clearly show that any individual having significant risk factor, particularly early CKD, the blood pressure has to be brought down to good levels, maybe 130 to 80 or lower if patient can tolerate. So I'm not going to that details. So initial 3 combination as this patient is receiving, I am completely agree with the regimen which patient right now is going on with. But if we see the alpha blockers, when everything fails, there are all the guidelines when blood pressure is not controlled. Say with ACE inhibitors, say ACBs or beta blockers or diuretic or whatnot, then the alpha blockers are brought in to reduce the blood pressure. So now it is there is no disagreement that they are not effective in reducing the blood pressure. Beta blockers, on the contrary, they increase the diabetes and stroke both risk. As we are aware, alpha blockers reduces blood pressure remarkably, but with that also proteinuria is remarkably reduced. The lipids are brought down to a good level. And in this patient, as we have seen, the serum creatinine is already 1.6. Patient is early CKD. So this is the patient where you would certainly like to reduce the blood pressure to a more suitable level. And alpha blockers just do that very effectively. Only incidence of this heart failure, which I have shown in 3-4 trials, I'm not going to details because of the time constraint, but in post ALLHAT, there are at least 2 or 3 major trials where the stroke and the heart failure, both incidence has not shown to be as much as projected in the ALLHAT trials. So we have an agent which is very effective in reducing the blood pressure, neutral on lipids, neutral on sugar, no increase in the diabetes, no increase in the heart failure, contrary to what was suggested, and it reduces the proteinuria. So again, this is one of very important thing which makes our case very strong for the alpha blocker here. The albumin creatinine ratio. This again is a very important parameter, and in this ASCOT BPLA trial and many other trials, this also is shown to be significantly reduced with alpha blockers. So this was an early trial, echocardiographic trial, where ejection fraction is shown to improve in those patients having congestive heart failure. So we should not be wary of using alpha blocker in a patient where patient is already on 3 drugs, particularly if the heart rate is just okay, say 80, I would be okay using alpha blocker. 90 or something, then certainly beta blocker is one of the choice. Another choice in these patients would have been aldosterone antagonist like spironolactone. But in Indian patients, we do have to keep in mind that they, as I said, do not turn up frequently for follow-up. And if you are using spironolactone or eplerenone, then this patient needs to be monitored for hyperkalemia every 3 months at least. So if that patient is not able to follow that schedule, then it is probably better to go for some agent which is more safe. So already 3 drugs, including acetaminophen diuretic, CKD is already set in. Heart rate is not too high as per given to me, it was 80. So in this case, we certainly have to think about small dose of alpha blocker probably would do wonders. Thank you.
Thank you, Dr. Ashmit Bhai, for giving a very illustrative discussion on this alpha blocker. Alpha blocker actually late 90s, rather late 80s, Dr. Kaplan, he was very fond of promoting alpha blockers. And unfortunately, it could not stand for long.
He's done only one trial. He's done only one trial.
Abhishek.
Yeah.
Yeah, yes, please. Hello, may I audible? Hello?
Yes, Abhishek, you are audible.
Yeah, please allow me, someone please allow me to share my screen.
Dr. Rashmit, you have to stop sharing first.
Yeah, I am extremely thankful for this warm introduction as well as warm welcome. In addition, I congratulate Dr. Desai sir and Dr. Rashmit sir for their wonderful presentations, which made my job.
Dr. Abhishek, you are
easy.
not seen on the screen.
Yeah, just
Your
a minute.
video
Let me share the screen.
Yes, now your
Yeah, so
video is open, but you are
yeah,
not.
so please.
Yes, that's right.
Yeah.
There is a lot of background sound.
Yeah, there is a background
Yeah,
noise,
so-
and also we need your slides to be shared. We can't see your slides, Abhishek.
Actually,
Abhishek, we can't see your slides. I think we have network issues with you.
yeah, so I opened the slides. Are these slides visible?
No, you need to share them. Please click
Yeah,
on
so
the share screen button below. Are you sharing?
Yeah, otherwise, I have shared my present.
No, it's not. Then probably you need to reshare. Yeah. Stop sharing and then again click on share screen and then go share your slides.
Yeah, otherwise, may someone from technical team share? I have sent the presentation to them also.
Yeah, sir, please share on cardiac mail ID.
You've shared where, on which ID, on the cardiacal email ID, Abhishek?
I have sent to that technical team numbers.
It's on the WhatsApp?
Yeah.
Yeah, Neelam, please do needful. In the meanwhile, we can have some discussion chairpersons for the two presentations so that we can save time.
The discussion can be preponed. Rashmit and yes.
Dr. Dharmin?
Dr. Bhupen and Dr. Rashmit. Yes, please go ahead with the discussion.
Yeah, I think in this patient, the beta blocker would have been the ideal choice. It was a clear-cut case for a beta blocker. Who had a beta blocker?
88 beats per minute. I agree, definitely.
Yes, sir.
But I'll also like to comment about exercise. Here in this patient, if you want to bring down the heart rate, it would be much more prudent to prompt this patient for doing.
So we have Abhishek's slides here. Abhishek, you can go ahead with your presentation. We will come back to discussion. You have to just say change next slide and then she'll do. Next slide, please. Abhishek, you need to unmute and go ahead. You're muted, Abhishek.
Yeah. So this is the summary of our case is a 55 years old male with tachycardia and uncontrolled blood pressure on ABPM. Patient is having end organ damage. However, he is on a suboptimal dosages of ARBs, calcium channel blockers, and thiazides. In addition, clear that the function has not been mentioned in this case. So I think from that point of view, patient is stable. Next slide. Yeah, so this is the sprint trial who emphasizes the control of systolic blood pressure to less than 140 and diastolic blood pressure to less than 90, which reduces the significant morbidity and mortality. Next slide. So this is also emphasized in JNC 8 as far as the gold blood pressures are concerned. Next. Next slide. Next. Yes, someone please change the slide. Yeah, so I'll emphasize the roles of different guidelines in decision making regarding the selection of antihypertensive therapy. So this is a JNC 8 back slide. This is the JNC 8 where they emphasize ARBs and calcium channel blockers and ARBs in the primary treatment. Next, diastolic less than 90 and systolic. Please.
Abhishek, your voice is not clear.
Yeah, next slide, please.
Jayesh bhai, there is a lot of background.
Now yeah, so this is the slide of my presentation with within 1 month of treatment, we should optimize the dosage and the selection class would be according to the recommendation 6 that thiazide diuretics, calcium channel blockers, ARBs or AC inhibitors. And if the blood pressure is not controlled, then we may either optimize drugs simultaneously or sequentially. So JNC 7 and JNC 8 not specifically mentions the other class of drug as a primary treatment, and they they have asked to add the alpha blockers as well as aldosterone antagonists only when the optimum dosage of these primary drugs have achieved, and which is not in our case, where our patient is not on the optimum dosage of other antihypertensives. So we need to optimize the these classes, as well as we may change the molecule amongst these classes prior to switching over to other molecules like beta blockers, alpha blockers, or others. Next slide. In addition, regarding the beta blocker, I am totally agree with Dr. Desai sir regarding the role of beta blocker for the control of tachycardia. For the control of tachycardia, and the tachycardia of 88 as a resting heart rate is not permitted. But still, as far as the antihypertensives are concerned, the panel of JNC8 does not recommend the beta blockers for the initial treatment of hypertension when the other drugs are not optimized. So this is because the beta blockers are increase the primary composite endpoint of cardiovascular death, MI, stroke, compared to uses of ARBs or other antihypertensives, and with increment in central blood pressure, these beta blockers may lead to increment in risk of stroke. So as per the JNC8, the role of beta blocker sole as an antihypertensive, which is required in this patient, is not supported. Next slide. So this is the guidance algorithm, and the red mark box suggests that we may maximize the first medication. Like first medication in this case may be either a CCB telmisartan 40 milligram, which we may increase to 40 milligram, 80 milligram, or we may change to other potent ARBs like azilsartan, etc. Or we may, or if we are considering amlodipine as the first medication, then we may either make it to 10 milligram a day or 10 milligram twice a day, or may switch over to some newer calcium channel blockers who are highly potent like benidipine, effonidipine, or ezilnidipine, rather than switching over directly to alpha blockers or beta blockers. Or we may optimize the both drugs simultaneously. Next slide. And this JNC8 as well as previous JNC7 guidelines both suggested aid and titrate, and this is the more emphasis given to titration of ACMs, ARBs, CCBs, and diuretics, etc. These class of drugs rather than adding. Next slide. This is also showing the saying that aid and titrate. Next slide. Hello, someone please change. Next slide. Next slide, please. The optimization of these primary drugs, because primary drugs are more proven as far as the control of hypertension is concerned, as well as risk reduction is concerned. This is the another guideline which is also newer as compared to JNC8, and this is a minus slide. Next slide. Previous slide, please. So ESC guideline was also suggesting of control with these primary drugs. Antagonist was recommended is potassium sparing diuretic, which is extremely helpful to counter the breakthrough resistance and control the blood pressure. So European guidelines also supported AC optimal tolerated doses of AC inhibitors, ARBs plus CCBs plus like diuretics are beneficial. So nice guidelines are also suggesting of optimizing the primary drugs. Other different guidelines are also considering these primary antihypertensives as primary drugs and beta blockers as a add-on therapy after optimization of these agents. Next slide. So regarding we might either optimize these agents like benidipine, which is highly potent, and we have experienced that 4 or 8 milligram of benidipine may control the blood pressure in most patients. Other important molecule in antihypertensives as far as the CCBs is concerned is effonidipine, which apart from blocking the L type of calcium channel blockers, which amlodipine blocks, is also a potent blocking agent for T type of calcium channel blockers, so which is more the micro vessels, capillary vessels as well. So it leads to alleviation with amlodipine. GI disturbances are lesser. Next, in addition, effonidipine has also beneficial effect our patient is having by controlling the sympathetic cut down, which is may not be as effective
Abhishek, your voice is not coming. Abhishek, if you can listen to me, your voice is not there. Kindly unmute your mic.
I think he has a net issue.
Abhishek, unmute your mic.
Sir, he is left from this meeting. तब तक हम डिस्कशन कर रहे हैं, चालू रखें.
I think it is better we start discussing because there is some problem with the Abhishek's mic and other things. So let us start discussion. Abhishek, you can join in the discussion. You can give your views and everything. Anil bhai, is it all right? No? We can start discussion.
Yeah. It is better. I think we should discuss this patient in toto rather than going for what you will do.
Because Abhishek has a lot of communication problems.
So there are 3 options, as I understand. One is beta blocker, other is calcium channel blocker, or third is titrating on alpha blocker. So as far as I think my experience goes, and I think most of the people will agree, amlodipine is still the most powerful CCB rather than this newer agent. They may be having less side effect, but most of these newer CCBs, they are not as potent as amlodipine, especially if you use in the full dose, that is 20 milligram. And alpha blockers nowadays you use as a last step. Only, I think the best.
Let us take opinion of Dr. Bhupen Desai and Dr. Rashmit Pandya.
Yeah.
And Mahadev bhai is also there. He can also give his expert opinion. And you are also there. So there are so many. Dharmin is also there.
Yes.
So let us start discussion.
Yes.
Meanwhile, Abhishek, you can also join.
In this particular patient, small dose of beta blocker would have solved all the issues. Alpha blocker like prazosin are quite difficult to tolerate. It may cause many side effects, like it may increase the resting heart rate and cause postural hypotension also.
So it might create a new problem rather than solving already having one.
Yeah, I agree. At 88 heart rate, beta blocker is that is what we usually practice. But if the patient's blood, say heart rate is in the range of 70, then probably it would be good. Then again, another choice would be spironolactone inhibitor, spironolactone, like that. I think that also is a very, very important drug, which many times we forget. Another thing in this patient which we can do is we can sometimes switch over if this patient is not on optimum doses of any medicine. So we like to increase all those doses. I am not at all for any new agents, any benedipine or this and that dipine and statins. Unless they are tried and tested in large clinical trials, it is none or null for us cardiologists. We cannot do that.
Yes, bhai, can I say something here?
Rashmin, Dr. Abhishek has just joined. Abhishek has joined. Abhishek, you unmute your mic and give your opinion. Abhishek. Okay, meanwhile, Madhav bhai, you please go ahead.
I think
Abhishek,
was just to
Abhishek, you can give your opinion loudly.
Yeah, I was yes. Yeah. I was just to emphasize the status of the guideline like JNC8, NICE, and ESC, adding the beta blockers or alpha blocker kind of agents, sold as antihypertensives. We should optimize the dosage of CCBs, ARBs, and thiazides. So we may increase the dosage in this patient of telmisartan, amlodipine to the dosages which has been studied in trials. And if we can't achieve the targeted blood pressure with optimizing the dosage of switch over to either newer agents, or we may add the beta blockers or alpha blockers. However, still I suggest that we need to optimize and titrate the primary drugs rather than going to other newer agents.
Okay, Dr. Madhav, you wanted to say something?
Yes, thank you very much, Dr. Jayasbhai. I think there is no question that beta blockers is definitely the drug to be preferred. The question is whether you are which side of the table when you are discussing. When you want to say about against beta blocker, you use old beta blockers like ethanol or something, which have been proven to have side effects. But the newer beta blockers like bisoprolol or nebivolol definitely are much better, and they are not the same beta blocker that we used to see the side effects. So I personally feel, and as we see that the use of bisoprolol and nebivolol is definitely the one which is going to help a lot in all such patients.
Dr. Rashmit bhai, you wanted to tell something?
Yeah, as I clarified in the start, only if patient is having tachycardia, it is not acceptable, and we need to reduce it down based with either nebivolol or bisoprolol as Suresh said. That is, I would definitely like that. Only if the patient's heart rate is controlled and still blood pressure is not controlled, then we should not shy of using alpha blockers. As a cardiologist, we get a fairly large number of patients where blood pressure is not controlled with many agents, and there these alpha blockers and even clonidine, which is left out in most of the trials and discussions. These things are not bad. We can use them. Definitely use them.
In alpha blocker, what is your preference?
Prazosin.
Okay, Dr. Bhupen bhai is there. Dr. Bhupen.
Yes, sir. I'm there. I'm very much there.
Dr. Bhupen.
Yes.
You want to tell something else?
No, I think I have convinced you all that everybody has agreed that this patient requires beta blocker. I think Dr. Rashmit bhai spoke about the role of alpha blocker. I fully agree. If your heart rate is less than 70, there is no point in adding beta blocker. It will cause more harm. But in current clinical practice, I think alpha blocker comes as a fifth drug. I think after you use first 3-line drugs, the first choice, particularly in India, becomes beta blocker. We are all little hyper people, we have increased sympathetic activity in our population. Our resting heart rate in a normal population is 82 or so. There is one study called India Heart Study, and which have found that Indian people do have a higher resting heart rate because we are a little high in our sympathetic overactivity. So beta blocker is very, very important in my opinion. And whatever things spoken about beta blocker against it, right? Increased incidence of stroke or increased incidence of diabetes, they are with atenolol, not with, I fully agree with Dr. Madhav Desai, they are with atenolol. Because of atenolol, we got a bad name for the beta blockers. So newer drugs like nebivolol and bisoprolol are too good. I mean, I would say bisoprolol is a very good molecule. We must use it more frequently in our population, though it has not come into guideline because there are no big randomized controlled trials. And that is why it has not become a part of any guidelines. But absence of data does not mean the drug does not deserve its right place. And guidelines are not guidelines. Guidelines are not guidelines. We have to use our own clinical judgment. And we can use in our population beta blocker. In fact,
our president, Dr. Anil Bhai, APS president, also wanted to tell something.
Yes, sir.
Anil Bhai, your mic is mute. Your mic is mute. Yeah.
Yeah. Bisoprolol basically is a very old molecule. It's not a new molecule. And unfortunately, it is a European molecule. So it was never used much in USA. That is why bisoprolol is used less. Otherwise, it's a wonderful molecule I have used for last 30 years almost. And it is given a wonderful result. So
yeah,
beta
from
blocker,
bisoprolol, we are publishing our own tenacity investigator-initiated study, which is part of the e-poster today. In the session we have published, and it's going to be published in European Art Journal as well. We have looked at in acute coronary syndrome, however, it's not in the settings of hypertension, but because you were mentioning about beta blockers, I think heart rate is an important determinant here. But for alpha blockers, we do have a strong role, especially in patients with CKD and patients with already having diabetes. These two are the subgroups where you can still not completely rule out alpha blockers, and newer CCBs do have good evidence as far as eGFR and kidney protection is concerned. But I think CV outcomes, as I think both the speakers, Bhupen and Rashmit Bhai, pointed out, is something that we probably will have to look as the time comes and the data evolves.
So,
because there are many agents, many drugs which they come and go, they come with a big O and then they are thrown into dustbin because of many side effects on all these. So any new agents, whatever, however promising it is, unless it is shown to be effective and safe in large trials, we senior consultants would definitely be wary of using them.
Yeah, I fully agree with you. There are no convincing data about any of the newer CCVs or any of the newer ARBs. There is no convincing data. I think they are marketed in India because this regular drug like amlodipine has gone into price control. So companies are not making any money out of it. So they come up with some fancy newer calcium channel blockers at 5 times the cost of amlodipine.
So in spite of having so many issues actually in transferring Abhishek's messages and everything, we could conclude that yes, the discretion is lying with the physician and cardiologist, what to use, when to use, how to use, and what dose and everything. So now we'll go to the next topic.
Jayesh bhai, before closing, I just want to thank you and Dr. Kamal bhai for giving me the opportunity.
But you are always welcome, and you have come in the dinner also today.
I am out, actually. I am from Delhi. Right now, I am sitting in Delhi.
There cannot be any excuse for you.
I am in Delhi, boss. I cannot come today. I will be reaching late. Thank you very much. Thank you very much, sir.
Thank you, Anil. Thank you. Thank you all the speakers, Bhupen bhai, Rashmit bhai, Dr. Abhishek, all the panelists, Dr. Dharmin, and all the respected dignitaries, faculties, chairpersons. We move to next session.
This is
Thank you so much. Captivating.
We would like to invite Dr. Anant Yadav, Dr. Ashwin Gadvi, Dr. Tanish Modi, Dr. B.D. Makar sir, Dr. Apurva Parekh, and Dr. Mahadev Bhai. Mahadev Bhai is already there. I would like to request Dr. Mahadev Bhai to kindly introduce the subject and speaker. Dr. Mahadev Bhai.
Yeah, I think we can see that the temperature is already rising, not only outside, but also inside the cardiocon that we could see the last. But I'm sure this is going to be the hottest because the stalwarts coming on the field. And we have Dr. Om Lakhani. He is a consultant endocrinologist at the Zydus Hospital.
Raise your volume, please.
Okay, just a minute. Yeah, before the temperature rises, let's talk something. I'm sure it's going to be a big fight. The very meaning of bout will be realized to the audience now that we have got Dr. Om Lakhani, Dr. Sabu, and Dr. Pankaj Agrawal. And the topic is also such, and Dr. Kamal always puts one or two points in such a way that everybody takes advantage of it. And so Dr. Om Lakhani is an endocrinologist at Zydus Hospital. He has his MBBS, MD, and DNB degree, and he is having a President NB Gold Medal in endocrinology. And he has his own notes in endocrinology app, and that's very useful to the practicing physicians. The next speaker is Dr. Pankaj Agrawal. He has his DM endocrinology degree and he is in Ghaziabad. He's a founder. Medical concepts in Hindi is his main innovations, and he conducts online classes of integrated endocrinology for the postgraduate students in Hindi. He's a principal investigator in 29 global and 5 national studies. He has 26 publications in international and national journals. He is an examiner at the DM endocrinology in the universities. Next is Dr. Bansi Sabu. I'm sure everybody knows him. He's a chief diabetologist and chairman at the Diabetes Care and Hormone Clinic in Ahmedabad. He is an immediate past president of RSSDI. He is president of AIAARO. And if I continue giving his degree, his time will be consumed. So I would better avoid and say he's Dr. Bansi Sabu, and that should be enough. And the topic on which we are going to have the 3 different views are about an elderly gentleman with diabetes, coronary artery disease, CKD, and we have to add the 4th drug in over and above the glargine and the metformin and one of the drugs. So first, Dr. Lakhani is going to talk about the case for liraglutide.
Thank you. Dr. Lakhani may start to his talk. I would like to say a few words regarding this topic. Our topic is titled as CAD, Diabetes, CKD, where GLP-A1, DPP-4 inhibitors or AGI. Out of these 3, which one? The organizers have very intelligently omitted sulfonylureas and glutazones in this discussion. Here, the problem is that he is an elderly man. He is obese. His weight is 90 kg. He is undergone PTCA. He is suffering from CKD and heart failure. With best medicine so far he is on SGLT2 inhibitors, metformin and glargine, and diet and lifestyle modifications. His diabetes is not under control. So our main discussion today will be regarding how to control his diabetes well as far as his fasting, PPBS and HbA1c are concerned. Because by controlling his diabetes, we can have some better outcome. In this patient being elderly, there may be other coexisting comorbidities.
We will have a discussion at last.
Just few
10
words.
minutes. So you
Just
can
few
always
words,
give your
because
opinion
these
and
things are to be
suggestion.
kept in mind while dealing and discussing this type of case. He might have cognitive dysfunction, he might have gastroenteropathy, he might have prostate problem, he might have osteoporosis and other things. So I request the speakers to consider all these points if they have time. So
very valid
later on, the
points.
discussion
Yes, sir.
can be handled
Yes, sir.
nicely.
We agree,
please,
sir.
I also welcome all the chairpersons and co-chairmen, co-moderators. Please start the discussion.
Thank you, sir, for the kind introduction, and thank you to Dr. Jayesh Trivedi, sir, Dr. Madhav Desai, sir, Dr. Kamal Sharma, sir, for this. Can I be allowed to share my slides, please? Yeah, thank you. Yeah, are my slides seen?
Yeah.
Yeah, okay, thank you. So, I think the case is already been introduced to the, to the audience. And I'm going to talk about the GLP-1 receptor agonist. This is the financial disclosure. And I'm going to talk from the perspective of GLP-1 receptor agonist as the, the next choice for this patient. But, as all of you, and a lot of you would have seen the movie 3 Idiots, these 3 guys who end up in a marriage and then they are told that आप कौन से side से हैं, आप bride के side से हैं कि bridegroom के side से हैं, तो they say हम science के side से हैं. So I think same here. I'm neither from GLP side or DPP side or AGA side. I'm actually trying to be more neutral and from science side, I think. So that is what my focus will be. So we have this patient who has already been introduced, like I said, 72-year-old, 90 kg weight. Its EGFR is 39, HbA1c is 8.9, his fasting is 212, postprandial 276, and LVEF is 48%. So this is the history with the past history of PTCA. Now let's dissect this case further. So what are the issues that we have in this patient? So naturally the patient has a poor glycemic control, but I'd like to see the data more closely. And I often see the delta value. So delta value is basically the postprandial sugar minus the fasting sugar, which is 64 over here. But his fasting is 212. So keep this in mind. I'll come back to this. Remember, मैं science के तरफ से हूँ, right? Okay. The patient has an increased creatinine. Now, see, we have been told that the patient has CKD, but we don't know the baseline creatinine of this patient, right? We don't know the past history. We just know the current situation, right? And that is what happens in a lot of our practice. We don't know the etiology for the increased creatinine. We have the patient having AHCVD. He's having heart failure with reduced ejection fraction, slightly reduced ejection fraction, and he's having ongoing medicines, which are basal insulin, metformin with an SGLT2 inhibitor. Now, these are the options which are given to us. Add a GLP-1 receptor agonist, either an oral semaglutide or a liraglutide. Add a DPP-4 inhibitor. Add an AGI. Add a maglitinide, which is, Dr. Banshi Saab was going to speak on this, and others. So, what is your answer? Well, I'll allow you to think about it. We'll come back to this in a discussion. But my answer, I said in the beginning, I was to talk on GLP-1 receptor agonist, but my answer is none of the above. I'm not going to add this patient on a DPP-4, a GLP, a AGI, a maglitinide. No, I'm not going to do any of this. All I'm going to do in this patient is to fix the fasting first. I think that is the message which should be going today, right? The answer, in my opinion, and science ki taraf se, the answer is E, none of the above. The patient does not need any of these medication. All the patient needs here is to correct the basal insulin dose titration, right? That is all we need to do. Remember, no matter what the dose the patient is taking, right? There is a lot of wrong concepts about basal insulin. We don't know what dose this patient is taking, but whatever the dose is taking, the best thing about insulin is that you can always give more, right? So you can easily give this patient more basal insulin, titrate the basal insulin correctly. There is no upper limit of what basal insulin you can give. Remember, basal insulin is going to be the safest drug as well, right? Because, the patient has CKD, there are very few contraindications to use of basal insulin. This patient is already on basal insulin. All we need to do is titrate the basal insulin correctly. That is all we need to do, right? No other fancy medicines are required here, right? That is the science ki taraf se answer, right? So no new medicines. We see this type of patients very commonly in our practice. All you need to do is, first of all, review the patient's basal insulin technique and teach the correct technique. Every single day, I see patients with high doses of insulin, multiple doses of insulin, sugars are not under control, and you see this patient is having big lipohypertrophies on their abdomen, right? Patient is taking injection at the same site every day, right? Initially, the sugar was controlled for a few days. After that, the sugars are not under control. Half of the patients are not aware that they are supposed to change their pen needle. They don't know how frequently to change their pen needle. They don't know the correct technique for insulin injection. That's the most important thing. That is what we should be doing, right? So teach the patient the correct technique, check the patient's technique and teach the patient the right technique. Increase the dose of basal insulin. Ask the patient to report the fasting sugar daily by whatever means. Target to fix the fasting. Target a range of 90 to 130. And like Sir said, it's an elderly gentleman. Let's keep it 100, right? Keep it 100 to 130. What this will do is, remember the delta gap. Delta gap was 64. So I just bring the fasting down to, let's say, 100, right? 100 plus 64 is 164. The patient's postprandial will also come down to less than 180, right? And if you do the HbA1c after 3 months, patient's HbA1c will be easily less than 7, right? So remember the most important thing, right? In any patient, always, especially patients with high HbA1c, whenever you have higher HbA1c, the contribution of the fasting sugar is higher to the overall HbA1c. And hence, in all these patients, the important thing is to fix the fasting first, right? And in this patient, the fasting itself is 212. You don't need to do anything, just fix the fasting first. And we need basically, right, an agent which improves the fasting. And in this case, the patient is already on the best agent which can control the fasting, that is basal insulin, right? But we are, have to play the devil's advocate, right? I think this is I would say the correct answer, but we have to choose one of the drugs as we have been told, right? And in that scenario, right, let us look at the other options, right? So your GLP-1, your DPP-4, AGI, maglitinide. Well, answer 2, 3, and 4 are all wrong answers, because remember, we need a drug which corrects the fasting. And amongst all these 4 options, the only drug which has predominantly good action, or not say predominantly, I'll say good action on fasting is GLP-1 receptor agonist. That is a long-acting GLP-1, right? So we need a long-acting GLP-1, something like either a liraglutide or an oral semaglutide, which can have action on the fasting blood sugar. DPP-4 mainly has action on postprandial. AGI only has action on postprandial. Meglitinib has only action on postprandial. Patient fasting is 212. उसके postprandial is 264. उसको postprandial को और कम करके क्या करोगे? Right? कुछ नहीं करना है. Postprandial को नहीं touch करना है. Just correct the fasting. Right? So, I don't know what Dr. Banshi sir is going to argue or what Dr. Agrawal is going to argue, but the simple point is, इसमें postprandial control करके there is nothing we are going to gain out of it. Right? So, of all the options which are available, the only viable option, right? Forget cardiovascular risk, forget CKD, everything. The only viable option is to either increase the basal insulin dose or to add a GLP-1 receptor agonist. These are the only options that we have, right? Now, the other big question here is the patient's, should the metformin be continued? Now, this is an important question, right? This patient's eGFR is 39. The patient is already on metformin, right? So what do? Should you continue metformin or should you discontinue metformin? That is an important question, right? So this is the guidelines from Korean Diabetes Society. Similar guidelines are followed all across the world, right? I chose the Korean one because it's the most well written, right? Remember, it is said that metformin can be used in full therapeutic doses when the eGFR is more than 45, right? If the patient is already on metformin and the eGFR is between 30 to 45, then you can continue metformin, but the dose should be less than 1 gram. And if the patient's eGFR is less than 30, then you do not initiate metformin, right? So that's the broad guideline. So in this case, we don't know the dose of the metformin the patient is taking, but the patient's eGFR is 39. That means up to 1 gram of metformin we can safely give to this patient. So metformin, I will continue. If the patient's dose is more than 1 gram, I'll reduce it to 1 gram, but I will continue the metformin in this patient. Second important question, and Dr. Kamal Sharma sir is like a mentor and teacher to me, right? I've learned a lot from his book, and I knew that if this question is asked, there will be a SGLT2 there, right? I'm sure he's a big proponent of this very good molecule, right? Should you continue SGLT2 inhibitor in this? That's also important, right? So in this case, now we know that the patient has CKD, but we don't know whether this is acute on chronic or this is just a chronic kidney disease. We don't know the prior creatinine of this patient. So we are assuming that the patient is having CKD, right? We are assuming that the patient's creatinine has been stable, right? But what do you do if it was not, right? So if you see the KDIGO guideline about CKD, the KDIGO guideline says, again, we talked about metformin already, but about SGLT2 inhibitor, it says that if the eGFR is less than 30, do not initiate SGLT2. If the patient is on dialysis, discontinue SGLT2. But in other conditions, you can either continue SGLT2 or add SGLT2. In this case, patient is already on SGLT2 inhibitor, so you can continue that, right? And added to that, the other options you have are GLP, DPP-4, insulin, AGI, and so on, right? But if you see the guidelines very clearly, it says the preferred drug is GLP-1 receptor agonist. So again, right, I may say anything, but the guidelines clearly say that the next preferred drug in this patient should be a GLP-1 receptor agonist, which of course, is the thing, right? And again, in simple terms, any patient with SGLT2, with CKD, remember if eGFR is more than 30, you can give, right, at any level of hyperglycemia. So you can give SGLT2 in this patient or continue SGLT2 in this case. When do you discontinue? Now what happens is if you add an SGLT2 inhibitor and there's an acute drop of eGFR, which is often hemodynamic in origin, if this drop is more than 30%, you discontinue the SGLT2 and reassess the patient. But if the drop is less than 10%, you can continue using the drug. So in this patient, you review the patient's past eGFR values. If you have that value, assess whether there is a recent drop in eGFR. If there is no recent drop in eGFR, you can continue your SGLT2. If the recent drop in eGFR is more than 30%, you need to discontinue SGLT2.
Last 1 minute.
Yes, sir. Okay, sir. What is the so with conclusion with SGLT2, you can continue SGLT2 in this patient. Now, coming to GLP-1 receptor agonist, right? We need to consider two things here. First thing, can the patient afford a GLP-1? Second is, can the patient tolerate it, right? Any patient you start a patient on GLP, these two considerations should be there. Assuming that both these considerations are there, the arguments in favor of GLP are, you have good glycemic control, it helps in weight loss, it prevents CKD progression, and most importantly, prevents future cardiovascular events, right? If you see overall in terms of, the weight loss of oral semaglutide is definitely more sharper than sitagliptin. right? You can clearly see from this data, right? And again, if you talk about cardiovascular benefit here, remember this patient has ASCVD, patient has atherosclerotic cardiovascular disease, and the drug, which is the best drug for preventing the progression of atherosclerotic cardiovascular disease, as we have seen from data earlier, is a GLP-1 receptor agonist, particularly in this patient, a Victoza oral liraglutide, right? Oral semaglutide, unfortunately, does not have cardiovascular benefit data. We have cardiovascular safety data, right? So this is the point here. HbA1c reduction is also the sharpest, again, with oral semaglutide. And most importantly, oral semaglutide can be given at any eGFR value. You can give it to any patient irrespective of the eGFR, and it can be easily given, and it is completely safe, right? So you can give it at varying degrees of renal impairment, and no dose adjustment is required. In fact, it is effective in patients with higher grades of CKD also, and it prevents the renal deterioration also, right? So again, we are all aware about the cardiovascular benefits of GLP-1 receptor agonists. And I think, I'm sure Dr. Banshi Sabu and Dr. Pankaj Agrawal sir will also agree with me that if cost is not an issue, then GLP-1 receptor agonist would be a great choice for this patient, right? So again, these are the other things. We'll not go into details about how, GLP-1 receptor agonist protects the cardiovascular system. You are all aware of this, right? But let us look at GLP-1 from a perspective of this being an ideal agent, right? It reduces HbA1c, fasting, and postprandial. It will produce minimum hypoglycemia. It will reduce the weight. It will have cardiovascular benefits, especially atherosclerotic cardiovascular benefits. Generally, side effects profiles are tolerable except for GI side effects. No dose requirement is required in old age, and no dose modification is required in this CKD situation. So there's no doubt about it that GLP is an ideal drug. The only factor is the cost here, right? That is the only factor in mind, right? So just to summarize, in this patient, remember, like I said, मैं science की तरफ से हूँ, ना मैं bride की तरफ से, ना bride groom की तरफ से. In this case, the best idea is to fix the fasting first. All the patient needs basically is proper basal insulin dose titration. The metformin can be given up to 1 gram in patients with eGFR between 30 to 45. SGLT2 may be continued. Of course, the benefit is definitely more than the risk in this patient and can be continued. GLP-1 receptor agonist is a great choice, provided the patient, two things. Patient can afford it and patient can tolerate it. If both these things are taken into consideration, GLP is a great choice for this patient. In obese patient, GLP provides additional benefit of weight loss. And remember, in terms of atherosclerosis, GLP-1 receptor agonist is the best agent for the atherosclerotic prevention. And remember, in this patient, a combination of GLP-1 with an SGLT2 from a cardiovascular point of view will be, as a lot of us would say, and as Dr. Pankaj Agrawal would say in Hindi, "Sone pe suhaga." Right?
Very well taken. You did very well, Om. It's a very big topic, but you summarized so well. Now we'll go to Dr. Pankaj Agrawal. You will remain with us during the discussion, please.
I think Om also spoke for others. I mean, he was covering others' topic as well.
Yes.
He has made things clear for everyone now.
Yes, sir.
Dr. Pankaj Agrawal.
Yeah, धन्यवाद. धन्यवाद डॉक्टर कमल शर्मा, धन्यवाद डॉक्टर जयेश. और जैसा कि डॉक्टर ओम लखानी ने, मेरे मित्र ने बहुत अच्छा स्टेज सेट कर दिया है. और एक फेमस सेइंग है, रास्ते अभी और भी हैं. तो किसी भी एक रास्ते को पकड़ के जिद उस पर करना बहुत अच्छा भी नहीं है. हमें मालूम है हार्ट फेलियर के ट्रीटमेंट के लिए बहुत सारे ओरल एजेंट्स हैं. जॉब मुझे दिया गया है वो DPP-4 इनहिबिटर्स को डिस्कस करने का. तो DPP-4 इनहिबिटर्स आर सेफर, ओरल, इनएक्सपेंसिव एंड बेटर ऑल्टरनेटिव्स. इसको डिस्कस करना चाहेंगे हम अगले कुछ मिनटों में. और जो हमारा मिशन है, मुझे आशा है कि आपको यह पसंद आएगा यदि हम अपनी इन्हीं डिस्कशंस को अपनी मातृभाषा हिंदी में करें. दो प्रश्न यहाँ आते हैं इस पेशेंट को देखते हुए. पहला, एक जनरलाइज्ड क्वेश्चन कि क्या हार्ट फेल्योर में DPP-4 इनहिबिटर्स सेफ हैं. दूसरा, इस पर्टिकुलर केस में यदि हम DPP-4 इनहिबिटर्स जोड़ें तो क्या वह फ्रूटफुल होगा, इसके लिए लाभकारी होगा. आइए इनको एक एक करके हम लोग डिस्कस करते हैं. DPP-4 इनहिबिटर्स हार्ट पर, स्पेशली हार्ट फेल्योर में, जो दो तरह से काम करते हैं, एज ए पार्ट ऑफ GLP-1 एंड एज एन इंडिपेंडेंट एजेंट. डॉक्टर ओम लखानी ने बहुत अच्छा GLP-1 एनालॉग्स के ऊपर बोला, बताया, और मैं उनसे पूरी तरह से सहमत हूं कि हमें साइंस की तरफ से होना है, ना कि किसी एक एजेंट की तरफ से. DPP-4 इनहिबिटर्स क्या हैं? GLP-1 एनालॉग्स और DPP-4 इनहिबिटर्स एक ही थैली के चट्टे बट्टे. DPP-4 इनहिबिटर्स फिजियोलॉजिकल मैनर में काम करते हैं, फिजियोलॉजिकल लेवल्स ऑफ GLP-1 को बढ़ाते हैं, और इसलिए उनकी लिमिटेड कैपेसिटी है। मैं इनको कहता हूं सल्फोनिलूरियाज। और GLP-1 एनालॉग्स वो एक्सोजिनसली दिए गए GLP-1 एनालॉग्स हैं जो कि फार्माकोलॉजिकल कंसंट्रेशंस में GLP-1 को बढ़ाते हैं, और इसलिए इनकी पोटेंसी DPP-4 इनहिबिटर से बहुत ज्यादा होती है। इट्स जस्ट लाइक इंसुलिन। तो सल्फोनिलूरिया से हम थोड़ा इफेक्ट अचीव करते हैं, इंसुलिन से हम, जैसा कि डॉक्टर ओम ने कहा, अनलिमिटेड। उसी तरह से DPP-4 इनहिबिटर से हम थोड़ा एफिकेसी हम ले सकते हैं, और GLP-1 एनालॉग से उसकी अपेक्षाकृत बहुत ज्यादा। लेकिन जो फार्माकोलॉजिकल कंसंट्रेशंस में जो इफेक्ट है, जो एडवांटेजेस बताए ओम ने, वह DPP-4 इनहिबिटर से हमें नहीं मिलते। DPP-4 इनहिबिटर्स के अपने इंडिपेंडेंट एक्शंस भी हैं। नाइट्रिक ऑक्साइड प्रोडक्शन बढ़ाता है, थोड़ा एंटी इन्फ्लेमेटरी रोल है इसका इंडिपेंडेंटली, और बहुत महत्वपूर्ण है कि BNP की मेटाबॉलिज्म में DPP-4 BNP को भी मेटाबोलाइज करता है, जो DPP-4 इनहिबिटर उसको कम करके BNP लेवल्स बढ़ा सकता है, और इस तरह से फ्रूटफुल हो सकता है। लेकिन यह जो पैथोफिजियोलॉजिकल मैकेनिज्म इसके लिए सजेस्ट की गई है, यह स्टडीज में बहुत अच्छे से अभी तक प्रूव नहीं हुई है। तो इतने एडवांटेजेस होने के बाद भी कंट्रोवर्सी क्या है? कंट्रोवर्सी शुरू तो हुई थी 2013 में सेवर्टिमेट ट्रायल, जो सक्साग्लिप्टिन का ट्रायल था, जिसमें देखा गया कि हार्ट फेल्योर की इंसिडेंस 27% बढ़ गई, 1.27 हार्ट हैजार्ड रेशियो। इसी के बाद यह रिकमेंडेशंस आनी शुरू हुई कि नंबर 1 DPP-4 इनहिबिटर्स हार्ट फेल्योर या हार्ट में कोई बेनिफिशियल रिस्पॉन्स तो देते नहीं, स्पेशली सक्साग्लिप्टिन हमें ऐसे केसेस में अवॉइड करना चाहिए, और जो कि हम आज तक मानते चले आ रहे हैं। मैकेनिज्म क्या हो सकता है? शायद जो सिंपैथेटिक ओवर एक्टिवेशन, उससे इंड्यूस्ड कार्डियोमायोसाइट्स की अपोप्टोसिस, और शायद कुछ और पैथोफिजियोलॉजिकल मैकेनिज्म में जिनके द्वारा ये हार्ट फेल्योर जनरेट करते हैं। लेकिन 2013 से अभी तक बहुत बहुत लंबा सफर तय हो चुका। कई और स्टडीज में यह डाटा कभी आज तक रेसिप्रोकेट नहीं हो पाया। सक्साग्लिप्टिन दोबारा किसी भी ऑब्जर्वेशनल स्टडी में उसने यह नहीं शो किया, यह नहीं प्रूव हुआ कि उससे हार्ट फेल्योर की प्रेवलेंस इंसिडेंस बढ़ती है। आप ये देखें, 2 लाख पेशेंट्स में भी सक्साग्लिप्टिन का हॉस्पिटलाइजेशन फॉर हार्ट फेल्योर उसके बाद दोबारा नहीं देखा गया। सिटाग्लिप्टिन 1 लाख एंड अबव पेशेंट्स में नहीं देखा गया। और जब डिफरेंट स्टडीज में और बड़े बड़े डाटा पर ये चीज ट्राई हुई, तो देखा गया सिटाग्लिप्टिन वर्सेस सक्साग्लिप्टिन कोई डिफरेंस नहीं है, और सल्फोनिलूरियाज के साथ भी बहुत कोई डिफरेंस नहीं है। तो सुर बदलने लगे। 2013 से 2018 आते आते क्या कहा जाने लगा कि देयर इज नो स्टैटिस्टिकल इंक्रीज रिस्क विद DPP-4 इनहिबिटर्स इन रिस्क फॉर हार्ट फेल्योर। तो सक्साग्लिप्टिन लेकिन अभी एक बार बदनाम हो चुकी, तो क्या किया जाए? उसको हम अभी भी एक अलग कैटेगरी में रखते हैं। लेकिन बाकी DPP-4 इनहिबिटर्स का जो ऑनगोइंग जितने भी क्लिनिकल ट्रायल्स हुए, उनमें देखा जा रहा है किसी से और हार्ट फेल्योर के हॉस्पिटलाइजेशन का रिस्क नहीं बढ़ता। तो आज की स्थिति क्या है? आज का जो करंट लास्ट ईयर रिकमेंडेशंस है वो ये है कि डेफिनेटली इनसे सीवी बेनिफिट तो हमको नहीं मिलता, लेकिन दीज आर नॉट बैड एजेंट्स। तो 3rd, 4th लाइन एजेंट के तौर पे आफ्टर SGLT2 इनहिबिटर्स, आफ्टर GLP-1 एनालॉग विच आर द प्रूवन ड्रग्स, उनके बाद मेटफॉर्मिन के बाद एज 3rd और एज 4th लाइन एजेंट हम DPP-4 इनहिबिटर्स को यूज कर सकते हैं। अगर किस कार्डियोलॉजिस्ट के बीच में मैं इसको कहूं DPP-4 इनहिबिटर्स को, तो मैं जो डिस्कशन अभी डॉक्टर अभिषेक के साथ हो रहा था, मैं कहूंगा कि DPP-4s आर जस्ट लाइक एम्लोडिपिन। जैसे ये एम्लोडिपिन आप कहीं भी दे देते हैं और उसका कार्डियक पेशेंट, रीनल पेशेंट में बहुत ज्यादा डिफरेंस नहीं होता, माइनर चेंजेस को छोड़ के, वैसे ही DPP-4 इनहिबिटर्स हम लोग बेहिचक इस्तेमाल करते हैं, कहीं पे बहुत मेजर डिफरेंस नहीं आता। और मैं इसको इसीलिए कहता हूँ ये तो आलू है, किसी भी सब्जी में डाल दो उसके साथ में चल जाएगा। तो अगला क्वेश्चन आता है, इस हमारे पर्टिकुलर केस में DPP-4 इनहिबिटर्स की क्या पोजीशनिंग होनी चाहिए? हमारा प्रोफाइल अभी ओम ने अच्छे से डिस्कस कर ही चुके हैं। आइए एक एक करके हम इनकी पहलुओं को समझते हैं। ओल्ड पेशेंट DPP-4 इनहिबिटर्स बहुत सुरक्षित हैं और बहुत इफेक्टिव हैं। देयर इज नो डाउट। ओबेसिटी के साथ दे आर न्यूट्रल, इनसे वेट गेन भी नहीं होता, वेट लॉस भी नहीं होता। अगर ओबेसिटी को ध्यान में रखना हो तो डेफिनेटली SGLT2 इनहिबिटर और GLP-1 एनालॉग एक बेहतर चॉइस होंगे। पोस्ट PTSA पेशेंट में डेफिनेटली ये न्यूट्रल है, इनसे कोई ना बेनिफिशियल रिस्पॉन्स है ना इनका कोई डिलीटेरियस रिस्पॉन्स है, और यहाँ पर भी SGLT2 इनहिबिटर्स और GLP-1 एनालॉग्स बेटर होंगे। मैं इसके लिए डॉक्टर ओम को और उनकी प्रेजेंटेशन को यहाँ पे प्रेफर करूंगा और कोट करूंगा। इजेक्शन फ्रैक्शन 48% कॉम्प्रोमाइज्ड है। यह वो जगह है जिसके कारण से अभी तक DPP-4 इनहिबिटर्स जो डिस्प्यूटेड है, तो या तो वो न्यूट्रल है या सेक्साग्लिप्टिन के साथ देखा गया इट इज हजार्डस। और डाटा हमारे पास क्लियर कट है कि SGLT2 इनहिबिटर्स दे आर प्रेफरेबल एजेंट्स फॉर दिस ग्रुप ऑफ पेशेंट, तो उसको हमें प्रेफर करना है, वो हमारे पास ऑलरेडी चल रहा है। EGFR कॉम्प्रोमाइज्ड है। यहां पर DPP-4 इनहिबिटर्स की क्या पोजीशनिंग होनी चाहिए? कॉम्प्रोमाइज्ड EGFR के साथ में DPP-4 इनहिबिटर्स दिए जा सकते हैं, सुरक्षित हैं और इफेक्टिव हैं। अंतर क्या है? कुछ एजेंट्स जिनका डुअल मोड ऑफ एक्सक्रीशन है लाइक लेनाग्लिप्टिन, टेनेलिग्लिप्टिन, वह विदाउट डोज एडजस्टमेंट दिए जा सकते हैं, और बाकी सेटाग्लिप्टिन, विल्डाग्लिप्टिन, एलोग्लिप्टिन, यह सब डोज एडजस्टमेंट के साथ दिए जा सकते हैं, लेकिन ये इफेक्टिव हैं और इनके कोई डिलीटेरियस रिस्पॉन्सेस नहीं दिखेगा। जो लास्ट और जो डायबिटोलॉजिस्ट के लिए सबसे महत्वपूर्ण जो पहलू आता है वो है HbA1c 8.9%। सारे DPP-4 इनहिबिटर्स अमूमन 1% HbA1c को रिड्यूस करते हैं, और यहाँ पे ओम ने बहुत अच्छे से डिस्कस किया इस पहलू को कि अगर हम 7% का टारगेट भी लें तब भी 1.9% का एलिवेशन है, और 1.9% का एलिवेशन हम केवल DPP-4 इनहिबिटर से नहीं ले सकते। तो यहाँ पे अगर हम DPP-4 पे ही भरोसा करके चलेंगे तो यह राह हमारी मुश्किल हो जाएगी, हमें किसी और का सहारा लेना पड़ेगा। लेकिन 1% HbA1c रिडक्शन से भी आप जानते हैं, मुझसे बेहतर जानते हैं कि 15% रिस्क हमारा हार्ट फेलियर का कम होता है, तो यह बहुत अच्छे एजेंट रहेंगे। फिर से जिस पहलू को हमने बहुत अच्छे से डिस्कस किया, मैं तारीफ करूंगा कि 212 to 76 जो डेल्टा फिगर जिस पे अभी लोग बहुत कम ध्यान देते हैं, वह उन्होंने पॉइंट उठाया। यहाँ पर 212 फास्टिंग एक बड़ा डिनोमिनेटर है और सिग्निफिकेंटली हाई HbA1c, तो मेटफॉर्मिन तो हमें चलाते रहना है, जिसकी के ऊपर डिस्कस हो चुका कि EGFR के अकॉर्डिंग उसकी डोज डिसाइड करें। SGLT2 इनहिबिटर्स चलाते रहना है, पुनः इस बात को देखते हुए कि बहुत सीवियर कॉम्प्रोमाइज ना हो। यहाँ पर 38 है, कोई दिक्कत की बात नहीं। ग्लार्जीन हमें बढ़ानी है जब तक कि फास्टिंग हमारा नियर नॉर्मल लेवल पे ना आ जाए। DPP-4 इनहिबिटर्स अगर हम जोड़ ही रहे हैं तो हमें वह DPP-4 इनहिबिटर प्रेफर करना है जिसका कि बाई मोडल एक्सक्रीशन पैटर्न हो, लिनाग्लिप्टिन या टेनेलिग्लिप्टिन, जो हम फुल डोजेस में यहाँ पे फुल एफिकेसी के साथ इस्तेमाल कर सकें। और केवल ग्लार्जीन को देते हुए यदि हम PP को कंट्रोल नहीं कर पाते हैं, हालांकि ग्लार्जीन और DPP-4 इनहिबिटर के बाद कोई पहलू अनटच्ड नहीं रहना चाहिए, लेकिन अगर फिर भी आफ्टर ब्रेकफास्ट कंट्रोल हो गई, हमने देखा आफ्टर लंच बढ़ी हुई है, आफ्टर लंच कंट्रोल हो गई, आफ्टर डिनर बढ़ी हुई है, तो करस्पॉन्डिंग मील के पहले हम एक ग्लैंडियन इंसुलिन जोड़ सकते हैं। तो डेफिनेटली इस प्रकार के पेशेंट्स में हम DPP-4 इनहिबिटर जोड़ तो सकते हैं, लेकिन यहाँ पे इस गिवन केस में ग्लार्जीन को बढ़ाना सबसे पहला पहलू होना चाहिए। DPP-4 इनहिबिटर्स को हम उसके साथ जोड़ सकते हैं, जैसा कि बात हुई कि GLP-1 एनालॉग होते तो बेहतर होता। तो मैं यहाँ पे विदाउट एनी आर्गुमेंट मैं सरेंडर कर रहा हूँ, मैं कोट कर रहा हूँ उनको कि GLP-1 एनालॉग्स अगर होते तो यहाँ पर बेटर होते। DPP-4 इनहिबिटर न्यूट्रल ही रहेंगे। और AGI मैग्नेटाइट के बारे में अभी आना है और बंसी बात करेंगे उसके विषय में। DPP-4 इनहिबिटर्स डेफिनेटली सेफर एजेंट्स हैं इस तरह के पेशेंट्स में भी, ओरल और इनएक्सपेंसिव आज 2022 में तो है ही, लेकिन मैं बेटर कहने से पहले बचना चाहूंगा। बेटर एजेंट्स नहीं है, बट दीज एजेंट्स कैन बी यूज्ड इन सच टाइप ऑफ पेशेंट्स। धन्यवाद। मैं समझता हूँ चेयरपर्सन मैंने अपने टाइम के अंदर ही खत्म किया और डिस्कशन के लिए मैं उपलब्ध रहूंगा। धन्यवाद
सर। टाइम से खत्म करने के लिए आपका धन्यवाद। वी विल गो टू द नेक्स्ट स्पीकर, who is our Bansi Sabu. Dr. Bansi.
Yes, I am there, Dr. Jayesh Bhai.
You are always ready. I know that.
Yes. First of all, thanks, Kamal, for giving me an opportunity. Om was talking for first 5 minutes that case is wrong. I agree that, the fasting sugar was not controlled. And let us assume that glargine is given in full dose. And let us consider that fasting sugar is 112. And Kamal and Dr. Apurva had referred the patient for control of the sugar with 8.9 A1C. So now understand that this patient is already on insulin, full dose, and he's having fasting sugar of 112 with 276. Already Dr. Pankaj has talked about the DPP-4, but he agreed that GLP-1 is the best, and that as far as science is concerned, we agree and we will go with the guidelines also. But where I will place that, should I put the patients on a glinides or on alpha-glucosidase inhibitor in combination? Because patient has been referred from cardiologist and nephrologist for a good control of diabetes with 8.9 is not acceptable. Even the patient may be a 72-year-old guy, or he is having a patient with a post-PTCA or his LV dysfunction. So this is the case. We all know now. I did not need to discuss more about it. So the guideline approach, fully I agree that this patient should have achieved the A1C of around 7.5. And there should not be further weight increase, which GLP-1 will be best. Cardiorenal prospective anti-diabetic agents, if patient is already on SGLT2 inhibitor, we would like to put the patients on GLP-1, and glargine will take care of the fasting sugar. But in real world, it does not work. And that is what, even after next 5 minutes, again, we could not convince that patient should be started on GLP-1 or not. Are we adherent to the guidelines, which is recommended therapy? And this is the data which is published in 2019. And even from the Western world, where these molecules are available to the patients free of charge. And still, the clinicians are not writing the way they should write, or the guideline-based therapy. Here you can see less than 10% of the patients with type 2 diabetes with cardiovascular disease received guideline recommended therapy for CV risk reduction, even in developed world. And this is the data which I am showing, which is published in 2019. Now, attaining A1C for these patients, I am sure all of you will agree that patients should achieve a A1C of less than 7.5. If not very good tight control, we don't want hypoglycemia, but definitely HbA1c should be around 7.5. Hyperglycemia itself leads to a lot of problem, even in a person who is not having cardiovascular disease or somebody who is having already cardiovascular disease, because PPSG is a postprandial hyperglycemia associated with hypercoagulability, including increasing platelet activity and activating platelets. And there are multiple other reasons for which postprandial hyperglycemia has to be controlled, not only just for getting A1C to get control. If I just put the list of all the anti-diabetic agents which are available to us, and this patient is already on SGLT2 and metformin, can we give the patient sulfonylurea? Risk of hypo is more. Glitazone may precipitate heart failure. SGLT2 patient is already there. GLP-1, yes, it's a choice of drug, but the GI issue, the cost, pancreatitis, needle prick, even though now it is available in oral form, but the cost is a major challenge. Alpha-glucosidase inhibitor safely can be given with eGFR up to 25. This patient is having 39. The glinides can be given even in the patient with CKD and end-stage renal disease. You can give up to 0.5. 0.5 can be given further broken in half tablet as per the dose, as patient should not develop the hypoglycemia. And at the same time, post-meal glucose has to be controlled. Now, this is the data. I'm sure all of you agree. And you know it also that which anti-diabetic therapy can be given in different stages of CKD. And it is the glinides which can be given in the patient even his eGFR is less than 25. Even we can give it even in end-stage renal disease where the eGFR is even less than 15 also. So this is safely can be given in the patient with CKD, and this patient is having a progressing chronic kidney failure. Now, as far as efficacy is concerned, now this patient is 8.9, considering the fasting sugar is 112 and glargine dose is full given, still the A1C is not getting control. Now, what molecule would you like to give? You have a choice of GLP-1 and DPP-4 with the average A1C reduction as a third line agent will be 0.5 to 1.1. And you can see here with the sulfonylurea, glinides and alpha glucosidase inhibitor, they are highly efficacious drug because now this patient's major concern is a postprandial hyperglycemia. If I can achieve the glycemic control or the post-meal glucose level from 250 to 150, the A1C reduction will be almost in the tune of 1.5 or 1.3, and that you can achieve only by AGI or glinides or a short-acting sulfonylurea, which will not be possible with DPP-4 and GLP-1 analog. And that's the reason the patient can be, for a good glycemic control, the glinides and alpha glucosidase inhibitor can be a choice of therapy. Is postprandial glycemia harmful? We all know it. International Diabetic Federation had come out with a special booklet which is talking about the post-meal hyperglycemia is a harmful and it should be addressed. And what they are talking, the several class of pharmacological agents which can preferentially lower the PPG, but it is AGI and glinides are a choice of therapy when we are trying to talk about only post-meal glucose to get control. The American Diabetic Association recommends, even they don't talk about the post-meal glucose so much and they don't talk about the AGI, but they talk that it is clear that postprandial glucose level, like preprandial hyperglycemia, it contributes to elevated A1C level, and its relative contribution is being greater when A1C is closer to 7. So when you are looking at the patient whose A1C is around 8 or 8.5, try to control the post-meal glucose level also along with fasting control. If your fasting is controlled and still the A1C is around 8 or 8.5, try to achieve the tighter control of the glucose also. The RSSDI, we also recommend the same, that post-meal glucose level should be less than 160. It is AGI, GLP-1, DPP-4, all of them are also working on post-meal glucose level, but glinides and short-acting sulfonylurea are recommended in a patient with CKD who have a post-meal glucose level are high. Now let me talk about this combination where the talk is given to me, what repaglinide and voglibose does. Rapid and short-acting insulinotropic oral hypoglycemic agent, and AGI is a class of agent which is competitive inhibitor of enzyme needed to digest the carbohydrate. In very simple language, this combination takes care of both the parts and they can be combined in a patient who is already the post-meal glucose is not getting controlled. Repaglinide is a glucose dependent. It does not cause so much longer hypoglycemia. It restores early phase of insulin secretion, improves post-meal glycemia and reduces lipolysis. And it is recommended by various societies, and particularly when PPG is associated with diabetes and CKD, the glinides is a choice of therapy. It exerts direct action on a pancreatic beta cell, but it is unlike sulfonylurea, so the chances of hypoglycemia with glinides are very, very less. It has got an insulinotropic action at a glance, but there are other benefits. It improves beta cell function, it restores early phase insulin secretion, and rapid onset of action with short-lived hypoglycemia effect, and it's a glucose and dose dependent insulinotropic effect. It is other like a glibipride. It does not cause long-acting hypoglycemia, and it is only controlling the post-glucose excursion only. But the point is here, whether it can be given in a patient who is post-PTCA, a 72-year-old guy. Repaglinide is more efficient than controlling the post-meal glucose excursion, and it has got a beneficial effect on reducing cardiovascular risk factor, for which I will show one more paper that. Repaglinide CV safety data. Repaglinide associated with lower cardiovascular risk than any other insulin secretagogue. So if out of all sulfonylurea, if I put, then the glinides, I am not comparing here it with the GLP-1 or SGLT2. So mind well, but here out of all the sulfonylurea, if we want to control, the glinides are safe as far as no previous myocardial infarction, those patients, cardiovascular death, or the patient who have MI, stroke, or cardiovascular death. The voglibose, it inhibits absorption of carbohydrates from intestine. The inhibitory activity on maltose and sucrose is 190 to 200 times, 70 times higher than a carbose. It reduces oxidative stress. Voglibose lowers the daily glycemic excursion. It increases the release of GLP-1 and had got a better safety profile in compared to other oral hypoglycemic agents. Voglibose prevents post-meal glucose excursion. It reduces post-glucose excursion. It delays intestinal absorption and carbohydrates. It also increases the GLP-1 level, which helps in delaying the gastric emptying and decrease appetite, and there is a weight loss also. Why repaglinide and Voglibose combination can be given? The combination provides better efficacy compared to monotherapy. It is a rationale for doubt in patients who have prandial regulators are needed. AGI modified rapid insulin release, which is induced by repaglinide with different mechanism of action. Both the molecules actually they supplement each other, and there is no evidence of clinically significant pharmacokinetic interaction between glinides and Voglibose. If you just see the data that along glinides, if compared to that, if you put the repaglinide and Voglibose, there is a significant decrease in the post-meal glucose level. As far as hypoglycemia is concerned, if you combine both instead of only repaglinide, the frequency of hypoglycemia is significantly decreased because sudden chance of post-meal hypoglycemia will be decreased by adding the Voglibose. So the combination have less risk of hypoglycemia and a better control also. So in which condition or useful condition when it can be used? The typical condition is a type 2 diabetic patient with CKD, and definitely the patient with irregular meal pattern or the patient who have high carbohydrate content, even after explaining the patient or nutrition counseling has been done. To summarize my talk, repaglinide with alpha glucosidase inhibitor, that's Voglibose, will provide better efficacy to control post-meal hyperglycemia. Both of them have a different mechanism of action. Therefore, combination will have a synergistic action, and no evidence of clinically significant pharmacokinetic interaction between repaglinide and Voglibose. Combination was weight neutral, had fewer hypoglycemia events than in compared to monotherapy. To take away from this complete debate, we all understand that diabetes and cardiovascular disease are both global epidemics, and we have to accept that as a person with diabetes, with a 72 years old guy, the patient should be given a choice of a therapy which is most CV safe and CV benefit. The post-meal glucose level itself is a problem with the patient with CKD, and it is again higher associated with CV and mortality risk and additional risk factor of hypertension and dyslipidemia. By adding alpha glucosidase inhibitor, we are benefiting the surrogate markers of CVD and maybe useful drug for reducing cardiovascular risk. By reducing postprandial hyperglycemia, by decreasing glycemic excursion, it improves vascular health, reduces oxidative stress, and prevents endothelial dysfunction. It promotes weight loss, it improves blood pressure and decreases risk of hypertension, it inhibits platelet activation, and it improves gut dysbiosis. In real-world data, it demonstrated significant lower risk with the use of AGA and glinides combination for risk of hypoglycemia, particularly in patients of CKD. With this, I thank, but I am sure if patient is referred to us, the patient with the adding the AGA and glinides with the fasting sugar, which is well controlled with insulin glargine, which is up titrated and getting the even fasting sugar less than 130. If the patient sugar is remaining more than 200, I think it is best choice to add these patients on glinides or AGA combination without increasing the risk of hypoglycemia. If patient is not accepting the GLP-1 analog, and which is in most of the situation, a person with a 72-year-old with a history of CKD will not accept the injectable and the costly therapy. So with this, I end my case, but I will be very happy with the discussion. Thank you.
So the house is open for discussion. I think Makar Sahib want to tell something. Makar Sahib. Bankim Bhai, would you like to add something? You were.
Can you hear me?
Unmute, I think. Yes, sir, please.
See, first of all, I would say I enjoyed all the three speakers, extraordinary discussion. And let me tell you one thing, that as the life expectancy has increased, now we see large number of diabetes type 2 patients with multiple morbidities. So it's a case by case dependent issue. See, basically, very difficult to give a guideline for one particular drug in one particular condition, because we come across large number of patients with large number of diseases in a multiple combination. So which drug is to be given, which drug is not to be given, sometimes very, very difficult. But let me tell you very frankly, I entirely agree in this particular given case, because data given are not that complete. What is the dose of metformin? I don't know. So first of all, I would say metformin, according to the EGFR, should be modified. Then you increase the basal insulin. And then GLP-1 analog, probably I would give the only factor I would say is cost. That gives me a little bit apprehension whether I should give it or not. And then in that case, I entirely agree with Bansi. Yes, the combination would have been better. But still, I would like to have a drug which is effective on fasting blood sugar. That is the only thing.
Thank you.
But otherwise, as I say, you have to go case by case. That's very important. Thank you.
Bhai, you would like to add something?
Sure. I think this was a topic of a debate where there was no debate. There is one thing that everybody is talking of science, and we expected more cross corrections or some talwarbaji, but kuch hua nahi hai. Kamal sir, my sorely disappointed, but Kamal physicians are always looking at one side and not looking.
Sir, talwarbaji ke liye aaj sham ko mil rahe hain dinner par.
That's what I'm telling. The physicians are always going by the science and they don't quarrel too much like our counterparts. You know whom we are talking about. But anyway, the point that is not discussed is about the SGLT2. We took as a whole, but do we have the all SGLT2? We can give it at the EGFR of 30-40. That is what I would ask Dr. Apurva Parekh, who is with us.
Yes, sir.
Yeah.
Yes, Apurva.
Yeah. I think, sir, Dapagliflozin, Dapa and Empa, we can give up to 30 only, except one, all the SGLT2 inhibitors can be given near GFR less than 40-30. Even up to 25 Dapa also can be given.
So now the new indication that SGLT2 inhibitor can be initiated even below 30. The latest data is up to 20, it can be continued. Before that, it was there that below the EGFR of 45, it should not be initiated. But if somebody is already on that, then it can be discontinued up to 30. With the data of DAPA CKD, now it is shown that even the benefit is continued. It is not as in glycemic benefit, but you think of the benefit of CKD progression halt. And that's a much better benefit of SGLT2 inhibitor. So here is the case with the 39, that SGLT2 inhibitor has to be there. It was already there. The patient was already on a metformin, and I'm sure it must be on reduced dose of metformin. Unluckily, I think the fasting plasma glucose return is very high, and that should not be case. The glargine, if it is already there, the glargine has to be up to the dose when the fasting glucose level should be less than 130 by all means. So a patient with 130, but in patient with CKD, you may see a patient with a post-meal glucose level of more than 250. So you believe that a patient with a more than 250 with a fasting glucose control and still 8.9 or 8.5 A1C. Now what to do for post-meal glucose to get control? So that was
प्रतिक्रिया देना चाहते हैं.
Yes, Pankaj, please go ahead.
We didn't discuss SGLT2 inhibitors because it was already in another session before. But the point I was willing to raise has been touched by Bansi, that SGLT2 inhibitors, they are excellent drug and they work very well even at GFR less than 30. And the advantages of SGLT2 inhibitors are more in the field of their cardiovascular benefit as well as renal benefits in EGFR below 30. Glycemic benefits goes down below 30, but renal benefits actually goes up. The problem is whenever we are using SGLT2 inhibitors at GFR of less than 30, it can lead to a precipitous drop in blood pressure and may not be tolerated very well by the candidate. So the expertise of a doctor or the doctor should be very high, very good at that level of EGFR to justify its uses over there. Glycemic benefits are lesser at that extent.
सर पंकज भाई, आपको तो बंसी ने हिंदी में से इंग्लिश में कन्वर्ट कर दिया बोलने में.
Can I help?
Whenever you are
Ashwin bhai, बोलिए. Please, Ashwin bhai.
Yes, yeah. After hearing,
it was very unique to have
Ashwin
Dr. Pankaj Agrawal speak in Hindi. काफी बढ़िया रहा और मुझे यही कहा गया था कि
डॉक्टर अश्विन इज आल्सो
सबसे बड़ा फायदा ये है कि थोड़ा मातृभाषा में भी वार्तालाप होगा और आपकी बातें सुन के काफी बोर प्रभावित हुए, काफी प्रसन्नता हुई और इस तरह का आगे वार्तालाप आपसे सुनने का मिलता रहे, आशा के साथ आपको जरूर वापस बुलाना चाहेंगे.
I want to add something. Jayesh bhai, can I help?
Please.
see, looking at all the discussions and looking at the given case, this patient does not require tight control of blood sugar, looking at his age and the conditions.
So 7.5 is required. No?
I agree with everybody, but it doesn't require tight control. Secondly, by increasing the doses of glargine insulin, we may invite hypoglycemia at any time because we do not know how is taken. And secondly, his weight may increase with the increasing doses of insulin. So there we have to take extra precautions so as to prevent these problems. Second thing that these type of patients have many times gastroparesis. They cannot tolerate GLP-1 so easily. So that required good explanation and to convince the patient that they have to consider like this or that. If I am to treat this patient by doing this, I would have added GLP-1 if patient is affording plus AGI, and if not affording, I would have added GLP-1 DPP-4 inhibitors plus AGI. Any of these could have give him the better results. But it has been observed that DPP-4 inhibitors, they are losing durability after some time. If so, then we may have to think something else. This is what so far I have come across.
But we are very happy that there was a wonderful
one. 279. Let us understand that this patient is 279 post-meal glucose level, and by adding only alpha glucosidase inhibitor, you will not able to decrease the post-meal glucose by 100 milligram. Here you have to think that you have to keep the target post-meal glucose less than 180. I am not putting the patient should go in hypoglycemia. The fasting I am keeping almost around 110 to 130, and alone EGI will not be effective to decrease from 278.
And even
in given case, now let us understand, if I put the patient on DPP-4 and EGI in a combination along with metformin and with the SGLT2, even if you put the DPP-4 and EGI also combinedly, you will not able to get this patient. So if I'm putting the definitely given situation, it may not be, it's a complete hypothetical situation, but still it will require a short acting, and that's the reason the glinides and the combination of acarbose or voglibose will be real effective to control the post-meal glucose level. And my target for this patient is 110 and 180. We don't want to decrease the A1C less than 7.5. By any condition, patient should not go in hypoglycemia. Then all points are well taken, but still we want to achieve the A1C of less than 8 at least, not 7.5. Patient is referred to us by a nephrologist or cardiologist. Patient himself had come to diabetologist only for getting control. He knows that his cardiovascular safety is already been taken care by Kamal Sharma. His kidney is already taken care by Apurva Parekh. He had come to us only for a glucose control. I don't want my patient to go in hypoglycemia, but at the same time, patient sugar has to be at control. Otherwise, why he has to come for a diabetes specialist? There is no reason for that.
I agree. The whole point of creating this debate was that we need to define not only that the sugar needs to be controlled, but how do you control also matters now, just the way it mattered in cardiology, in hypertension. Now, I think we also know in diabetology, what drugs you will use to control sugar will also matter. We can hear our nephrologist friend. What does he think about the three therapies? Apurva?
I completely agree with Bansi Bhai. Completely agree.
I have a question for all the endocrinologists. We change the glargine to either a high potency glargine or a different long acting insulin to control both fasting and PPBS.
No, sir, I would not do that. I think glargine is a good insulin. I think, there is a lot of noise level from other insulins to say that A is better than B. In my experience, as long as you titrate the patient to, like Dr. Bansi sir said, to a fasting sugar of 110 or 120, you are not inviting hypoglycemia. In fact, this patient would not have hypoglycemia if the basal insulin is titrated effectively. I'm not worried about that. And one thing, I'll say that in my opinion, the newer basal insulins give more of convenience rather than, the edge in terms of glycemic control. I think glargine is good enough for as an insulin to control the, the fasting sugar. And I think it should be the only thing we need is a good titration here, and that is the main thing we should be doing here. I think, Dr. Bansi sir, I don't know if you noticed this. Maybe a few years back, we are having a debate, similar debates.
I know.
Yeah, I think one of the best thing here is that at least, I would say, I would consider this a moral victory. But at least, in this debate, there is no debate about sulfonylurea.
I agree with you, Om. And as Mahadev Bhai's comment was on the second generation basal insulin, they are not more potent. Rather than I will also go continue with the glargine. And here there is an advantage. This patient is already having 1.7. So, you know, the glargine will also act for more than 24 hours. So there is no reason why you should change the basal insulin just because patient had a creatine of 1.7. If you are worried of midnight hypoglycemia, if there is a documented hypoglycemia, if you are putting the patient on continuous glucose monitoring and you are finding there is a hypoglycemia, and then you want to change to the newer basal insulin analog, that's fine. Otherwise, glargine is good enough and there is no reason. As he told very rightly that in some of the patients where we use newer insulin are only for the purpose of flexibility because that's for convenience. They don't want to take the insulin at the same time every day. And that's the only reason why we go for the, instead of glargine, maybe glargine 300 or degludec.
One small point I will like to add with the permission of chair is the concern with all insulin is hypoglycemia. The major concern is to rule out midnight hypoglycemia. So in such type of precarious patients where midnight hypoglycemia could be very much deleterious, we can use, and I regularly use, Lantus or glargine insulin in morning hours. I understand that the effect on the fasting hyperglycemia, the hepatic glucose output would be lesser when it is used in morning hours, but it reduces, number one, midnight hypoglycemia chances. Number two, it increases, it gives an edge over the postprandial control as well in the after lunch hours or so. So in all patients at risk of midnight hypoglycemia, this insulin can very well be used in morning hours. It will be safer, and in offering postprandial control, it will become more efficacious as well.
So it was a very wonderful discussion. I think I should make the end of this session, and I'm thankful to all speakers, everyone. आपका भी बहुत अभिनंदन, धन्यवाद. Thank you so much for attending this, and we really enjoyed the whole discussion. Now we'll go to another bout, second bout, which is bout number 23. It's related to stable coronary artery disease, and I would like to invite for this session, I am going to invite Dr. Surendra Gupta from Palanpur, where I work, Dr. Shabbir Gadi from Ahmedabad, Rajiv Sabnani, again from Ahmedabad, Dr. Uttam Chandarana, Dr. Nilesh Patel, and Dr. Kamlesh Fatania, our President, Association of Physicians of Ahmedabad. I would like to request Dr. Kamlesh Fatania to kindly introduce our speaker. Dr. Jasraj Panwar.
Chairpersons, please introduce all the three speakers and then the case, and then we go to the discussion.
Okay. Dr. Jasraj Panwar from Kadi, Ahmedabad. He is MBBS MD DM Cardiology, Interventional Cardiologist at Kadi and Ahmedabad. Our next speaker is Dr. Dharmadeep Humane. He is MBBS MD DM Cardiology, Mumbai. He is cardiologist and interventional cardiologist and consultant interventional cardiologist at Pratibha Hospital, and currently working and consultant cardiologist at Lifeline Hospital. And our next speaker is Dr. Rutvik Trivedi. He is consultant interventional cardiologist at Zydus Hospital, Anand. He had done MBBS, MD, and DNB cardiology from UN Mehta Institute of Cardiology and fellowship at Complex Coronary Intervention from South Korea Interventional Cardiology, UN Mehta Institute of Cardiology and Research Center. And he is also from European Society of Cardiology. So I would like to invite our first speaker to give a talk.
Dr. Jasraj.
Jasraj sir.
Please remove your earphone and then be connected with your devices. Please change the desktop setting for this.
Sir, there is some problem with your voice, sir. Dr. Jasraj.
Dr. Jasraj, we can't hear you.
Am I audible, sir, now?
Yes, you are audible now. Can you share your screen?
Yes, yes. My screen is visible?
Yeah.
Yes. Good evening, respected teachers and colleagues. Thank you very much, Dr. Kamal Sama, sir, giving me such a great opportunity to speak on.
Sir, वो mouse नजदीक रखिए, sir.
Yes, yes.
Can you please share your screen?
I'm sharing my screen, sir.
Stop sharing and then again reshare.
Okay.
જયેશ ભાઈ તમે ચાલુ રાખો યાર જયેશ રાજ જસરાજની જગ્યા.
Jasraj, you can move to the second session. Then, Jasraj, in the meanwhile, you can send your presentation to the RX events. You can WhatsApp it in the group. They will present the slides and you can speak. Meanwhile, we can move to second case, second presentation by Dr. Dhamdeep.
Okay.
Dr. Dhamdeep is there? Is he ready? Yes. Dr. Dhamdeep.
Sir, unmute yourself.
Yes, hello. Yeah. So, good afternoon, everyone. Good afternoon, sir. Myself, Dr. Dhamdeep. So, should I read the case also? I'm presenting a 70-senior male with history of old inferior wall MI. With he had undergone CABG 4 years back for triple vessel disease. He has an occluded SVG to OM graft, but patent SVG to RCA graft and Lima to LAD. So stress radionucleotide imaging was done, which showed that there is mild reversible ischemia in LCX territory. His LVEF is 45%. He has class 2 angina with class 2 dyspnea on glyceryl trinitrate 6.4 milligram twice daily, apart from dual antiplatelets and hydrostatin. He's already on metoprolol 100 milligram and ACE inhibitor and diuretic. He is resting heart rate is 78 beat per minute with a blood pressure of 106 by 70 millimeter. He has occasional VPC on ECG. So the preferred modality of next line of anti-anginal would be. So now I just want to stress why angina is so important in our case, because the recurrent of angina that will give rise to increased ischemia, and increased ischemia will result in higher mortality. So why we must use newer anti-anginal drugs? That is because the first line drugs like beta blockers, calcium channel blockers, nitrates, they have been not able to control angina in quite a few subset of patients who have stable coronary artery disease. So this is because of the beta oxidation of free fatty acid pathway and late invert sodium entry current. These two pathways, they can cause angina because of ischemia. So this is free fatty acid oxidation, then the trimetazidine ranolazine, which inhibit the beta oxidation, and this beta oxidation can lead to acetyl CoA, which leads to pyruvate to lactate. Lactate can cause acidic milieu in the intracellular environment, which can further precipitate the ischemia. So this is in ischemic conditioning. As we know that heart uses both glucose and fatty acids. So in ischemia setting, there is this increase in free fatty acid, that beta partial oxidation of free fatty acid, which will lead to accumulation of lactate, which will further lead to acidic milieu and will cause increase in ischemia. So this is how I was talking that the next is how late invert current sodium prolongation can cause ischemia. This is the channel which will keep on opening for longer time, which will lead to sodium overload. So because of the sodium calcium exchanger, which lead to calcium overload. This will result because of the increased intracellular calcium. It will cause diastolic relaxation failure, which will cause diastolic stiffening, which will further lead to ischemia. So the ranolazine inhibits the inward sodium current. So ischemia begets ischemia. So what is the outcome of diastolic stiffness? So this results in impaired coronary blood flow during diastole due to diastolic stiffness, increased ventricular diastolic wall stress, and end diastolic pressure. So what are the benefits of ranolazine? Ranolazine blocks late inward sodium current. Thus, by blocking the late inward sodium current, there is reduction in calcium overload and decreased diastolic wall stress. So along with this, it also causes partial free fatty acid oxidation inhibition, which contributes to its superior anti-anginal efficiency of ranolazine. So this is just pharmacokinetics, that it is orally available. Elimination, it is eliminated by cytochrome P450 enzyme. So this is the diltiazem, ranolazine, and verapamil have significant interactions. So those drugs which cause increase in QT prolongation, they are almost like not used in patients who are on ranolazine. So simvastatin. So this is like Marisa trial, in which it showed that ranolazine, it increases your exercise performance at 500 and 1000 milligram BD dose at trough and as well as at the peak of exercise. This is a data from Cariza trial, in which showed that ranolazine along with beta blocker or a calcium channel blocker can increase exercise type at trough and as well as peak. Again, this data shows that it reduced weekly anginal attacks and nitroglycerin consumption. ERICA study. This is a study with chronic angina in patients who are having subset similar to our patient who had a history of coronary artery disease, stable angina, who were on anti-anginals, first-line anti-anginals, and their angina symptoms were not controlled. So we moved on to second-line anti-anginal drugs. So in this, ranolazine was found to reduce anginal events as well as increase exercise tolerance. This is that it is heart rate and blood pressure neutral, that it doesn't decrease blood pressure or it doesn't reduce heart rate. So ranolazine is effective as atenolol, that is the first line anti-anginal, in reducing the time to onset of angina, that it increases your exercise duration and the exercise capacity is increased. Thereby, your insulin resistance is also sensitivity is increased. So anti-anginal and anti-ischemic efficiency of ranolazine. So it is dose and plasma concentration dependent. So now if the anti-anginal action is not actually 500 milligram, then we can increase it to 1000 milligram BD dose, consistent throughout a broad population of chronic angina patients. There are almost like 5 major trials which have shown that benefits of ranolazine in stable angina patients, not dependent on decreasing blood pressure and heart rate. In our patient, the blood pressure is 106, so we don't want it to drop down further, and the heart rate is around 78, as great as atenolol. So the safety, like except for Torsades pontis, which is has been shown in there is a theoretical risk, but it in clinical trials or in real world data, there are no reported cases as such. But obviously, if used with drugs which cause QT prolongation, then ranolazine cannot be used. So this is ranolazine summary, that it causes metabolic modulation. This is a newer pathway for our angina control. It causes reduction in inward sodium current, does not affect blood pressure. It is heart rate neutral, extends exercise ability, reduces angina frequency, reduces nitrate consumption, is well tolerated anti-anginal drug. So now we are moving on to that. We have two options, ranolazine and trimetazidine. Trimetazidine is another metabolic modulator. So along with that, ranolazine has one additional mechanism of action, that it causes inhibition of late sodium entry, which is another important mechanism for angina, and as well as it helps in decreasing your arrhythmia events. So in trials, it has shown that along with anti-anginal, it has anti-arrhythmic property as well. So ranolazine can be preferred. Ranolazine has been found in trials to reduce the HbA1c in patients. So how does it do it? By increasing your exercise capacity, by increasing your insulin sensitivity. So patients' physical activity is increased, thereby reducing the calories. So now about ivabradine, it is a funny current inhibitor. It causes reduction in heart rate, and ivabradine inhibits the pacemaker IF current in dose-dependent manner. So blocking this channel reduces cardiac activity, slowing the heart rate and allowing more time for blood flow to myocardium. So it is indicated in symptomatic patients of stable angina pectoris with normal sinus rhythm. So understanding ivabradine, now in beautiful trial, it has showed that it is
last 1 minute.
Yeah. So it causes decreased it doesn't improve your heart ejection fraction. So this is another real one trial in comparison of ivabradine with ranolazine, in which showed that both have similar efficacy, but ranolazine has better tolerant profile. So I will say that ranolazine kills 3 birds with 1 stone: arrhythmia, ischemia, and diastolic dysfunction. So now if one wants to add second-line anti-anginal drug, then definitely ranolazine, which is a US FDA approved agent, is my choice for anti-anginal in this patient. Thank you.
Yes, wonderfully spoken. Kindly remain with us for discussion. I would like to request Dr. Jasraj if he is ready with the presentation. Dr. Jasraj, are you okay, sir? Dr. Jasraj.
Hello. Yes, sir. I'm audible.
Just bring that mouthpiece near your mouth so that we can hear it properly. Yes.
Hello. Yes. Good evening, respected teachers and colleagues. Thanks, Dr. Kamal Sharma, sir, for giving me the opportunity. In about 23, we have stable CAD. We have a case scenario that is a 77-year-old female with history of old MI and angio triple vascular patient undergone CBG 4 years back. Now, patient has the angina class 2 symptoms and was evaluated and found to be occluded LCX graft. Now the patient is on a GDMT and heart rate of 78, blood pressure 106/70, and occasional revision ECG. Now we are discussing what is the next preferred anti-anginal drug to control his anginal symptoms. Next, please. Now this is a 2019 ESC guideline which states that all second-line anti-anginal drugs, including ivabradine, ranolazine, and trimetazine, they are a class 2A indication, level of B. Next, please. Ivabradine is the preferred add-on due to class 2 symptoms on background of old MI with high heart rate and LV dysfunction on GDMT, according to me. Next. At the point we will discuss that do we really need to add any drug as an anti-anginal second-line drug? In this case, why not to just increase the beta blockers, as the patient is having 100 mg of the metoprolol, and we can go up to the 200 mg of the metoprolol to control the symptoms. Wouldn't that just suffice? So we have some evidence. Next. We have a study, control 2 study, which state that efficacy of the ivabradine in combination with the beta blocker versus uptitration of the beta blocker in patient with stable angina. In this, we have patients with the same age group, with the same past history of the MI, CABG patient with same risk factors, and they were all from the they were all on optimal medical guideline therapy, including beta blockers, DAPT, and statins, and they were on the most commonly used beta blockers, metoprolol and bisoprolol. So next. In this study, we can see the divergent curve that adding ivabradine on beta blocker has a good outcome as compared to the increasing the beta blocker dose. Even side effect profile like including hypotension, fatigue, dyspnea, and bradycardia, they were more common with the beta blocker dose up titration. instead of using ivermectin and beta blocker. So in conclusion, next please. Next. We also have several other papers which also state that ivermectin plus beta blocker demonstrated good tolerability, safety, and a more pronounced clinical improvement as compared to the beta blocker titration. Next, please. These two studies, associate and addition study, they also study the same phenomenon and found the add-on therapy ivermectin was effective and well tolerated, independent of the PCI status. Next. So point two, do we really need to address this class 2 angina, as the SD score in our patient on SPECT was 3. That is a mild, between 2 to 4, it is a mild SDS score. And as interventionalists, we can think about the fixing the blocks, but in this mild SDS score, we can offer patient the medical management. So really we do need to address the class 2 angina in this patient. So we have evidence. Next please. We have clarified registry in which the 34 patients were studied from the 45 countries and followed for the 5 years, and they included the same class of patient, like more than 3 months history of either old MI, class 2 angina, dyspnea, old PC and CBG. Next please. And in here we in this Kaplan-Meier curve, we find that the patient having a prior MI have more CV death and MI, and even among the having MI patient, those which were symptomatic with angina have more incidence of the death and so on. So it clearly showed we need to address this class 2 angina. Next please. Point 3 is we don't think that the beta blocker and ivermectin are the same. Ultimately, they both are causing the benefit by decreasing the heart rate. So we have evidence that the ivermectin is better than beta blocker. Next please. Next, we have one study back. We have one study. We studied the ivermectin and bisoprolol on Doppler-derived coronary flow reserve in patients with stable coronary artery disease. And here we find that both the drugs decrease the heart rate at the same level, but the coronary flow reserve was very well demonstrated with the ivermectin. Ivermectin increases the hyperemic coronary flow reserve to a greater extent than the bisoprolol, despite having a similar heart rate reduction. Next, please. So the factors which may have contributed to the superiority of the combination treatment with ivermectin plus beta blocker over the uptitration of the beta blocker input. The beta blocker increases the perfusion of ischemic area by prolonging diastole, but it also impairs the IVRT and thus offset the part of the benefit in terms of diastolic pressure time integral if we increases the beta blocker dose. Ivermectin reduces the entry of the sodium by funny currents at the pacemaker cells and ultimately reduction of the cytosolic calcium, and thus decreases the pacemaker current and improves the reuptake of the calcium by the circular reticulum, leading to an improvement in the ventriculation also. And ivermectin also have some additional effect also, additional pleiotropic mechanism, like it's also decreases the reactive oxygen species in cardiac myocytes. It also maintains and improves the coronary flow reserves, and it's despite patient on atrial pacing, ivermectin effect can be observed, which is the we cannot see in the beta blocker dose. Next, please. Next. So ivermectin is not just a pure lowering the heart rate or IF current inhibitor. It's it do not have negative inotropic and lucitotropic effect, and it do not affect the cardiac ionic channel. Ivermectin does not unmask the alpha-adrenergic vasoconstriction, unlike the beta blockers, and maintains the coronary dilatations. It does not decrease the blood pressure, contractility, and AV conductions. Specifically, it does not alter the QT prolongation or repolarization and conductivity or effectivity of the ventricle and its pancreas system. Next, please. So we have a pleiotropic effect on the heart, decreases the heart rate, maintains the myotropic, decreases the ROS, and by this slide we see that heart rate is the main contributor to the ischemia event. So by decreasing the heart rate, we can reduce the ischemic symptom. Heart reduction by 10 beats saves the 5 kg ATP per day. So heart reduction can improve efficacy of the heart. Next, please. Next. So benefits of heart reduction with ivermectin we can see in both CAD and heart failure patient. In CAD patient, the reduction of the oxygen demand in myocyte reduces the energy requirement and reduces the ischemia and angina. In heart failure, it increases the perfusion in the coronaries, reduces load on the heart muscles, and improves the heart muscle function and prevent the worsening of the heart failure. So we have benefits both stable CD as well heart failure patient. Next. So we have a spectrum of evidence from clinical trials in variety of clinical scenarios. It is also effective as a monotherapy versus over beta blocker and CCB. As an add-on therapy, we have discussed the associated addition and control 2 trial, where the addition of ivabradine to beta blocker is better than a titration of the beta blocker. We have also studies which about the impact on the coronary outcomes like beautiful angina subgroup and SIP and Signify study, which will be discussed next. Another point 4 is, does ivabradine affect the hospitalization outcome in patient with CAD, angina, and LV dysfunction? So we have an evidence about this hospitalization CV mortality. Next, please. So this is the beautiful study which was studied in the patient of heart failure and angina and LV dysfunction, and patient was having heart rate more than 70. In beautiful trial, we have subgroup post-hoc analysis in patient which was having angina symptom. The data shows that there was the reduction in the primary endpoint, hospitalization for MI, hospitalization for MI in case of more than heart rate more than 70, and coronary resolution was also reduced. Next, please. So here in Kaplan-Meier curve, we can see that adding ivabradine decreases the event rate for hospitalization for fatal and non-fatal myocardial infarction. Next. We have another study from SIP trial, that is a randomized double-blind placebo-controlled trial where the 6,500 patients were studied, and to test the hypothesis that the heart rate slowing with ivabradine improves the CV outcome. This study also the same group of patients which we have in our case scenario, like class 2 angina, left ventricular ejection fraction less than 35%, sinus rhythm, heart rate more than 78, and patient was on GDMT, and hospitalization for worsening of heart failure within the prior 12 months. Next. So the data shows that adding the ivabradine in this kind of patients decrease the primary endpoint, secondary endpoints, as well as the heart failure hospitalization and the recurrent heart failure hospitalization. Next. So in conclusion, in SIP trial, heart reduction with ivabradine in patient with heart failure and heart rate more than 70 beats per minute and on GDMT substantially decrease the risk of clinical deterioration as reflected by reduction in total hospitalization, incidence of recurrent heart failure hospitalization, increase in time to first and subsequent hospitalization. So thus the benefit reduces the total burden of heart failure for the patient and can be expected to substantially reduce the healthcare cost. Next, please. So does the ivabradine reduces the CCS or NIH class of angina? Evidence is there. Next. So we have a Signify trial where the ivabradine
just for last 1 minute, please.
Yes, sir. And in Signify study, it was a negative trial regarding the CV mortality and fatal MI outcome and all, but it also showed that it reduces the angina event with a significant p value. Next. I will. To conclude, ivabradine has its own distinct set of beneficial effects, not just another heart rate lowering drugs. Combination of beta blocker and ivabradine is superior to beta blocker titration alone. More is not necessarily better. Ivabradine has shown to decrease the outcome patient with a stable CAD, LV dysfunction, angina, heart failure. In patient with a limiting angina on GDMT, it will be the second line of anti-anginal drug. Thank you.
Dr. Rutvik, we can share your presentation.
Yes, sir. Am I audible and visible, sir? Hello.
Yes, you are. Go ahead, please.
Yeah. Fine. Thank you, Kamal bhai, for this opportunity and congratulations for the grand success of the CADCon. The case is about a 77-year-old male who had MI, CAPG, one graft is failed, he has mild angina, SDS score is 3. The important points are the ejection fraction, which is 45%. He's on a metoprolol, 100 mg, not on a maximum dose. AC inhibitors were given. He's on diuretic, probably because of his mid-range ejection fraction, heart failure condition. The rate is 78. So the one speaker has already justified the role of ivabradine The other speaker has also tried to justify the role of renolazine. That is on the basis of VPCs which were noted. Now, important points to consider here, and I will take these points forward as my presentation flow continues, that ejection fraction is 45%. That is one thing. The anginal symptoms predominates mostly. That is what the history-wise it looks. Is a non-diabetic patient. The VPCs are present. Is on 2 anginals, beta blockers, although on a lower dose, but on a almost maximally tolerated dose of nitrates. And is on diuretics. And I think the renolazine, we know that it increases the QT prolongation. The risk of hypokalemia is there. So that few points one need to consider. Now, do we need a drug which has a different mechanism? And that points were highlighted by Dr. Damraj, that conventional drugs, they act on 2 pathways. One, by decreases oxygen demand, and the beta blockers, calcium channel blocker, and even etabraline on that sense reduces the heart rate. The second group of drugs, we know that they are vasodilators, and by increasing the coronary flow and by reducing the microvascular resistance, they try to benefit in terms of anginal relief of symptoms. Now let us take ivabradine, and I think the previous speaker has tried to justify the role of ivabradine, but the most impactful trial, if you look at the data-wise, the one is the Beautiful trial, and the important part here is the ejection fraction was less than 40. So that point is very important. All the patients which were included in the Beautiful study, which was a landmark study, they quote that the ejection fraction was less than 40. Here the ejection fraction of the patient was more than 45. So I don't think that one should apply that rule to our patients. Second study was the SHIP study, which was also a very landmark study. The ejection fraction of that patients were less than 35%. And what I would like to highlight here is that after the Signify study, people tried to look into the matter and tried to find out why the Signify failed, why the others were quite successful in terms of hospitalization. And they found that there are different mechanisms to basically understood in the management of the coronary patient. So the SHIP study, the ejection fraction was 35% and lower, and the predominant symptoms were heart failure. Beautiful study also had ejection fraction less than 40%. Now, if you look at the Swedish heart failure data, what they found that most of the patients, those who were on 2 groups, one group, sorry, so one group of patients were having a SHIP protocol, one group was having a non-SHIP protocol. And in non-SHIP protocol patients, most of the patients were not on a maximum tolerated load, that is 50% doses of beta blocker. So that is one point which was noted. And they also noted that 14.2% of the patients were eligible for ivabradine, and over a period, those patients who are basically eligible for that becomes quite negligible. So unselective use of ivabradine was considered as a non-futile exercise, and there were more side effects which were noted. Now, Signified study, and Signified gave us a lot of insight. They tried to look the outcome in a patients who have primarily a stable angina part, where the heart rate was more than 70, angina was present, the ejection fraction was more than 40. So our patient had ejection fraction of more than 40. In fact, it is a 40. And this study showed that ivabradine added to a guideline-directed medical therapy did not improve the outcome in patient who had a stable coronary artery disease without clinical signs of heart failure. And there is a signal for an increase in the risk of cardiovascular event among the patients with angina who are in between class 2 to 4. And given that the primary cardiovascular effect of ivabradine is to reduce the heart rate, this result suggests that elevated heart rate is a marker of risk in CAD patient, but not a modified detrimental outcome in patient who had a stable coronary component without heart failure. So how to explain this discrepancy between a signified Beautiful and SHIP? So the reduction in heart rate in patient with angina on top of beta blocker, which is almost 87% dose being used, is ineffective. And the myocardial metabolism in stable CAD and LV dysfunction were different, and they were rate sensitive. So in angina, the heart rate is reduced to adapt the energy production to oxygen delivery. In heart failure, the heart rate is reduced to adapt the energy consumption to ATP synthesis. In LV dysfunction, without or with CAD, elevated heart rate is a modified risk factor. Whereas in stable CAD with preserved ejection fraction, elevated heart rate is a risk factor, but the myocardial metabolism adaptation in heart failure is quite different than a normal situation. Heart rate reduction in angina and heart failure result in a two different situations, which are actually explained by different metabolic backgrounds. So in line with the significant registry, and if we look at the data by Shripal in 2011 and 12, and a recent article which was published in 2018 in JACC, even those patients who are on beta blockers with stable coronary artery disease with normal ejection fraction, they at the end found that there were no data to support the usage of long-term high doses beta blockers because it did not reduce the mortality. So that was a point one need to understand. And on the same line with the signified, that it follows that the signified data are not so counterintuitive. What was wrong was the perception that the heart rate reduction is cardioprotective, not only in the animal experiment, but also in the human with a stable CAD, a perception that had in fact never been confirmed in a proper randomized control trial. And that could be the reason the signified showed that only chasing the heart rate was not a futile exercise. And even with the beta blocker maximum, bearing the small trial which was quoted, I think we don't have that long-term data. And that too, I again record that Shripal Bangalore has clearly showed that in a patient with stable angina with normal ejection fraction, even a beta blocker has not reduced the mortality. Now coming to renolozine, a wonderful drug, we all know. Late sodium channel inhibition was this primary action which was proposed, and later on came to the actions which were fatty acid oxidation inhibitor. But in a CARIZA study, which was having a substantial number of patients, here the beta blocker usage was 45%, diltiazem, amlodipine usage were almost 43, so almost 80% of the patients were on other medications. And later on, it is proved that using this drug with the diltiazem and other CYP3A4 inhibitors, there was a substantial side effect, which was a QT prolongation, which was noted. However, with the beta blocker and renolozine, the exercise duration increase was not that substantial. In fact, the side effects which were quoted were very high. We have 3 studies, and all the 3 studies, that's constipation, syncope, asthenia, dizziness, weakness, headache. See, old age, 77-year-old male can have all these symptoms which are quite cumbersome. So, in fact, in ERICA study, the side effect rates were in 39%. So, the Merlin trial, which was in ACS patients, 28% of the patients discontinued the therapy. The other mechanism which was not been proven, say prevention of chronic AF, new onset AF, post-operative prevention of AF. So we don't have that data. All are basically individual supported data, which we generally follow in the current scientific era of medicines. Renolozine as quoted QT prolongation, and this patient had a VPC. Now, do you want to inhibit that VPC? Because previously we have very low, we have trials. In fact, in the patients who have ejection fraction of less than 40 with the VPC, we have a CAS study which has failed. We have SWOT study with the sotalol, it has failed. We have studies with the abiraterone, it has failed. So our patient had ejection fraction of 40%. So why do you want to chase on VPCs only? Because VPC treatment will not modify the mortality part. In fact, you in an elderly patient on diuretics will give rise to more long QTC and other complications. So that is why it is good drug, I will not like it. Now coming to a trimetazidine, and this picture, we know that it is a very popular picture. It is a Camilla, and Camilla was banned from a recent Chinese Beijing skating event because she took trimetazidine, and trimetazidine increases the exercise endurance and decreases the fatigability. This was quoted by American College JACC editor. So we know that trimetazidine increases the endurance. Now coming to cardiovascular benefit. So should we add trimetazidine with a beta blocker? We know the mechanism, in fact, that has been quoted by the first speaker, that the fatty acid during resting condition is the primary mechanism which we get our the cardiac cells get the energy, but it is not basically a very efficient pathway because almost 20 to 15% more oxygen is needed to generate the energy when we compared with the fatty acid. But what happens to ischemia? That ischemia diverts the mechanism towards a glucose oxidation pathway. But in ischemia, what happens is ischemia inhibits that pyruvate dehydrogenase, and because of that, the fatty acid pathway predominates, even though we wanted it to be on a glucose pathway. So from glucose, it goes to pyruvic acid, and from pyruvic acid, it goes to lactate, and there will be more acidosis. Even though we want a glucose pathway to become predominant, it's not going to happen in ischemia, and the pre-acid pathway will continue. And we know that pre-fatty acid pathway will basically need more oxygen for the ATP generation. So here there is a need that the drug which has a different mechanism of action without side effects and maximum tolerability should be in the line. So what this trimetazidine do is trimetazidine inhibits these three ketoacyl OS, and that inhibits your fatty acid oxidation and try to switch towards a glucose metabolism pathway. So there is 33% more ATP per oxygen millimole. There will be 6.4 ATP with the glucose oxidation compared to fatty acid oxidation. We have studies for CAD triple study. I'll not go into the detail, but it has clearly shown that it has reduced the episodes of angina, it has reduced the need of nitrate, and it has good quality of life. The triple at 12 weeks of and it showed that it improves the function. Choice 2 studies again for the anginal patient, and it was age was up to 90 years, and it was well trained. So it has also shown that significantly reduces the anginal episodes and need for nitrates. So trimetazidine also protects. Our patient was a post-CABG patients. They were graft dysfunction, both obviously a venous graft, but we don't expect that remodeling. But it has shown that it reduces the endothelial dysfunction. Even JAPI, this Indian guidelines has also showed that it has to be second-line agent to be used in the patients who failed on a primary agents. European Society has updated guidelines class 2A. Addition, it will also help in LV remodeling. It improves the ejection fraction. Although small study, it reduces the anti-proBNP. It increases the exercise duration, and the PCR to ATP ratio, which is a marker of mortality, it increases. So lower the ratio, increase the mortality. So there was almost 33% increase, which was noted. So adding this drug to beta blocker will give rise to maximum benefit. 77% reduction in the anginal episodes were noted. So one maximum dose of beta blocker, if you look at the mechanism of action of beta blocker, which also improves the calcium handling, adding ranolazine will not be a great futile exercise. We need oxygen, we need ATP to reduce the anginal episode and improve functional capacity. So I'll skip that slide, and at the end, what I like to do with my patient is 77-year, ejection fraction 45, class 2 angina, is on 2 drugs which we have used. We have an opportunity to increase the dose, but in ejection fraction more than 40%, ivabrudine indication has not been justified. Same way, for the sake of VPC inhibition, where the role of ranolazine has not been justified, should not be added. And the third mechanism, which is the drug which enhances the endurance, exercise duration. We had the Olympians, those who have a healthy heart, their functional capacity improves. So obviously the heart failure patients and anginal patients' capacity will definitely improve. So our patient is 77 years, and we all want a reduction in anginal episodes and increases the functional capacity, and that will definitely achieve with the trimetazidine. Thank you.
The forum is open for discussion if there are any questions or anything.
Yes, I think all the speakers had made a good justice to their topic. The question was very reasonable. All the points by 3 speakers have been taken very well. They have done good justice to their topic.
Oh, I would like to give a comment. All the 3 did well, and I think if I am a treating cardiologist or a physician, I would have gone for a combination of Jasvik, Jasraj, Jasdeep, or Rutdeep, Rutraj, and same way Damraj or Damvik. So at the end, I would like to say all the 3 molecules I would have given if the pill burden and the cost would have permitted. All the 3 molecules are good enough. So all the speakers, they have justified very well. Any combination, either of them or all of them, they are good and can be prescribed, as I said, if pill burden and cost permits. Thank you.
I have one question here. There is another symptom in the patient that he has class 2 dyspnea also. So how do we attribute this symptom, whether it is an angina equivalent or it is a part of failure? So if we consider it as a part of failure, then I think beta blocker is the only drug which should be increased in this case. Any comments on this? All three drugs will take care of angina, that is fine. But what about dyspnea?
1 minute.
So if dyspnea is primarily a symptom of heart failure, you have evidence more for ivabradine. If you're looking at heart failure in systolic format, also maybe there might be some evidence for diastolic heart failure. But if it's a manifestation of angina as an angina equivalent, then probably you have more evidences for ischemic remodeling for trimetazidine. So that's why it's deliberately kept in a fashion to define the therapies. Heart rate and LV dysfunction would drive it for ivabradine. Arrhythmias would drive it for ranolazine, and LV dysfunction and remodeling would drive it for trimetazidine. Otherwise, I think you can choose either of the three evidences are equally strong, or you can say equally weak for all three beyond the classical anti-anginals.
Sir, can you guide us that what is the point of time when one should add ivabradine or ranolazine or trimetazidine?
Yeah, I think once you have, as I said, EF is less than 40 and heart rate is more than 70, choice is ivabradine. If you have VPCs and you have a lot of VPC burden, ischemic burden, and LV dysfunction or no LV dysfunction, stable CAD, then ranolazine. And if you have acute coronary syndrome, NSTMIs recently, which is now going towards stabilization, and you have ischemic remodeling, which you have to look for, then trimetazidine. Only thing that you should remember with trimetazidine is in elderly, it can mimic Parkinsonism, or it can bring out Parkinsonism early. So in elderlies, my threshold for trimetazidine would be a bit high. Otherwise, in those patients, I would go for ranolazine or ivabradine. In acute MIs, recently revascularized, left out a branch, secondary angina, ischemic remodeling, young patients, my choice would be trimetazidine. So, and renal failure. So these are some of the subgroups where you have more data for each of them. But ATPCI is one of the recent trials which a lot of people were barking on, which actually failed for trimetazidine. That's why otherwise trimetazidine would have come ahead of the other two therapies. Ivabradine, of course, from SHIFT, we have data for heart failure. And that's why when you have LV dysfunction coming in, ivabradine is the therapy of choice.
Thank you, Mr. Thanks a lot.
Can I ask the speakers that can we be more aggressive and try for a combination of ivabradine or ranolazine, or ivabradine and trimetazidine?
In fact, if you look at history-wise, if someone want to add, we have a data with SGLT2 also with the preserved ejection, mid-range ejection fraction, so less than 40. Almost the ejection fraction is 45, we can try with the SGLT2 also. I would be quite skeptical using this ivabradine in a normal ejection fraction. In fact, if you read the initial literature with the ivabradine, they have in a contraindication lead with the preserved ejection fraction is a contraindication of ivabradine. In fact, ivabradine, a lot of people have used just for the sake of control of the heart rate in the ICU patient with the many conditions, even the recent COVID era also, and there were lot of QT prolongation and VPCs were noted. So with ivabradine, the indication to me is very reasonable. It has to be a LV failure predominating the symptoms rather than a ischemic symptom, because we have a data, and as I told you, that beta blockers, if you look even with the preserved ejection fraction data, the mortality benefits will not been observed. You can read a data by Shripal et al. And you can read a JAC article which has been published in 2018. So they also raised the same question that in CAD, are we have enough knowledge to treat this disease? So on that also they were very clear. So ivabradine on that part, I would be quite skeptical. Kamal bhai said about Parkinson's disease, it is reported, it is very low. In fact, the restless leg syndrome was very low. In fact, the commonest side effect with the trimetazidine was the gastric upset. And I would be skeptical in using elderly patients just because their creatinine are very high or eGFR is low. The side effect rates are very high. Ranolazine, I would say I have not seen the adverse effects which were mentioned in the textbook, even though the adverse effect rates were quite high in the studies which is mentioned, but personal experience with the ranolazine is good. The only problem is the QT prolongation. And if you look at the profile of the patient, if the patients are on diuretic and SGLT2, theoretically you have chances of electrolyte imbalance. So the combination with trimetazidine and ranolazine would be reasonable scientifically, but ejection fraction of 45, I would be not very keen to treat that beta blocker up titration or heart rate titration very aggressively, because the asthenia and the weakness and fatigue will predominate. So that would be my answer. In fact, SGLT2 and high dose of statin, patient as already on high dose of statin, I would be happy to have SGLT2 on the board, because we have 2 studies with the ejection fraction of the mid-rate and heart preserved ejection fraction, and that has shown the reduction in hospitalization for the heart failure. So that part should be considered.
Yeah, patient has a class 2 dyspnea also. So,
so Kamal has clearly answered. If you feel that that is because of angina, I think you can add this. If you consider it is a heart failure, because patient was on diuretic, and diuretic we take it as a heart failure with mid-range ejection fraction. So mid-range ejection fraction with the heart failure data, if you are taking this patient on board, I think I will be happy to have trimetazidine first rather than ivabradine, because we don't have a data with ivabradine with a mid-range and preserved ejection fraction. So all the studies have ejection fraction of less than 35 and less than 40. So not for the mid-range ejection fraction, and as again record, it is not been proven in a preserved ejection fraction patient. So that is why my thinking on that part becomes very clear on that part. Ranolazine, I said fine, you can combine. My experience with ranolazine is reasonable enough, even though the side effect of QT prolongation is very high.
So this is the time we are being given actually. Now we have to go for another bout. I think Kamal bhai, I will shift to the another bout.
Yeah, thank you everyone. Thank you, chairpersons, moderators, and all the 3 speakers. Fantastic learning for the stable CAD and all the 3 molecules. We move to the next session.
But it was a wonderful discussion all the time.
Thank you, Dr. Kamal Sharma, sir.
Thank you.
Thank you, Dr. Kamal.
We'll go to another session, another bout. Bout number 24. We will have Dr. Vimal Prajapati, Dr. Mukul Oza, Nural Abbas, Dr. Chirag Patel, Dr. Dinesh Joshi, and Dr. Ravi Bhojani. I would like to request Dr. Mukul Oza to kindly introduce our speakers, Dr. Urmil Shah, Dr. Kalpesh Ansora, and Dr. Ashwani Mehta. Dr. Mukul Oza, are you there?
Chairpersons, please introduce all the 3 speakers, the case, and then the images, and then we go presentation quickly in succession.
Okay. Good afternoon, everyone. Now our next topic is
yes,
IV
Dr.
antiplatelet.
Chirag, you can introduce.
Yes. Our next topic is IV antiplatelet in the case of acute coronary syndrome. Our first speaker is Dr. Urmil Shah. As everyone knows, he is a senior interventional cardiologist and director at SIMS Hospital. And he has more than 20 years of experience in intensive care in clinical cardiology and invasive interventional cardiology, and special interest in primary angioplasty. Our next is Dr. Kalpesh Ansora, and he is an interventional cardiologist at SAL Hospital and Sanjeevani Hospital. And our next speaker is Dr. Ashwani Mehta from Delhi, senior consultant cardiologist from Gangaram Hospital, New Delhi. So we will start with Dr. Urmil Shah, sir.
Good afternoon, everyone. Can you hear me?
Yes, sir.
Okay. And can you see my slides now?
Not yet, sir. Please upload the slides.
Yeah, I'm just doing it. Hold on for a second. Yeah, can you see now?
Yes, sir. Please put it on slide mode.
Okay, so good afternoon, everyone. My case which has been given to me is a case study where a patient is a 45-year-old male, diabetic, hypertensive, NT-wall MI. Patient is for the primary angioplasty, and coronary angiography revealed 100% occlusion in the LAD with a grade 5 thrombus. Now, just to understand what is grade 5 thrombus, is basically a complete occlusion of the vessels, and when there is a convex margin and there is a contrast stain which is still persistent in that artery. Along with that, patient also had 80% disease in the circumflex and also in the mid RCA. ejection fraction was 35%. Now let us understand the Quengerolol, which is an important new addition to the antiplatelet agents. Basically, it is a ADP receptor antagonist. It basically acts through the ADP receptor pathway, and it is little bit similar as far as mechanism is concerned, similar to the available, that is ticagrelor or the prasugrel. But what we have to understand is platelet aggregation. Last thing is GP2 activation. And we have also the molecule which inhibits the final pathway, that is GP2B3A on the platelet also. Now let us compare the three molecules which are P2Y12 antagonists. As you can see, both the ticagrelor and Quengerolol are the reversible agent, and there is no prodrug which is there. As far as the onset of action is concerned, for ticagrelor it is around 30 minutes. For Quengerolol it is 2 minutes. It persists for about 3 to 5 days. It persists for about 60 minutes after stopping. And it's an important addition to the antiplatelet agent, I would say. And that is the reason in some of the patients, it is also indicated to use Quengerolol. Quengerolol offers an impressive flexibility, as you can see. Suppose by chance the patient develops some complication, we stop the antiplatelet agent and patient surgery can be done without any major problem. That is an advantage. In a STEMI patient, when there is a disturbed absorption, maybe because of cardiogenic shock or something, then you can bypass because it's an IV agent and directly it goes inside the vein. Another important thing is sometimes in a stable patient, when angiography has been done, we don't know the coronary anatomy, then it is also good because by chance a bypass comes, then it's not a problem. But in situations like acute MI, this doesn't serve the purpose. And finally, it is going to be like a bridging between the, when you please want to discontinue the oral P2Y2 inhibitor when the major surgery is inevitable and we have to undergo that surgery. So this is a very classic indication, I would say, for P2Y2, for the Quengerolol. As you can see, suppose the patient is in cardiogenic shock with MI, or there is a heavy sedation, active vomiting, oral thing is not possible, patient on mechanical ventilator, definitely Quengerolol infusion is an important agent. At the same time, when there is a deferred surgery, we cannot delay the surgery post angioplasty, say 1 month, or there is a big thrombus inside the artery. Angioplasty has been done very recently, then definitely this may be a good agent when non-cardiac surgery has been planned. There is a nice comparison which has been done with the Quengerolol and the ticagrelor. As you can see here, when you give an IV Quengerolol, the antiplatelet efficacy compared to the oral ticagrelor is definitely better, and we can achieve a more platelet inhibition immediately. And that is the reason why this agent has basically come in the market. Limitation of any oral P2Y2 inhibitor, we know: delayed absorption, delayed onset of action, irreversible platelet inhibition, delayed offset of action. That is also very important and may have a drug-to-drug interaction. And that is the reason, if the patient is not being pre-treated by the P2Y2 inhibitor, then a stent thrombosis can be reduced if you give an IV agent, as I have told, which is acting very fast. And here you can see the GP2B inhibitor also is a good molecule in this context. So it's a GP2B inhibitor is a very potent antiplatelet agent. It can cause almost 90% platelet inhibition. The ischemic complications are reduced in various studies clearly, but there was also an increase in the bleeding. So the overall benefit many times was not absorbed, so it is not very commonly used. Another important thing is nowadays we have a very potent antiplatelet agent like ticagrelor and prasugrel, and that is the reason the use of GPI is definitely reduced. But still, it is a contemporary use when there is a large thrombus burden and there is a no slow flow, which is expected while doing angioplasty in a acute myocardial infarction. Let us compare now various GP2B inhibitor with Quengerolol. As you can see here, basically it's a competitive inhibitor. That is one, the half-life of all these three molecules, epsiximab, eptified, and tirofiban is long. Tirofiban is about 2 hours, and this is only 3 to 6 minutes. As you can see here, normally we stop the infusion after 4 hours of time. But if we are giving an GP2 inhibitor, we continue it for a little longer time. As you can see here, when we are giving GP2 inhibitor, we have to be a little careful because we know that it's a very potent antiplatelet agent and the bleeding complications are high. We try to have the ACT value of about 200 to 250, and the dose of heparin is slightly less because otherwise it can cause a more bleeding complication, and repeat ACT measurement is very important. Now coming to our patient, which has been given anti-wall MI, 100% occlusion. Also there is a disease in the circumflex. The class 1 indication, according to the 2017 latest guideline of primary angioplasty, a potent PTY2 antagonist has to be there. So I would definitely, let everyone know that whenever acute MI comes, usually give a second antiplatelet agent, and usually it is a ticagrelor because we wanted the patient to undergo. It is a class 1 indication, and normally we give before that. So suppose patient come with this condition, I personally believe that definitely a ticagrelor might have been started in this patient. That is one. Second is there is a big thrombotic complication. We can use a GP2 inhibitor. That is a class 2A indication, and that is we have to keep in mind. And the Congrelol, which is the point of discussion at present, is not those patients who has not received P2Y2 inhibited then and then. But as I have told, class 1 indication, we usually give in all the patient ticagrelor, and even then it is a class 2B indication and not a class 2 indication. So any patient acute result 2021 guideline clearly mentioned that loading dose of P2Y2 inhibitor has to be there, and it is reasonable to use ticagrelor or prasugrelor in preference to the clopidogrel because we know it is very fast acting and very effective. Now, where in 2021 guideline about the Congrelol, as you can see here, whenever there is a acute angioval MI with large thrombus, as you can see in our patient, it's a grade 5 thrombus, or we are expecting a no reflow, it is a class 2 indication to use a JP2 inhibitor. As you can see here, if the patient is not taken ticagrelor, then definitely IV Congrelol can be used. And even then, it is a class 2 indication in the recent 2021 guideline. So Congrelol has been approved by this situation, as you can see, basically to prevent the stent thrombosis, not treated with oral P2Y2 antagonist. And we all know that in all patients of acute MI, we always give clopidogrel, and even if the clopidogrel has been given, we give ticagrelor also, and then we normally take the patient for a primary angioplasty. In the European guideline also, it has been mentioned when patient is not being treated by oral this agent, then we have to give an IV Congrelol. Congrelol has been started in 2006, almost now it's 15-16 years. Still, it is a class 2 indication, and reasons are very obvious. As you can see, there are certain studies which has been done in past, which were stopped prematurely because of futility, no difference in the primary outcome, and that was the reason it was stopped. So that also we have to keep in mind. One study which showed the advantage of Congrelol over other agents were with the clopidogrel. And now we all know that we are not using clopidogrel in acute PAMI situation. We are using ticagrelor. So we really need to compare a ticagrelor with Congrelol rather than this molecule. Now let us compare the GP2 inhibitor. What has been mentioned is if you use a GP2 inhibitor, the efficacy wise, the Congrelol and GP2 inhibitor are equal. But if the bleeding complication, if you see, it is definitely high with the GP2 inhibitor. And that is a little limitation we have to keep in mind. But we have to understand that these data are not a double-blind study or so randomized study. It was a real-world data. Efficacy is almost same with the Congrelol. The bleeding profile and the safety profile has an advantage. So that also we have to keep in mind. Also, we have to keep in mind that GP2 inhibitor was prolonged for a longer time, which is nowadays not required. That is one thing. And second thing is in this data, eptifibatide was the molecule which was used and which is known to have more bleeding complication in the real-world data. So that also we have to keep in mind. And now what I am discussing is a use of tirofiban. And as I have told in the beginning, the heparin dose and the monitoring of HTT is very important when you are combining antiplatelet agent with heparin and Congrelol. This is the very recent study which clearly shown, which is a fabulous faster, which has compared, as you can see here, one group of patients who is undergoing for a STEMI procedure. 40 patients were randomized to Congrelol, 40 patients were tirofiban and the prasugrel. And the purpose of doing this study is to know what is the platelet inhibition, which is achieved at the end of 30 minutes. And as you can see at the end of 30 minutes, compared to Congrelol, the tirofiban was much more effective. Almost 90% platelet inhibitions were achieved. So both are IV molecule. If you compare with the prasugrel, it's an oral molecule. Definitely, it is Congrelol is better than this. But when you compare with the tirofiban, antiplatelet agents are almost similar. So why tirofiban in my patient? Because acute MI situation, grade 5 thrombus. Here I need a very effective molecule, which is, and as I have mentioned, the GP2 inhibitor basically acts on the final step of platelet aggregation. And that is what I really want to achieve. We need a molecule which is quick acting. As I have shown in the 2020 faster fabulous study, it is much better to Congrelol as far as 30 minutes antiplatelet efficacy is concerned. And tirofiban is basically a time tested, and it is according to the guideline. As you can see, the 2021 latest guideline it is a class 2A indication and not a class 2 indication, which is there for cangrelone. Another important thing is when using in this type of situation, we are much for us, it is more important to have a efficacy, and bleeding risk we may not keep in mind, because we really want to get rid of that thrombus. And our patient is young, and I presume that they may not have a very high bleeding chances, and that is the reason why the advantage of cangrelone will not be there. So cangrelone may be a safe molecule, but as far as efficacy is concerned, tirofiban is a good molecule. As I've told, any of the patient who comes with the primary angioplasty, I don't see any patient who has not taken an oral. So if it is not new, then according to the guideline, use of cangrelone is not there. And tirofiban is the better molecule compared to the clopidogrel in this situation. That also we have to keep in mind. When we are giving GP inhibitor like tirofiban, we have to be very careful. It should be weight adjusted, repairing dose, and the ACT guided treatment has to be done so that it avoids the bleeding complication in this group of patients also. And at the same time, we like to give cangrelone. Suppose this patient has come to me, which situation I will use a cangrelone. Suppose patients after 15 days or 1 month need a surgery, which is more of a immediate surgery, urgent surgery. Definitely I will use a cangrelone, will stop the ticagrelor or the other antiplatelet agent for 2 or 3 days, will bridge therapy, and then let the non-cardiac surgery being done. Or else if the patient is in cardiogenic shock, okay, not able to take oral tablets, then and then according to the guideline or according to the classing indication, we have to give cangrelone in this group of patients. Otherwise, there is no major role of this antiplatelet agent. And why not epsiximab? Because it is basically a long-acting. No recent trial has been done up till recently with this molecule. After the availability of ticagrelor and prasugrel, bleeding risk is very high, and no data or direct comparison with cangrelone. And it is little bit costly molecule, and many times it is not available also in the present time. So I will not use epsiximab in this group of patients. Recently, today morning, I did this case.
This will last 1 minute.
Yeah, it's over. This is last one case. Today morning, I did in fuel MI, as you can see here, a very classic thrombus, which has been seen. As you can see, after putting a wire, there is a big thrombus which is there. Now, in this type of situation, we really need an agent which is very effective, and we are more concerned about getting a good result. And as you can see here, we need an agent which is very effective, very with the long-term data. And this is the last result. I've used tirofiban in this patient, and as you can see, the last result is absolutely fine. Thank you very much, sir.
Now we speak to Kalpesh. Urmil may kindly be with us. We will have a discussion afterwards.
Yes, sir. Yes, sir.
We wish to hear so many things from you.
Yes, sir. Nice to see you, sir.
Yeah. So
Sunday afternoon, still morning.
Your look has changed so much, Joe.
Yeah, we are not mad since long.
Dr. Kalpesh. Dr. Kalpesh.
Yes, sir. I cannot share my content, sir.
Neelam? Darshan, if you can help us.
There is option of photo.
Sir, there is
Dr. Shah will have to stop sharing, then the other speaker would be able to do it.
Kalpesh, sir. Hello.
Yeah.
Yes, sir.
Yes,
you can share your screen. Just open your presentation. Then after come back to Zoom window. There are this green icon, the share screen. Click on that.
There is a share content. Okay.
Yeah.
There is option content. Is photos. I could drive. Dropbox.
Yes. Share content. Then after share your screen.
There is no option for share screen. Okay. I'm not getting share screen option. Wait a minute.
Darshan?
Hello.
Can I help?
Yes, sir.
If you want, I can show my presentation, which is the last one, and then later on Dr. Kalpesh can come back, sort out.
Sure, sir.
So with the permission of the chair, can I do that?
Yes, Ashwani, you can go ahead.
Sure. So we've had a very nice talk by Dr. Shah, and I really enjoyed. And he has shown that how, the drugs work, the tirofiban and the cangrelor. I'd like to put forward why I think cangrelor is. This is my disclaimer, and I'll go with the practical scenario, and the practical scenario is very clear. I'll show you the patient taken up for angiography, 54-year-old lady, but just 48 kgs. And this lady, we did an angiogram, and this is, we did an angiogram and found lesions in the LAD and RCA, did angioplasty, shifted back to the CCU. But then again, in the CCU, just after minutes, patient had severe pain. We took the patient back, and this is what we found. There's the stent thrombosis just beginning to happen in both the arteries. This patient was subsequently treated and did well. Another scenario, patient came with acute anterior wall MI, like the case we have, and the proximal LAD preloaded with crushed ticagrelor, which is a standard choice and my preference. And this was the initial blockage in the proximal LAD, opened up nicely. On the table, patient after 5 minutes had a ventricular fibrillation. We did a check angiogram. This is what we found. Found a thrombus. And then this happened with grelor, which was given crushed. Another case, 65-year-old male, long-standing diabetes, came with chest discomfort, ACS. He was loaded, taken up for coronary angiogram. No, this is an angiogram. Look at the triple vessel disease. Look at the left main, LAD, proximal circumflex. The RCA was the culprit. So what does it mean? It means very clear that the present set of medication which we are using, the oral drugs, probably still have something lacking. And there's a huge unmet need in the PCI patients. Many agents are available, but still there is a problem. More and more patients are going to cath labs sooner and sooner, and there is no doubt that the P2Y12 inhibitor activity is important, and it's still a challenge. There is limitation even with these drugs which we are using. Definitely prasugrel, ticagrelor are better drugs, but then the challenge persists. And what about those going for surgery? Still, we are not sure. Many of our friends are loading before, some are even loading after. So many things remain yet to be established. We know, we are giving prasugrel, we are giving ticagrelor, but look at this one study which showed that even after giving these two drugs, many patients would not achieve complete platelet inhibition till 1 or 2 hours. So what is the choice? How do we bridge the gap? Early administration if possible, high loading dose, not possible with prasugrel, ticagrelor, crushing the tablets. Yes, we are all doing that. IV therapies, GPI and cangrelor. So let's see what the evidence says. Many patients of acute MI, like our patient who has come, may be in cardiogenic shock, may require, maybe sedated, could be vomiting, like what happened in our patient with acute MI who had a ventricular fibrillation. Unfortunately, when I got to ask the patient and the attendants, and what I found out that the patient had vomited. So he was given crushed ticagrelor, and in the way to the cath lab, the patient vomited, and the ticagrelor was out, and that's what happened. And the patient landed up with acute stent thrombosis. So this is not uncommon. Patients would not be loaded properly and would not achieve the adequate platelet inhibition. So definitely oral P2Y12 may not be a feasible option in many patients. So what about cangrelor? Dr. Shah has shown a couple of slides, and he has very nicely shown that how cangrelor has certain advantages. I've been part of this Champions trial a couple of years back, and did number of patients with good results. And this is a novel drug, intravenous drug, and it works very fast, rapid onset of action. Within 5 minutes, in fact, you achieve a very good inhibition. And when you switch it off within an hour, most of the inhibition is gone. No dosage adjustment is required in renal and hepatic impairment patients, high bioavailability, and no drug-drug interaction. case number 3, where I showed a triple vessel disease patient who had an ACS. And now this was the patient where we just did a plain balloon angioplasty of the RCA and referred the patient for CABG. This patient did well just because of cangrelor. Imagine had we given ticagrelor and then doing a plain balloon angioplasty, waiting, and then sending a patient for CABG, we have to wait and get into trouble later on. So let's look what is the evidence. What is the clinical evidence? The efficacy and safety of cangrelor in patients undergoing. The study has been studied in major trials, more than 25,000 PCI patients in 3 trials. Champion Phoenix, Platform, and the PCI Champion. And we know, that the PCI and Platform did show a reduction, but they did not achieve statistical significance. It was only Champion Phoenix which showed a statistically significant reduction. And that was the reason that caused the advantage, and that's why it came to be approved by the US FDA. And what it showed in the meta-analysis was there was reduction in death, MI, IDR. Shown by Dr. Shah, and this is something very interesting. I like to show here. We know the role of GPI is now being questioned. And why it's been questioned? Because of the new drugs, the ticagrelor and prasugrel. And look here, what does the CANTIC trial say? The crushed ticagrelor, when compared with cangrelor, the pharmacodynamic assessment shows a much better effects within 5 minutes with cangrelor versus the ticagrelor. So what's the conclusion from CANTIC trial? Very clear. It's cangrelor, which is an effective strategy to bridge the gap in platelet inhibition. It can be administered as intravenous drug, and without any delay, you achieve a very good sustained effect, whereas ticagrelor would still require some time and maybe up to 3 hours for same efficacy as you get with cangrelor. So today, the talk and the debate is on the GPI inhibitors versus the cangrelor. So I would like to quote this very interesting study which has been published last year. And this particular study looked at cangrelor versus GP2B3A. Now this had both the tirofiban and the abciximab. And what do we see? This study design looked at a single center. Cangrelor was given in about 478 patients, and the GPI is in 1,594. And up to 99% of the patients. We know there are certain disadvantages of abciximab, longer acting, and I distinctly remember about 15 years back doing a very good angioplasty, large thrombus burden, and we gave abciximab. Unfortunately, the patient had an intracranial hemorrhage and died. So the bleeding events, that's the big shocker, which is there with these GPIs. The bleeding events are much more. And in this particular study, they looked at bleeding events, the clinical outcomes, in-length hospital stay, intensive care unit stay, and this is what they found. As compared to GPI, cangrelor achieved a procedural success which was similar, but major bleeding is lower in the cangrelor group. The vascular complication rates, the in-hospital length of stay was significantly higher in the GPI group. The in-hospital ischemic events such as myocardial infarction, all-cause mortality, stent thrombosis definitely were the same. And my friend Dr. Shah has just shown that why he prefers tirofiban, and he also showed the Fabulous FASTER study. But Fabulous FASTER study definitely just is a study which looked at the platelets. It didn't look at the clinical outcomes. This particular study also showed the 30 days significantly lower rates of myocardial infarction and the target vessel revascularization in the cangrelor group. So the bleeding events, as I said, were less with cangrelor. The myocardial infarction rates were less. The total hospital stay was less. And here the cangrelor was the winner, hands down. And then there's another study, the BRIDGE study. Now we know that bridging, specifically the patients who are going for a surgery, is a big issue. And the results of this bridge trial support this hypothesis that we know that IV cangrelor is feasible and a safe management strategy in patients who require platelet Y12 inhibition after the thienopyridine discontinuation prior to surgery. And this is where it scores over all others. So in clinical practice, there is no recommendation at present from the ACCHE guidelines, but there is a reason. Because most of these studies and papers have come now, but the ESC guidelines have come about and they recommend the cangrelor as class 2B for patients across the spectrum of coronary artery disease who are P2Y12 naive while going for PCI. So where is the place in therapy? The US FDA recommends as an adjunct to PCI for reducing risk of periprocedural myocardial infarction, for repeated coronary revascularization stent thrombosis in patients not treated with P2Y12 inhibitor and not planned to receive a GPI. And also, the European Medicines Agency is very clear for reduction of thrombotic CV events in CAD patients undergoing PCI. And also the ESC, I just mentioned the guidelines. Which of the patients are going to benefit the most? The ACS spared from preloaded DAPT, clopidogrel resistant patients, CABG or non-cardiac surgery patients, to reduce the cost and need for GP2B inhibitors where bleeding is a major concern, benefit sustained up to 30 days we are looking at, intuitive in chip cases, left main bifurcation, long stents, multiple overlapping stents, bridging, and also in sick ICU where internal medicine is, the enteral medicines are withheld and patient is being fed by the Ryle's tube, and also in patients where the timing of clopidogrel, ticagrelor itself is an issue. Another thing I'd like to mention here that probably if you look at the pharmacokinetics of platelet inhibition, probably devaluridine plus cangrelor could be a wonderful combination. So I go back to our case. This 45-year-old type 2 diabetes patients, anterior wall MI, 100% osteal lesion, and also lesions in the circumflex LAD. We don't know how the distal LAD is, maybe calcified, maybe bad, and maybe requiring a triple vessel CABG. There's a reappraisal going on the role of GPIs as a strategy to reduce the periprocedural complications, especially after ticagrelor and prasugrel. The current recommendations for GPI are basically two. One is the bailout use and another for bridging for selected patients. But remember, cangrelor has a faster onset, faster offset of action with some more favorable characteristics than GPIs, especially the bleeding risk and especially the study I quoted. My strategy is very clear. It would be predictable and fast platelet inhibition and a better bleeding risk, and it could be cangrelor. Thank you so much for your kind attention.
Thank you so much, sir. And now we'll go to Dr. Kalpesh.
Good afternoon, everyone. Am I audible, sir?
Yes, Kalpesh, go ahead.
Yes. Thank you, Kamal, sir, for giving me opportunity to talk on GPI in this case scenario. And I think that was a wonderful discussion with all participants of the CardioCon 2022. So here already we have discussed about the case study. Next slide, please. So patients having osteal 100% occlusion of LAD, and my seniors has already justified about the use of the diarophyban in this case, and as well as the cangrelor in their particular view. So, but this is a case of primary PCI, so I would prefer epcoritamab as a choice of GP2B inhibitor treatment for these patients for primary PCI for several reasons. Why? Next slide, please. So I will go through the quickly about the points which favor in use of epcoritamab in this case. Next slide, please. The point number one, we know the guidelines, as Ulmilstar has already discussed about the indication of using the GP2B3 inhibitors as a class 2A recommendation as a bailed-out therapy if there is the angiographical evidence of massive thrombus. So already the case of the case, already we have a grade 5 thrombus, and slow or no reflow is a prediction if patients having a grade 5 thrombus burden. And also there is a class 2B indication as a adjuvant to the primary PCI performed with unfraction impaired, it may be considered in those without contraindication. Next slide, please. So point number 2, if you look at the pharmacokinetic comparison, next slide. So epcoritamab as compared to other GP2 inhibitors, that is a non-competitive inhibitor and it has having a high platelet affinity. If you look at the plasma half-life is less than 10 minutes, but the recovery of platelet function will take a longer time. So that would be an advantage of using the epcoritamab if patients who requires the higher anticoagulant level or who is having a high risk for the thrombotic complication. The effect of epcoritamab persists even for 48 hours. And we should not forget about the renal function, because most of patients who is having anterior may be having an involvement of renal parameters. So in patients who is having a renal insufficiency in there, the epcoritamab will be preferred as the route of elimination as compared to GP2B inhibitor will be different. It is a vascular space and spleen will debride the epcoritamab. So there is no dose adjustment even if required for epcoritamab. Next slide. So next is patient's reversibility. As we have discussed, it will take for 24 to 48 hours for reversibility with platelets. Next slide. Point number 3, if you look at the mechanism of action as compared to other GP2B inhibitors, the epcoritamab binds with the RGD binding pocket and secondary KQ receptor, while tilofiban and iftafibatide it binds RGD binding sequence and it will react with both latent and active state of the GP2B inhibitor. So it is therefore it binds with the non-stimulated as well as stimulated platelets, but only epcoritamab react with only activated platelets. Next, so it has a potency with the only activated platelet will be inhibited. So this is a diagram which is showing the epcoritamab also bind with the other receptor which is present on leukocyte, MEK1 receptor which is present, and leukocyte which will inhibit this leukocyte and also decrease the inflammatory response in patients who is having a acute MI. Next slide, please. Point number 4, the clinical indication of epcoritamab as current guidelines is always recommended that selective use of epcoritamab for patients with high risk of ischemic event like large anterior wall MI, what we are having a case, large thrombus burden, as we know that there is a grade 5 thrombus burden in these patients, and angiographic complication, distal embolization and no flow reform for primary PCI, especially in patients with low risk of bleeding. Next. So point number 5, we know that the concept of no flow after PCI, but there is a unique mechanism of epcoritamab. What the no flow phenomena? When the microparticles set from the activated or dead cells which contain the pro-coagulant and this pro-inflammatory property. These microparticles from various vascular and peripheral blood cells, it will circulate in blood and accumulate into atherosclerosis plaque. So this is responsible for basics of inflammation and new thrombus formation in patient with the acute MI. While lower levels of pro-coagulant microparticles were achieved with epcoritamab if treated compared with the iftafibatide therapy or primary PCI only without administration of GP2B3 antagonist. Next slide. Next slide. So this is the concept of no-fibrilla and advantage of using epcoritamab. So in particular, epcoritamab has shown it enhanced the coronary flow in primary PCI by its action on platelets, leukocyte, microparticles, as well as a microembolism. Next. So there is a multiple mechanism of action which has a beneficial role of as an anti-inflammatory action. While tirofiban and iftafiban are non-peptide molecules with marked specificity with GP2B3 inhibitors. So only epcoritamab, which has a potential direct inhibition of adhesion of platelets and endothelial cells and platelets and white cell as a consequences to inhibit the or limit the inflammatory process in SCS patient, specifically after PCI. So epcoritamab may suppress the rise of markers of inflammation after PCI. So there is another advantage of using epcoritamab in patient with the large thrombus burden. Next slide, please. Point 6 is comparative benefits of axinab, the longer duration of inhibition of the platelets. Next slide. So if you look at the chart of the axinab, tirofiban, and iftabifil, there is a duration of the inhibition of platelets will last longer. So in patients, next slide. So in patients who require having a high thrombotic complication risk, in this the axinab will be more advantage as compared to the other iftabifil and tirofiban as well as the cangrelor, because the duration of action lasts shortly in comparison with the axinab. Next slide, please. Point number 7, this is out of case discussion, that it will promote the thrombolysis. Even patients who is having an anterior wall MI, large infarction, if he's going for the thrombolysis, the axinab allows the penetration of the both endogenous and parenteral fibrinolytic agents into clot. Thereby, it will promote the fibrinolysis. Next slide. Point number 8, it's clinical data. As we have shown, many trials has shown that there is an advantage of using axinab in patients who is having acute coronary syndrome with a low dose heparins will reduce the acute myocardial primary endpoint in terms of decreased revascularization as well as the cardiovascular mortality. So main axinab trial was EPISTENT and EPILOGUE trial. There were the 3 largest trial which have been studied, and many patients who is undergoing a PCI and who is having a high risk for PCI. Next slide. So if you look at the clinical benefit in terms of primary endpoints, means 30-day death, myocardial infarction, and urgent revascularization rate was achieved lower as compared with other GP2B inhibitor. If you look at the EPIC, EPILOGUE, and CAPTURE trial, where they used the axinab, the percentage of achieving primary endpoint as compared to placebo was lower, and p value was very significant. So in terms of reduction in absolute risk reduction as well as the relative risk reduction was quite achieved in patients who has received the axinab. Next slide. So this was the EPIC phase 3 trial where they have shown that the death, MI, urgent revascularization endpoint was lower in a patient who has received the axinab. Next slide. Next slide. So, though there was a little higher incidence of thrombocytopenia in patients who has received axinab, but the bleeding rates was not that much significant as compared to the placebo. Next slide. If you look at the comparative clinical data, point number 9, so there is the trial, DREAM trial. They studied the axinab versus iftabifil versus tirofiban. All 3 drugs studied, and they have shown that intimal dissection and thromboembolism were higher in iftabifil and tirofiban treated group. Similar major and minor bleeds as per TIMI were more with the iftabifil. So cumulative major cardiac adverse event, if you compare the tirofiban was 4 point, with the axinab, it was only 4.8% as compared to tirofiban and iftabifil at the end of 30 days. So the cumulative mesh was higher in other GP2B inhibitors as compared to the axinab. Next slide, please. And we know that the onset of action time to achieve 80% platelet inhibition is very less with the axinab as compared to iftabifil and tirofiban. Maybe less, more or less with the Sanglor, as we have discussed about the Sanglor presentation. And advantage of using the axinab in patients, because the elimination occurs in the vascular space, so you don't need to reduce the dose in patients who is having a renal insufficiency. Next, please. So comparison in randomized placebo control trial, the risk of recurrent ischemic complication within 30 days after PCI was reduced by almost 40 to 60% with axinab and only 15 to 35% with the iftabifil and tirofiban. Moreover, axinab associated with the long-term decrease in mortality, where mortality reduction has not been observed to the date with the iftabifil and tirofiban. Next slide. So if you look at the clinical trial, which is compares the previous absolute and relative reduction was achieved with epcesimab more as compared to the tirofiban. So EPIC, epilogue and capture trials, the absolute risk reduction and relative risk reduction were more as compared to tirofiban was studied in RESTORE as well as the target trial. Next slide, please. So in target study also, the primary endpoint composite of death, non-fatal MI and urgent target revascularization within 30 days more occur with the tirofiban as compared to epcesimab. And targets showed that tirofiban to be inferior to be epcesimab and not better than the putative placebo. Next slide. Next slide. Next slide. About Sanglor, as Saresh discussed the advantage of Sanglor, but most of patients who comes to the primary PCI, the Sanglor already indicated who has not received the P2Y2 inhibitor, other P2Y2 inhibitors. The most of patients comes with us with loaded with either Prasugrel or Ticagrelor. In this case, the potential interaction can be possible with the Sanglor. Point number 10. Next, long-term benefit has been shown with use of epcesimab. Next slide. If you look at the troponin level, patients who has an elevated troponin level, they will get the benefit, more benefit with the epcesimab. Next slide.
Kalpesh, last 1 minute.
Yes, sir. Next slide. Next. And comparative safety. Next slide. Though thrombocytopenia was higher in patients who has received epcesimab, but TB bleeding, if you look at the minor and major bleeding, almost equal in all three group of patients. Next slide. And adverse profile, if you look at depth profile, the all having a cumulative major adverse outcome was equal in all three GP2 inhibitors. Next slide. So take home message, early admission of epcesimab in high risk patients, 1 year mortality was significantly lower with early epcesimab administration as compared to the late. There is no significant increase in bleeding rate and provided better benefit to harm profile than standard therapy in high risk patients, high infarct related artery patency at the onset of PCI and higher left ventricular function at 90 days post PCI and lower incidence of heart failure. Next. And the intracoronary administrations have a more advantage of using epcesimab because a higher local concentration deriving from intracoronary administration, which will may lead to the optimization of both GP2B and 3A and non-GP2 3A dependent property. Thank you. Next.
Wonderful. All three presentations. Thank you, Dr. Urmil, Dr. Ashwini Mehta, and Dr. Prashant. Over to chairpersons. Dr. Durul, I can see you. Any questions
yes,
that you have?
No, sir,
Dr.
I would
Chirag,
like to
Dr.
highlight that
Dinesh.
all the three speakers have very well, highlighted upon. Somebody took the potency as an advantage. Somebody took it as a, as the risk of bleeding. So I would really like to highlight that Urmil sir had really stressed upon the grade 5 thrombus, the intake of P2Y2 oral inhibitors. And the next Ashwini sir has been very much telling about very well about insisting upon the bleeding risk and the profile of distal CAD distal LAD, which might lead to CABG in that case. Kalpesh sir has also very much stressed upon nicely upon the duration of action and the multiple mechanisms of epcesimab and the renal insufficiency, which might be there in the case where it would be very safe. So all the three had been justifying their molecules very nicely.
Dr. Chirag?
Yes, sir. I want to just ask Dr. Ashwini, sir, if we are using IV cangrelor, what should be the timing of switching to oral drug like clopidogrel or tirofiban, that ticagrelor?
Yeah, I'll tell you, that in the trials, the way it was done, and just after the procedure, you can load the patient, and that would be taking care of most of the patients.
Okay.
I'd like to I like to have, this was a very nice sessions and we had really enjoyed. the presentation by my fellow speakers also. And Dr. Kamal Sharma, it's a wonderful conference. And let me tell you, I had the opportunity to go through the various topics. The way it has been done, it packs the punch, and it's very compact and to the point, and really enjoyed being the part of it. I think all the panelists and the speakers would agree that each molecule has its own space, has its own role. And I think there's a time that in naive patients, sick patients, there's a time to revisit Cangrelor.
Yeah, completely agree. Dr. Ravi, your comments, if you have any? Dr. Ravi Bhojani?
Yes, it was a very nice session, and thank you, sir, for giving me an opportunity to be part of it. And I every time I see that whenever we don't have a opportunity to load the patient, either patient has got crashed or maybe has got intubated because of some critical event. In that case, definitely we have to go through such a issue where we don't have a proper loading of the patient with antiplatelets, and in such scenario, this kind of discussion definitely is going to help us in the managing the patient. So I am really so the Cangrelor can be kept as a reserve molecule for us when we have not able to load the oral antiplatelet agent, and we can use it as a reserve molecule. I guess that is the best thing with Cangrelor we have.
I think it's, as Dr. Ashwini Mehta pointed out very clearly, it's a good therapy for bridge and good therapy for short when you are actually dealing with somebody who's going to bleed or have a risk. The reason I gave moderate to severe MR here was to prompt you that maybe he'll end up with an MV repair or MV surgery, or maybe the thrombus is not cleared enough. You still have thrombus hanging, patient decompensate with MR, and you need to go for a repair. And that's why we created a reason for, Cangrelor to come in. Of course, with the hope that maybe the 2B3 inhibitors would clear it off and then MR goes away. Then probably you will not need a surgery. But if I was to mention this is a severe MR, then Dr. Ashwini Mehta would have it his way. And if I was to mention no MR, then he would not have a chance to speak. So I had to keep it that way. But I think we've used it in 4 or 5 patients now. All of these patients are patients who've had history of recent bleed, patient who've done a high risk surgery, angioplasty. I remember a lady, we did a left main to LAD 70-year-old, and there was a diagonal which was flowing well, but there was a circumflex from the flowing well across the left main to LAD, but the diagonal had TIMI2 flow, and we were worried because it was a long stent. We'd done a pot, we did imaging, we did IVUS, everything was looking good. Lady had a typical, she was restless even when before we took her for PCI, and she was frail lady, 40 kg, 70-year-old, not very cooperative, always the somebody that keeps you awake all night. And then she had history of GI bleed in past. So that was one of the first case that we used Cangrelor, and we had good result. I gave it only 1 vial. And once the patient was actually out of the cath lab, maybe Cangrelor worked or shifting out of cath lab work, the patient was settled. So most of these elderlies, they don't like to be in caths. So those are the case scenarios where we have used it often. But let's remember, this is an antiplatelet and that's an antithrombotic. Let's not mix up the two. If you are loading already with a potent P2Y12 inhibitor, we don't have data. We don't have data for Cangrelor if you've already loaded them with, say, the ticagrelor or aspirin. That's my take. Any comments from any of you? Dr. Urmil, Dr. Kalpesh, and Dr. Ashwini?
Yes, so I absolutely agree with all the speakers and all the panelists that as far as safety is concerned, definitely we can vouch on that. It is a much safer molecule, and it is something a very, very good molecule. Just like switch on, switch off. Just you switch on, the effect starts, you switch off, the effect goes. And that is a real advantage. And I would say cardiogenic shock is going to be the main indication. And second is breach to the surgery is going to be the second most common indication, because many a times we do come across patient within 15 days, they either cholecystitis or any acute abdomen, and they need a non-cardiac surgery. And we didn't have a choice. So similar to the warfarin in post-MV or post-valve replacement patient, we have a breaching like heparin. This molecule also can work very nicely in this subset. So that is I wanted to highlight. These are the 2 very good indications of using this molecule. Thank you very much, sir.
Dr. Ashwini Mehta, any comments?
Yeah, in fact, I'll agree with what Dr. Shah said. And the point you made, and let's not get carried away, and we should remember that it's an antiplatelet molecule, and the tirofiban definitely is being used also as an antithrombotic agent. So, so let's not use cangrelor in situation where you already see a thrombus. So I would be I would still use tirofiban whenever I would see a thrombus. There's no doubt about it. So like post angioplasty, I get a stent thrombosis, I would be using tirofiban. There's no doubt about it. So, but only in loading patients, when the patient is naive, there is an indication for cangrelor. So that message should be absolutely clear.
Absolutely. So I think if there are no more comments, then we can end this session. And this was the last bout in the hall. We'll be having our valedictory function. We'll be just declaring the winners of the e-poster segment, which has been analyzed by the judges, and also the quiz winners of both the days. The quiz questions were based on all the sessions that we had on day 1 and day 2. The questions were one from each session, each bout. So we had question even from this bout, and the quiz has just closed. And now we'll be, because it's online, so we have quick, if in those cases where we have equal marks, then those who attempted in lesser amount of time, that was the tiebreaker. So coming to the e-poster winners, we've decided based on not making 1, 2, 3, but 3 separate categories. And this is the best case report, the best scientific method, and the best signs of evaluation. So can we have the slide, please? So the most scientific evaluation, which is best science in terms of methodology of doing a clinical research, goes to tenacity study. This is to evaluate real-world performance of bisoprolol in post-myocardial infarction with LV dysfunction. The corresponding author is Dr. Hardik Desai. This is one of the good papers that actually is going to be published in one of the journals, and they've done it before it here. So that goes to take the first prize in that category. Best research idea, which is prevalence of MTHFR gene polymorphism in acute coronary syndrome patients from Western India. This goes as the best research idea category, as the best e-poster, and that prize goes to Dr. Ashwati Konath. Dr. Ashwati Konath is a PhD fellow from Gujarat University. She's posted this. Dr. Hardik Desai is a former observer at Harvard Medical Center. Now he's right now in India. And the best case report goes to cardiac sarcoidosis presenting as recurrent ventricular tachycardia, a case report. This is presented by one of our own fellows, Dr. Devrat Singh Parmar. So these are the 3 winners for the e-poster category. Let's have a round of applause for them. We had a total 17 posters this time. Let's go to the result of quiz for the 2 days. So on 19th, the first, second, and third prize, or the first, second, and third winners were Dr. Surinder Kumar, Dr. Somesh Arvindan, and Dr. Rana Kundu. So these are the top 3 winners. Last, we had more than 3,000 footfalls for our conference this year on our platform, and this was live streaming on Medflix, where they also had another 3,000 plus footfalls. So we had almost 5,000 to 6,000 people actually watching this conference and attempting it, which is like the numbers that we find in CSI. I'm overwhelmed, and it's really, I'm thankful to the from the bottom of my heart for your all participation, and it would not have been possible without support of each one of you, including the faculty and the APA and my organizing team. The winners for today's quiz. And we have ESO, highest marks are to Jaideep Dasgupta. Second rank is Dr. Prasanna Pillai. And third rank is to Sai Kiran Kakarala. So these are the winners, and all these winners, these 3 posters and 3 quiz winners, will be contacted personally for the prizes that are there from the CardioCon in form of various prizes, and you'll be intimated personally and contacted personally. You can write back to CardioCon Ahmedabad for your feedback if you have any. Your certificates for participation for all posters, all quiz participants, all faculties will be shared with you soon. Next slide. So at the end, as I close, I want to thank each one of you. Firstly, my organizing team, Dr. Mukesh, Kalpesh, Jignesh, Prashant, Dr. Aman, Dr. Jasraj, Ahmedabad Physician Association, Dr. Jayesh Bhai, who was chairing the Hall A along with me, all the faculties, each one of you who was part of this conference, chairpersons, moderators, each and every speaker, and each and every delegate, our streaming partners, RX Event, Medflix, and all the sponsors who supported and facilitated and brought us out the best in the science. And we look forward to have you physically or maybe in the truly hybrid mode where we have a crowd of not just 20, 25 people sitting here and the rest of the show running virtually, but probably 500 sitting in the town and maybe looking for 10,000 hits online as well. So thank you very much. Thank you, everyone. Good night and take care. Stay connected. That's always a pleasure being with you all. Thank you. Bye-bye.
Bye. Bye, everyone.